So now our inaugural session is coming to its end, and I invite Dr. Arun for a vote of thanks. Arun Maman, please.
Good morning, all. I would, at the very onset, I would like to thank the Pediatric Dermatology Chapter IEP and the IEP Pathanamthitta for giving me an opportunity to say a vote of thanks for this session that is going to ensue. I would like to thank the State President and the State Secretary, Narayan Sir and Bala Sir, and also the Pediatric Dermatology Chapter President, Dr. Harikumar Sir and Dr. Nauchi, for giving IEP Pathanamthitta an opportunity to conduct the Dermaped 2020. Lastly, I would like to thank all the participants who have joined. We have almost around 290 participants, and that too for an inaugural session is a good thing. And I'm not taking much of time, so let's have an academic feast. Thank you.
Thank you, Dr. Arun. And our inaugural session is closed in time. It is only 4 minutes delay. Okay, that's no. We will get more time for academic session, and people are eagerly waiting for that. So without wasting much time, I hand over the mic to Dr. Jijo. Jijo, please continue academic session. Please start.
Thank you, sir. Before we go on to the first talk, I would like to, it is my honor to introduce the first chairperson. The first chairperson for today is Dr. Girija Mohan. She is a past professor from LP Medical College. She is a teacher and a mother for all of us. And we are proudly saying she's a current professor in Believers Church Medical College, and she's a medical superintendent of Believers Church Medical College. Over to you, madam, to introduce the speaker, and we'll start our academics with the first session. Thank you. Girija, ma'am.
Unmute, madam.
Thank you, Jijo. Am I audible?
Yes, ma'am.
So, good morning to each one of you. At the onset, let me thank the organizers of IAP Pathanamthitta for giving me the privilege to chair a session by the most eminent speaker, Dr. Vijay Bhaskar, and an authority on dermatology. So, I think we must go through this. Where's the slides, Dr. Vijay? I think I'll introduce Dr. Bhaskar. He is the associate professor at the prestigious Institute Madras Medical College, and also he is. Am I audible?
Yes, ma'am.
He is a consultant at Vijay Health Center, Chennai. And if you go through his credentials, he has organized many international and national conferences, and also he is an invited speaker at many international and national conferences. He has conveyed so many conferences, and he is also an editor of the famous journal, Indian Journal of Practical Pediatrics. And one more note I want to stress is, when I say he is authority in pediatric dermatology, I am very much genuine, and I mean it, because whenever I hear his talk, listen to his talk, I always take down all the notes from all the points, and I keep those notes as a treasure and a ready reckoner. So I think I need not tell you more anything about his talks and messages. So I invite the eminent speaker, Dr. Vijay Bhaskar, to enlighten us with the common problem, hair problems in pediatrics, which is a need of the hour. So over to you, Dr. Vijay Bhaskar. Let us hear from you. Thank you.
Very good morning. Good morning to one and all.
I think most of the people here are my seniors, or maybe we have met already. And really, thank you for inviting me for this wonderful CME. And I will share the screen now. So this is one of the common problem we come across in our practice. And first of all, why hair is so important? One, it is distributed everywhere in the body, except palms, soles, perimeter border of lips, glands, nail
Not
beds.
able to listen.
So not audible, sir?
Audible.
Okay. So
Audible.
it is in the, except in these areas, everywhere the hair is present. Second, it gives a great cosmetic effect. And also it helps the individual to maintain the self-image. And particularly in Indian scenario, it is an essential identity for women. And on an average, we have more than 1 lakh hairs, maybe probably around 1.25 lakhs at the time of birth, and then slowly it starts regressing to 1 lakh. And the growth rate of terminal hair is 2.5 millimeter per week. And generally we lose 50 to 100 hairs per day, and simultaneously they are replaced each day. So any person who complains of hair loss like 10, 20, 30, you need not worry about that. You can reassure them that that is a normal hair loss. And this is the how the hair grows, no? Like from the scalp at average 0.25 to 0.35 millimeters per day, like that this one happens. And hair has got 3 cycles. One is an anagen phase, which is the longest phase in the hair cycle. It lasts average around 2 to 6 years, and this determines the length of the hair. And it is also has high mitotic activity, so it is sensitive to noxious stimulus, stress, and most of the problems starts in this place. And the second phase is the catagen phase, which lasts for 2 to 4 weeks. There will be apoptosis of a hair matrix here. And telogen phase, where the hair shaft production is absent. So we straight away come to the different types of alopecias that can occur, hair loss that can occur. I'm going to concentrate more on hair loss rather than excessive hair. With the time permitted of 25 minutes, I'll do justice to this topic. So the common hair conditions we come across is, the non-scarring alopecias with hair shaft abnormalities and increased fragility. The following list goes on. And the hair shaft abnormalities without increased fragility, again, there are a few conditions which goes on. And the non-scarring alopecias without hair shaft abnormalities are there. And the other conditions like telogen effluvium, anagen effluvium, alopecia areata, androgenetic alopecia, traumatic alopecia, and tinea capitis. I am going to discuss only the common topics which we come in day-to-day practice. I am not going to talk about syndromes or very many conditions where we are not able to do much for the conditions. And of course, as I told you, the excessive hair growth is also an issue, like a hypertrichosis and hirsutism. Again, if time permits, I may touch on this, or otherwise we'll be seeing more of hair loss problems. And coming to the newborn period, there is one condition called as telogen effluvium of newborn, or it's otherwise called as physiological hair loss. At birth, we have terminal hair of scalp, which is present in the anagen phase. They get converted to the telogen phase. Those scalp will start shedding, the hair will start shedding from the scalp during the first 4 months of life, particularly between 2 to 4 months of life. And occipital area is the place where the hair loss occurs. And many people relate it to the friction. They say the baby is lying on the occipital region, so it occurs. No, it is not related to the friction. It is where the your telogen effluvium occurs. And rarely hair loss can occur in the frontotemporal areas. If that occurs, it occurs usually in the first 4 weeks of life. Like this, it can come in the frontotemporal areas. It's very commonly thing. So what are you going to do? Most of them, the parents are worried when they come to you. They say, particularly when father is having an androgenetic alopecia, they are more worried. They say whether my child will also become bald like him, right? So don't worry about that. You have to reassure that's the only thing you can do. And you can see that by 6 months to 1 year, most of the hairs will regrow, most of the hairs. Sometimes we can have even hair loss from the frontal to the occipital area, and all these hair will regrow. So reassurance is the only thing that is needed for the mother. This is another we come across commonly, and another common conditions. This is nothing but alopecia areata. You can see that there is a small patchy hair loss that is present there. And sometimes it can be single or it can be multiple. And see the smoothness, how smooth it is. So it is one of the commonest hair loss disorder. So you will have patchy hair loss without inflammation. There will not be any inflammation at all. It will be very smooth, and suddenly only it will be appearing, or suddenly it will be noticed by the parents, or mostly in the salons, in the barber. He is the first person to diagnose most of the time that there is a patch of hair loss. And if you see the skin, that is very smooth and soft. You can see that it is very smooth and very soft, that is present. And it is genetic susceptibility, and almost in 30% of the children we have seen that either the father, mother, or somebody in the family should have suffered from the same type of alopecia areata. It is an autoimmune process that occurs, and it affects both the sexes, but more common in males. And in the margins, if you see carefully, look at them, you can see exclamation mark hairs which may be noted. It will be like this, small hairs with a tapering end. You can see that tapering end. These are the exclamation marks that will be seen particularly over the margin of the hair. And once the hair starts reappearing, you can see the smoothness goes away, and all these hair follicles will start opening up. And you can see this as one of the conditions. And sometimes what happens is, in alopecia areata, suddenly they may complain of sudden whitening of hair or overnight graying of hair, because it normally targets the pigmented hair that occurs. And sometimes you can see white hair in a normal patch. When the hair starts regrowing also, you can see a white hair. Just reassure them, all these white hairs will become black once it starts regrowing. So you can reassure them for these conditions. This is what I was mentioning about. Suddenly it may turn white, overnight graying we call it. Sometimes overnight they can become gray, but need not worry, they have a very good prognosis, and all these hairs will become black in color if they were black before. And this is another type we come across. You just carefully notice the borders, particularly the margins. There is hair loss. This we call it as an oophiatic type. Oophiatic type we call this, and this always carries not a very good prognosis. We have to be very cautious when you start treating them and telling the prognosis to the parents. And this is almost the whole scalp is bald. So this is alopecia totalis. Totalis, when the whole body's hair is lost, then we call it as alopecia universalis. So it is an autoimmune process. So, and sometimes what happens, you can have hair loss over the eyelashes also. Eyelashes as well as in the margins here, you can see that. And there may not be any hair loss in other parts of the body. You may have hair loss only in the eyebrows, and it can be a total loss that can occur. And sometimes when it is associated with alopecia and the other areas of the body, this may be the last to regrow also. And there may be associated other changes. Always when you have alopecia areata, kindly look for the pitting of the nails. And the course and prognosis is very difficult to predict. Most of the time we see that they normally regrow the hair, and new patches may appear for 4 to 6 weeks and rarely for months also. So keep reassuring your parents. And if it is limited to a few patches, the prognosis is really good. You can reassure them. And most of the time, the regrowth occurs within 3 months to 1 year in majority of the occasions. And the investigation wise, you can do a thyroid profile, and ENT dental sepsis can be done to rule out any focal sepsis. And the main anchor of treatment is going to be topical steroids, particularly in the patch is very active. You can go for a topical steroids. Particularly, you can go for a potent steroid on the scalp. What is applicable for that age group? Like more than 2 years of age, you can go for mometazone. And if under occlusion, if you are able to apply, that gives good results. There are only 1 or 2 patches. We even go for intralesional steroids like injection triamcinolone. 5 to 10 ml, we can dilute it and then we can apply, but you have to be very careful. You can't go very deep into it. And short contact therapy like irritant therapy with anthraline cream can be tried, and topical immunotherapy with diphenyl cyclopropene or squaric acid dibutyl esters also can be tried. They act as an irritant and they'll try to bring the hair outside. Sometimes even we use salicylic acid in a government hospital setup. Sometimes we use salicylic acid also to irritate the skin and to bring back the hair. When it is very extensive and active lesions are there, it is better to, you can manage as far as possible, or you can refer to the dermatologist. If you want to try, you can try oral mini pulse therapy. That means we give a high dose of steroids only in the weekends. Like Saturday, Sunday, we give beta-pethazone tablets, 0.1 milligram per kg body weight. We use it 0.1 milligram per kg body weight on Saturday. The same dosage again on Sunday. We give it, we try it for 3 months. Most of the time, the hair shedding will stop and the hair will start growing. Then you can taper down the steroids. Or else we can try PUA therapy, narrowband UVB therapy also has been tried. And in some of the patients, we try even immunotherapy, I mean, immunomodulating therapy like cyclosporin can be given. If at all there is no hair growth at all, then we can go for cosmetic aids like a wig, or even you can go for tattooing of the eyebrows, particularly in the eyebrows area. Sometimes when they don't develop it, you can go for tattooing also. This is the next common condition we come across in our practice is going to be hair loss. And you can see that there are multiple small pustules that you are seeing and a big swelling that is seen. And once a pediatric surgeon sees this, the first thing will be to put a knife on this. But if you put a knife, nothing will come. Only blood will come, nothing will there. This is one of the common conditions we come across. Sometimes there may be associated adenitis that may be present in the cervical area. And whatever antibiotics you give, whatever antibiotics you pump in, this adenitis may not disappear at all. Here you have to ask for the history of recent shaving of hair, or any haircut that has recently been done, or any other siblings are also having similar problem. Sometimes you can get lesions like this. A lot of pus and oozing can be there. But again, this is a common condition which is caused by a fungus, right? It is a tinea capitis that occurs. And when you have a doubt, you can do an hair root examination, or you can scrape the lesion and you can look the 10% potassium hydroxide wet mount can be done, and you can see the fungus that is there. And once you make a diagnosis, the treatment is going to be very simple. It is topically, we can try topical ketoconazole shampoos. What you do is you slightly wet the hair, apply the ketoconazole lotion, wait for 5 to 10 minutes, and then you can rinse it off. You can do it thrice a week for the first 1 month, and then you can make it twice a week also. And oral antifungals, you have to give oral antifungals. No topicals alone will not work in this condition. And still date, I can tell you that griseophaline is the drug of choice. It should be 15 to 20 milligram per kg body weight in 2 divided doses. And it's a micronized griseophaline I'm talking about. And you have to give it along with food. But you have to give it for a longer period of time. Now, for dermatophytosis, we give it only for 4 to 6 weeks. Here, you have to give it for 3 months. 12 weeks of treatment is essential. The other drugs you can try is fluconazole and terbinafine. To be very frank, in my practice, I have seen that griseophaline works better for tinea capitis, and other drugs, I have burned my fingers with the other drugs. So griseophaline will be a better drug of choice along with topical ketoconazole shampoos. This is another common condition you will come across, particularly when the mother is tying the hair very tightly. You can see alopecia like this. This is one type of alopecia. We call it as traumatic alopecia. Either it can be due to forceful extraction of hair, or breaking of hair shafts by friction, pressure, or traction. Commonly in our places, it is due to the traction. When mother puts the hair very tight, that is the one. Or sometimes for cosmetic practices, they may want to have a very different cosmetic things on the hair. That also can lead to this traction alopecia. And this is another common things. Then first, if you are able to identify the cause, then ask them not to tie it very tightly. Slowly, you can see within 3 to 6 months, most of this hair will come back to normal. This is one of the traction alopecia. The other common traction alopecia we come across in our practices, your trichotillomania. Here, they will have an intense desire to pull the hair, the children, and the peak age is somewhere around 9 to 13 years. It's an obsessive compulsive disorder. You can have a single patch that may be involved, or it can be multiple sites, and particularly it will be seen more over the accessible areas of the hair. And you can see that the hair follicles will be normal, but the hair density may be different. I mean, the hair density will be normal, but you can see different lengths of hair that is present. And when you do a pull test, it's a negative pull test that will be there. And sometimes these children may swallow these hair, that can lead to trichophagia and trichobezoar also. So it's a self-limited, self-induced form of traction alopecia, and it is consciously or by habit plucking, pulling or cutting the hair in a bizarre manner that can occur. And it can occur in any hair in the body. But scalp is the most common site, but other areas like eyebrows, eyelashes, even pubic hair can be plucked. In young individuals, it may be associated with finger or thumb sucking may be there. You can see in this child, there is thumb sucking also. So the treatment you have to do is more of a psychological therapy that is more important. So for diagnosis, it is the history and morphology, and the other differential diagnosis can be so many. And the treatment is going to have habit reversal training, refer to them as psychiatrists, they will take care of the problem. And there is one more trichotillomania called as trichotillomania by proxy. That is, you may have a child who comes with trichotillomania, but the parent will be having trichotillomania, but he may not pull his hair, but he may pull the hair of the child. So that history also is very, very important. You have to get it from the mother at least, or either one of the parents may be doing that. So this condition you should not forget. So it's called as trichotillomania by proxy. If at all that's the problem, then the parent has to be treated, not the child. And the other common conditions we come across in our practice is telogen effluent. It is one of the commonest cause of non-scarring alopecias. There will be a short onset duration, and the follicles are stimulated to lose anagen, and they enter the telogen prematurely, and the hair will start shedding. When it is less than 6 months, we call it as acute, and when it is more than 6 months, it's chronic. The commonest cause of this telogen effluent is a stress or a severe illness, post-typhoid. So many conditions. Any conditions, it can lead to the thing. So like fever, major trauma, surgery, thyroid abnormalities, iron deficiency, lot of things you can tell. And even drug like anticonvulsants, isotretinoin, even oral antifungals like terbinafine can cause this telogen effluent. And you can see that there will be loss of hair that will be present, and there should be shedding of hair more than 100 per day, and you should have a positive pull test, that is more than 10 hairs out of per pull. That is normally this is the way we do it. We grasp the hair, maybe a tuft of hair with a thumb and index finger, and then we gently pull it up, and you have to try it in 5 areas, and it is better to be done on the day of shampooing or one day later. It always gives good results. And the positive pull test is when it is more than 10 hairs, you get it at the time, then you call it as a positive pull test, that is more in favor of telogen effluent. How do you treat these conditions? No effective treatment. If there is a cause like stress and all, that can be taken care, or there is no effective treatment. This is one condition which neither respects me or my medicines also. So normally you have to reassure them, put them on some nutraceuticals containing amino acids and iron, ask them to take it for 3 months or 6 months. By the time they will have their natural hair growth, and you can take the credit and your consultation fees. And so usually the complete regrowth occurs within a few months, unless the triggers are not repeated, unless the child doesn't go into a stress or the repeated skin conditions. And always explain the cause of the disorder to the parents and tell them they have a good prognosis and they'll get back the hair. So whoever is having a timekeeping, please let me know, because I keep talking. So please let me know when my time is over. Okay. And this is another thing we come across is anagen effluent. It is common after radiotherapy or chemotherapy. Here the hair shaft production is markedly reduced. So tapering of a hair shaft occurs with shedding, and hair pull test, you will have a pencil point or dystrophic hairs with proximal tips tapered to a point. Either you say the drug which is causing it or the radiotherapy, then that will help in the regrowth of hair. This is called as anagen effluent. And premature graying, this is another common conditions. Normally, when do you call them as premature graying? As per the Indians, it is less than 30 years of age. When you get graying of hair, we call it as premature graying. So remember, more than 30 years of age, if somebody comes until they have premature graying, it is not so. It is a normal graying. And most of the time, it is genetically suspect, genetically prone individuals only will develop. But these are very many conditions which can cause this premature graying, what I put it. But most of the time, I don't come across many of these causes what I have put in the sites. All may be cause of premature graying, which are treatable if possible. But as I told you, most of the time it is genetic which is caused. So I reassure them. So all these medicines may or may not work. There is a topical melatonin solutions that are available that you can try. Twice daily you can try it. And whatever the hairs that are gray will start becoming black. And once you stop the treatment, those hairs which were becoming black will become gray again. So this works only up to 25 years of age. So please don't try it at this age, particularly at 50 years or 60 years. It never works. It's only for the children who are more worried about it. You can try this topical melatonin solution can be tried for this premature graying, or most of the time it is only genetic. And this is another problem. So they compare their hair with others, right? So they want hair like this. Most of our females, they would like to have hair like this, right? So the next common questions that comes in our practice is the hair. We can see that which hair oil is best for hair growth. So as far as my knowledge goes and what I have practically seen, none of the hair oil works. So the hair never grows with any hair oil, but only all the companies which are manufacturing the hair oil, they grow very well, right? So this you have to tell to the patient that they can apply the hair oil. There is nothing wrong in it, but how far it will help us is a question that has to be seen. And next common questions we come across in our practices, which is the best shampoo. See, as far as shampooing is concerned, most of the shampoos which are available on the market, particularly now, they're all regulated and it can be safely used. They do not cause any hair loss. That is one. Because they have some preservatives which can cause irritant dermatitis like formaldehyde, but the contact time is very short. We just apply the shampoo, we leave it for some time and then wash it off. So that shorter contact time may not cause any hair loss. That is one. So any shampoo is safe. That is not only the Chikaka that is safe. You can use any shampoo, which is nowadays safe and it will not lead to thing. And then another common questions I come across in my daily practices: will frequent shaving of hair or haircut increase the hair growth? They keep on tonsuring, thinking that the child will grow more hair. No. By keeping on tonsuring or frequent shaving of hair, you will never get any excessive growth or increase in hair growth. So in case that they have it in mind, please tell them to stop it. So, and most of the children, they don't like to have a shaving of hair also. So this is one of the common things we come across in our practice. And of course, these are the other hairs we come across is the woolly hair, which has a tight and curly hair, and they may have fine and dry hair with corrugation resembling wool of the sheep. And there may be many associated abnormalities, and they may be associated with systemic diseases. It's an autosomal recessive conditions. They may have ocular abnormalities, keratoderma, cardiomyopathy and all, but nothing much we are going to do for this type of hair like woolly hair, which come across in practice. Sometimes we get uncombable hair syndrome. Otherwise, we call it a spily trianguli canaliculi or spun glass hair syndrome. So here we have pale, silvery, blonde or straw colored hair that may be present, and hair will be dry, frizzy, unruly and uncombable. And usually it starts in the early life or during childhood. But if you see the other hair like eyebrows, eyelashes and body hairs, they will be perfectly normal. So these are the other few conditions we can come across. I think the common conditions, I think I have highlighted. If they have any doubt, they can ask the questions to me. I'll be happy to answer them. Thank you. Thank you for the opportunity given. And I thank the whole IAP, Kerala, and particularly all the people. I have to take at least 5 minutes to thank all the people. So I thank one and all for giving me an opportunity, and we'll meet again in the panel discussions. Thank you.
Thank you, sir. Thank you for that enlightening talk. There are a few questions.
Yes, madam.
One is...
Madam, sorry, madam. That questions will be answered in the end of the session. There are 3 more talks in the session. After that, we will answer the questions. Otherwise,
there is a message. It will be, can ask.
No, that is after session means no. 3 talks are there, madam. Yeah, in the first session. After that, we will answer, madam. Okay.
Sorry, Dr. Hariuma.
Sorry, madam. Okay. Next talk is on cutaneous fungal infection. That is Dr. V. Anandan will be conducting that session. And I invite Dr. Lata ma'am to introduce the speaker. And Dr. Lata, I was the secretary of Dr. Lata in Kottayam IAP, and I have very fond memories with her. And she is the professor in Pushpagiri Medical College, and she was the HOD and professor in ICH before. So I invite Dr. Lata ma'am to introduce Dr. V. Anandan.
Hello. Am I audible?
Yeah.
Good morning, dear all. So first of all, I would like to thank Vijay and other members of the organizing committee for giving me such an opportunity. And also, I would like to congratulate all those are concerned with the arrangement of this conference in a very good fashion. And Dr. Anandan, we all know that he is a well-known pediatric dermatologist, and he is a teacher, a PG teacher for the last 19 or 20 years. He is presently working in the Government Stanley Medical College, Chennai. And he is a good organizer, and he has contributed many times to the state, national, and international conferences. And he is a good organizer also. And we are lucky to have him with us during this morning. And the topic is again very important because we all know that it is a common problem, and they come to us, the pediatricians first, and so it is very important for us. And I'm sure that after hearing from Dr. Anandan, so we'll be able to diagnose them and manage them efficiently, and also we'll be able to refer the patient to a pediatric dermatologist or a dermatologist at the prompt time. So, over to Dr. Anandan for his speech.
Hello, am I audible?
Yes, sir.
Yes.
I'm sharing my slides now. Is it visible?
Perfect.
Is it visible?
No.
No?
No.
Visible, sir? No, because you are visible, but that slides have not come. Slides have not come.
Oh, I'm not good in all these things. But
Just share the screen, sir. That's all. From the
yeah, I've got
that
my
green.
file in the desktop.
Then that green icon, sir. In the
Yes.
you just share the screen.
Yes, I have touched it. And now I should touch the share, is it?
Yeah, share screen.
Share screen.
Yeah, it has come now.
Right. It's available.
Yeah.
Yeah.
Right. But I can't see the screen what I'm going to talk.
Only your screen is available. You're not open the PPT, sir. We're seeing your computer screen.
Hello. Hello.
Yes, sir. We are seeing your computer screen.
Hello. I'm seeing Dr. Leta, Dr. Hari Kumar, and my picture on the screen, but I'm not
This slide,
seeing the.
sir. Sorry, sir.
Sir,
This slide
that-
are not seen.
Dr.
Yes, sir.
Anand,
Sir.
Yes.
Dr. Anandan, can you just go first to open the PPT, go back,
Yeah.
open the PPT, put it in the, you minimize
Yeah,
it.
correct. Yeah,
Then
now
you
it
have
has
to open
come.
the PPT.
Now it has come.
Yeah, now
Oh.
it has come.
Fine. Now is it all right?
Yeah.
Fine.
All right.
A very good morning, ladies and gentlemen. And first of all, I would like to thank the organizers of this prestigious IAP Kerala Pedicon, which is mainly based on this pediatric dermatology. And I'm honored to be a part of this. And I thank once again. And let me move on to this session so that we can, if I'm able to make an impact by making this slides impressive, then it should be fine. So this pediatric fungal infections is supposed to be very, very important. Why? Because it is 100% treatable. If you treat it correctly, if you pick it up correctly, and if you are going to treat it correctly, the results are going to be 100% and the reputation is going to go up. If there's going to be a mess on this, the management, definitely the sufferer is going to be the child, as well as it is going to cause mental agony and trauma to the entire family. For any infections or for any discussions to go on the right way, there needs a classification. So this is broadly classified into superficial and deep. And this superficial is once again subclassified as dermatophytosis, non-dermatophytosis or candidiasis, malassezia-associated diseases, and others like black piedra, white piedra, tinea nigra, chitodellium infections. Of course, on the right side of the screen, you see a lot of lineup of the deep mycosis, which is going to be beyond the scope of this lecture. And we are going to concentrate mainly only on the superficial fungal infections. Dermatophytosis, one should understand that it is called dermatophytosis because it is going to thrive on the keratin of the skin, hairs, and nails. So it means that only these three areas, skin, hair, and nails, will be affected by the dermatophytes. And there are three genera which is going to be important, like Microsporum, Trichophyton, and Epidermophyton, with roughly 40 species. And the severity is based on the species and the immunological response of the host. So based on their natural habitat, it's called anthrophilic, that affects only the humans. Zoophilic, normal hosts or animals also infect humans. And geophilic, found in soil, and it becomes occasionally pathogenic. And the transmission is through the infected scales and hairs containing the infected spores, that is called the anthroconidia, which is shipped from the infected human or animal host. On the right side of the screen, one can notice this type of anthroconidias. So that is nothing but a concentrated fungi in a solid form. Pathogenesis is mainly on the enzymatic penetration by keratinases. The hyphae physically forces themselves between keratinocytes by the flattened branched fronds. And the favorable factors for this infection to have a hold in the skin is the minor trauma, abrasion, maceration, hydration, skin pH, alteration in the skin pH, increased in the carbon dioxide tensions. Now, as far as the pediatric dermatophytosis distribution in India is concerned, this is mainly the epidemiology. The trunk is the most affected part with 29%. Next comes the face with 24%, groin with 20%, limbs 15%, gluteal area 9%, scalp 2%, and once again the palms and soles almost negligible or 2%. And previously, the localized form used to dominate with about 90%, with only 10% of the extensive disease. But now one can notice that extensive has gone up to 28%, leaving the localized to 72%. It means that the infection incidence is more and the virulence of the organism is more, or we are wrongly handling with the disease. So this could be the implications for this slide. Now, the reason for this is mainly the usage of steroids or steroid combinations with antifungals, knowingly or unknowingly by the general practitioners, or sometimes even by the specialist practitioners also. And our IADVL has come with a slogan, say no to self-topical steroid use. And that was the theme for IADVL 2019 to fight the topical steroid abuse. Now, let's see one by one. Tinea capitis. So this primarily affects children and rarely immunocompromised adults. And this is caused by small spore ectothrix infections. So this can be either ectothrix infection, chirion, endothrix, and favus. This ectothrix and endothrix is nothing but based on the organism which is going to be infective in the hair follicles. Either it is exterior to the root sheath or interior to the root sheaths. And that's Tinea capitis. This is called small spore ectothrix infections. There will be partial alopecia and mild erythema and scaling. Apart from this, there may not be any symptoms and the child may be kept scratching. And this is most commonly caused by Microsporum audionae. So just keep visualizing the slides. And once this is over, finally we'll go for the workup and the treatment as a whole. This is chirion. My colleague, Dr. Vijay Bhaskar, was talking in detail about the chirion. This is caused by Microsporum canis. This is painful in contrast. And it is an inflammatory mass with loose hairs. You can see a lot of pus pointings here and there. And the loose hairs will be there. If you just pull out, it will come out just like that. And the follicles will be charging pus, as I said. Sinus formation can occur. And it can have thick crusts also. And lymphadenopathy could be there, as Dr. Vijay Bhaskar has already shown in the picture. So here, once again, I'll remind you to keep reserved for the investigations and the management. And this is an endothrix infection where you get a black dot as well as a gray patch type. So this is non-inflammatory patch of alopecia with minimal scaling. And you can see this black dots here in this picture. So this is nothing but the broken hair follicles, which is as the black dots. And the gray patch is due to the scaling on the scalp surface. This can result in diffuse alopecia. Next is the favus. This is a Latin word which means honeycomb. And the agent is going to be Trichophyton shaulinae. And here you can see the yellow colored crusts, which is in the form of crusts, cup-shaped crusts, that's called scutula. And typically this will have a mousy odor. And here the drug of choice is rhizofulvin again. And here also there will be hair loss. Ladies and gentlemen, if this is identified at the earliest, treated properly and appropriately in appropriate time, this hair will regrow. If it is left untreated, or if there is going to be a delay or any mismanagement, that is going to create scarring and the hair may not regrow at all. So now the differential diagnosis here are alopecia, seborrheic dermatitis, impetigo, and of course the connective tissue disorder, discoid lupus erythematosus. If it is untreated, it may become chronic and may sometimes resolve spontaneously, leaving a scar. Removal of crusts with wet compresses is advised. Analgesics are prescribed if there is pain. Ketoconazole shampoo or selenium sulfite may play an adjuvant role by reducing the spore load. And as said, ketoconazole shampoo 2% could be used after wetting the hair and leaving there for about 5 minutes, then rinsing it thoroughly for about 2 weeks for the first 8 weeks. Twice weekly for about first 8 weeks, and for another uh, once weekly for about next 4 weeks. So totally 12 weeks will be the best treatment. Now, how much our topical therapy you are going to give, that is not going to penetrate the hair follicles. So there is no point in trying any creams in the hair bearing regions. So straight away get into systemic therapy. Terbinafine, if it is less than 20 kgs, 62.5 milligrams, 20 to 40 kgs, 125 milligrams, and more than 40 kgs, 250 milligrams daily. Itraconazole, if you want to give it, is 2 to 4 milligram per kg per day for 4 to 6 weeks. Griseofulvin, for rounding off, it is given as 10 milligram per kg body weight for 6 to 8 weeks. Then it can go up to 12 weeks also, depending upon the healing of the lesions. And itraconazole can be given in weekly pulses also. And these are the drugs which are available for systemic management. But of all these, griseofulvin is supposed to be the gold standard of treatment. If it is going to be micronized form, it has been said that 11 milligram per kg body weight once per day in 2 divided doses for about 12 weeks will be the best treatment. But after 6 to 8 weeks, one can start monitoring the side effects as well as the regrowth of the hair. And this griseofulvin has been tried up to 25 milligrams per kg per day, but the results when compared with 11 milligrams and 25 milligrams was quite negligible. So it has been concluded by various studies, 11 milligram per kg body weight will be sufficient enough. When to go for this itraconazole? Most of the time, this griseofulvin can produce side effects in the form of photosensitivity or sometimes even irritant contact, drug reactions. In that case, one can go for itraconazole, or if it is recalcitrant, which has been treated for so many times, then one can go for itraconazole. And please remember, as pediatricians, itraconazole is available as solution also. But please do not touch the solutions because it is not recommended for the routine usage. It should not be used below 6 years of age as per FDA recommendations. And since it contains cyclodextrin, it can produce severe diarrhea. So this solution is mainly reserved for the invasive fungal infections, which is not amendable to the routine methods of treatment. And since the dosage in the solution is going to be very high, and that is usually reserved for invasive diseases or with HIV concomitant diseases. And if at all you want to give pulse therapy, I'll talk to you about the pulse therapy a little bit later from now. Now coming to the dermatophytosis of the glabrous skin, one can see here tinea faciae, tinea corporis if it occurs in the body, tinea glutealis which is partially treated, tinea pedis, and tinea unguum. Apart from that, tinea manum, which can occur in the palms, can also be there. But if you carefully look into this picture, so it is almost a patch, round to oval, or it could be of any size. And if you note carefully, you can see a beautiful border, wonderful border in this. And if you see very carefully with the hand lens, or since our eyes are very tuned for this, we can directly pick it up. The scaling here within the lesion will be more concentrated on the peripheries rather than in the center. And more or less, the center will be clear of scales. That is called central clearing, and peripheral scaling, we say. That is because the fungus keep on moves outside for the search of keratin, that is the food for it. And please do remember, while treating these diseases with the topical drugs, the fungus will be not restricted to this borders. It may be slightly away from the borders also. So one has to keep in mind that 0.5 to 1 centimeter to be covered with the topical drugs when you are planning for the topical drugs. Skin topical treatment, most of the time they do very well. And if at all the nail is involved, one should go for the systemic treatment. And for the nail involvement, greaseprevent is not preferred because one has to go for a long-term treatment, roughly about 3 to 6 months too. So the greaseprevent can produce a lot of side effects on that. So in that case, one can go for itraconazole. Itraconazole, as I said, 5 milligram per kg body weight for a period of about 4 to 6 weeks continuously, or one can go for the pulse therapies. Pulse therapy in the sense 5 milligram per kg body weight per day given for a period of 7 days in a month, which has to be repeated for 2 months, as if it is going to be in the fingernail, and if at all it is going to be in the toenail, it should be given for 3 cycles. Hope I am very clear. And for this topical drugs, one has to go for topical, glabrous skin infection. Most of the time, the topical drugs will be very effective. And while taking the topical drugs also, one should be very clear when to go for topicals and when to go for systemics. I'll tell you the criteria for systemics so that you can reserve the topical drugs causes. If there is more than 20% of the body surface area involvement, one. Number two, there are 2 concomitant sites involved. 3, conventional topical therapy failed after using for about 4 weeks. Any immunodeficiency status, primary or secondary. If the patient is on steroids, if the patient is on HIV drugs, if the patient is having any malignancy, underlying malignancy, then these are the patients who are justified to go for the systemic therapy straight away. And there are so many azoles which are available, like starting from clotrimazole to fenticonazole, that is the latest available drug. But I prefer personally, rather than these things, I go for amorolfine. Why? Because this amorolfine has got bi or 2 methods of action. That is, it acts at the 2 levels. One is it blocks the 14 alpha demethylase, usual like any other antifungals, and it also interferes with the reductase enzymes, a step above the 14 alpha demethylase enzymes. So in that case, there is going to be a dual block, and the treatment is going to be very, very effective. And please remember, one has to apply 0.5 centimeters to 1 centimeter away from or beyond the margins of the lesions. And the resolution is marked by flattening of the lesion, reduced scaling, reduced itching, and reduced erythema. And sometimes the borders will have active papules, that says the level of inflammation, and the papules also comes down, and that says the resolution of the disease. Apart from that, one has to take care of the clothing, which has to be washed in the hot water and sun dried, and one should cut short the nails, and so that the spores doesn't get accumulated under the nails. And one should be very careful about this this type of threads. So that has to be removed because that can act as a fomite. So one should be very careful in all these things while giving the instructions. Now coming on to the non-dermatophyte infections, that is the candidiasis, the common species is about albicans, tropicalis, parapsilosis, and glabrata. Apart from that, there are various species that can occur. So here, the predisposing factors are the newborn infants, local occlusion and maceration, immunodeficiency, iron and zinc deficiency, prolonged antibiotic therapy, endocrine diseases like autoimmune paraendocrine disorders with candidiasis and ectodermal dysplasias, diabetes, Cushing syndromes, and so many other endocrine disorders. And I'm not going to deal with all types of candidiasis because as a dermatologist, I can say about 10 types of oral candidiasis alone. So, but those things are not required for a pediatrician point of view. The common things are always common. Here, it is the oral thrush. It has been said that 6% of the babies do have oral thrush, and the high risk category is the low birth weight infants. This occurs as curdy white patches, and this will give burning sensation to the child, which can avert the feeding for the child, and that can result in feeding difficulties. And the best drug of choice will be nystatin topically, but since nystatin is not used very commonly, clotrimazole topical oral lotions can be applied for about a week or so, 3 times a day. That clears the lesions. perianal candidiasis or napkin dermatitis for that matter. This is an irritant contact dermatitis for that matter, and usually it occurs in the age of weaning. And the main pathology here is hydration, maceration, and followed by infection. And this infection, please remember, this is going to be a mixed infection. Eczema, there is going to be, initially there will be eczema, there is going to be overgrowing of Staphylococcus aureus, and later Candida albicans is going to be added. So it is going to be a combined infection. Apart from that, the pathology, pathogenesis, the urine, feces is going to be there under occlusion for a long time under the diapers, and this can alter the pH, and enzymes like lactases can cause an alteration in the pH, and that can induce the damage to the superficial skin, which is already macerated, and that can lead on to the diaper dermatitis. If one can watch this picture carefully, it is only the convex areas that is being involved mainly. And the concave areas or the flexures are totally spared. So that gives a clue for the diaper dermatitis. The treatment is going to be avoidance of diapers. And here, most of the people may not agree with me, but most of the textbooks support with me and most of the journals support with me. Here, the combination creams. Here, as a dermatologist, I used to tell my children or my postgraduates, if you are going to use a combination cream, it means you are not confident in your diagnosis. But here, it is use the combination creams will be wiser if you use it. Here, I go for a combination cream for about 2 weeks with good amount of barrier creams containing zinc oxide and avoidance of diapers. If at all it is required, we can go for alternate type of diapers, which can be taken up in the discussion period. And candidal paronychias are very common, especially when children with finger sucking history. And here what happens, chronic finger sucking can cause breakdown of the cuticles, and this cuticle can cause invasion of the candida, and that can cause an infection with edema, erythema, tenderness of the nail folds with or without pus discharge. It will be so very tender, ladies and gentlemen, and sometimes it can even discolor the nails. Sometimes it can discolor the nails, to brown or even green discoloration of the nail plates, and the nails can even become friable. They can get detached from the nail bed. And here once again, not much of topical therapies may be of use. One should go for analgesics and systemic drugs. Here, the best drug what I use is the fluconazole, which gives a very good results. Candidal intertrigo, that is the inflammation of the opposing surfaces. It's the most common form, and the organisms colonies are formed in the skin folds, especially the axilla, groin, and the submammary folds, and one can see the erythema, scaling, and sometimes even maceration. They can see the wet surface, and it will be intensely pruritic and sometimes with burning sensation. Id reactions can occur. It is nothing but due to the candidal antigen that can produce a distant site infection. Here, since already it is wet lesion, if at all you want to go for anti-candidal drugs, it's better to go for a cream which dries the area, or we can go for clotrimazole powders. This is a very, very rare condition for neonatologists in the nursery. This is neonatal cutaneous candidosis, which can present as papillovesicles. The child may be having a failure to thrive. And this is mainly due to the intrauterine candidal infection prior to delivery, where it ascends from the female genital tract to break the amniotic membranes and get infect the child. And even if the foreign bodies in the uterus like IUDs, cervical sutures, etc., can predispose for this condition. And usually it is occurring in the full-term infants. Most of the time it is a benign course, unless and otherwise the immune status is very unstable. So they respond very well to topical therapy, and it may clear spontaneously. And poor prognosis should be kept in mind when the child is premature or with low birth weight. And as far as the candidiosis in total is concerned, you can just scrape it and put it under the KOH with a cover slip, and one can see the round to oval budding. One round to oval budding yeast cells of 2 to 4 micrometer size with long hyphae and yeasts at the point of construction. If in doubt, one can do a culture with Sabros dextroagar. Still, if you are in the corporate setup, one can go for PCR for the confirmation of diagnosis. So while treating, one should think in terms of whether the patient or the child is immunocompromised or preterm. That might require a systemic therapy. Topically, oral candidiasis, nystatin suspension, as I was telling, 1 lakh unit per ml will be very, very useful and drug of choice. And of course, even the clotrimazole topical applications can be applied. Now we'll go for malassezia associated conditions. The common thing is the cradle cap. It occurs in the first 3 months of life. It is a scaly, greasy patch on the scalp, and it is usually asymptomatic. And there is an hypothesis which has been put forward that it is a fungal infection caused by Malassezia furfur and overactive sebaceous glands in the child because of the maternal hormones circulation, and it could be a manifestation of biotin deficiency in the child also. Here, just leaving alone can tackle the situation. If the mother is very much worried, one can go for the mineral oils extraction, and azoles can be applied topically, and ketoconazole shampoo 2% can be applied, and it can be, the water should be poured from front to back so that the water gets washed out towards the occiput and it doesn't spill over into the eyes, which can be irritant if ketoconazole is used. If the time is getting over, kindly interrupt so that I'll be happy to fold myself. This is a very common condition, which is called Malassezia furfur associated disease, that is called pityriasis versicolor. It occurs as a hypopigmented as well as hyperpigmented lesions, scaly lesions, and the scales will be dry. It will be like furfuraceous scales. Here, the borders will be very, very clear. That is called pencil line borders. And one can see here the pencil line borders as well as the color changes. And most of the time, it responds very well to the topical drugs. And if at all it is going to be very, very extensive, one can go for fluconazole, single dose therapy, that is 12 milligram per kg body weight as a single dose therapy. And if it is going to be very extensive, selenium sulfide shampooing, leaving it there for about 15 to 20 minutes, washing it off for 14 days continuously will be of much help. And that is pityrosporan folliculitis, which will
Excuse me, sir, we are crossing our time limits.
Yes, madam. Shall I fold it, or maybe I'll take 1 minute so that I'll finish it off?
Okay, you can hurry through.
Fine. So this is pityrosporan folliculitis, which will resemble acne, which is going to be bilateral, symmetrical, usually on the seborrheic areas, mainly spread over the back, and it will be itchy also. Here the treatment is going to be topical as well as systemic. And these are all the conditions which might be useful for dermatologists, but may not attract attention to pediatricians. But to finish it off, it is white piedra. Here, the hair shaft might have soft white nodules, and here the close shaving and imidazole derivatives will be of much use. The similar lesion, if it is going to be white, it's called white piedra, and if it is going to be black, it is called black piedra. Here it is caused by piedra horte. And tinea nigra, this is commonly missed, which can happen in the palms, where asymptomatic brown to black solitary patch with irregular, well-defined borders in palms and soles. And here, the treatment is going to be, once again, 4 to 6 weeks of topical imidazole after confirmation with KOH staining. Lastly, schistosomal infections. This is a plant pathogen. Scaling of soles and palms can occur, and cracking between the toes. Nail dystrophy too can occur. 30% KOH shows double contoured appearance. And here the treatment is going to be systemic, terbinafine or greaseprevir. And this is going to be very, very refractory to treatment to recur again. Thank you, ladies and gentlemen. This is a photograph taken in Kerala, Munnar. So I was very impressed with this place. So I add this as a thank you slide. Once again, I thank the organizers for giving me this wonderful opportunity. If there are any questions that could be reserved, which can be cleared to the best of my knowledge. Thank you very much.
Thank you, Dr. Ananthan, for the informative talk. So I think we can move to the next topic, and the discussions will be after the other two topics.
Now I invite Dr. Nisha Narendran, Associate Professor of Government Medical College, Thrissur, to chair the session. The next topic is nail changes in children. Dr. Nisha Narendran. Over to you, ma'am.
Thank you, sir. Am I audible?
Yeah.
A warm good morning to you all. I thank the organizing people and the IAP Pathanamthitta for giving me this opportunity, wonderful opportunity to join this lovely meeting. And I wish it a grand success. And I'm so pleased to introduce the next speaker, Dr. Soumya Jagadishan, a young, charming, dynamic one in the dermatologist brigade in Kerala. She is currently working as associate professor and consultant in Amrita Institute of Medical Sciences. And her academic credentials are actually very catchy. And she has won the GSK National Quiz for Postgraduates Gold Medal. She is also the receiver of the American Academy of Dermatology Scholarship and Women's Dermatological Society International Grant. And this young researcher already have got 2 prestigious awards, research awards in her kitty. That is Dr. BKH Nair Award for Best Original Research, IADVL Kerala, and Professor B.N. Banerjee Gold Medal for Original Research by IADVL. And she already has got 30 publications in index journals. She's also author in standard textbooks like Roxburgh's Common Skin Diseases. And her areas of interest include clinical dermatology, pediatric dermatology, immunodermatology, and pigmentary disorders. And her teacher, Dr. Girija Madam, remembers her as a great dancer and indeed a great student in UG times itself, bagging the gold medal in pediatrics in undergraduate level. Coming to the topic today, she'll be discussing on nail changes in children. And it is discussed in pediatric specialty in the wards very commonly, like Bose lines in trauma and severe illness, and the Lindsay nails or half and half nails in renal conditions. But that's not just the end of it. We pediatricians find dermatologists very helpful, not only in finding the nail pathology, but also in nailing the diagnosis very early at times, especially when the changes occur in young children. And also when the change is specific to the child, as in pachyonychia congenita, etc. So I look forward to the brilliant speaker for an enlightening talk to streamline our approach to nail pathologies in children systematically. Over to Dr. Soumya.
Thank you, Dr. Nisha, for a very lovely introduction. I really thank you from the bottom of my heart, but I'm not sure whether I deserve all those lovely words that you described me about. And thank you, Girija ma'am, for remembering me in a very nice way. I hope I'm audible. Right. Yeah. So actually, it makes me a little apprehensive to speak after such an introduction and after so many stalwarts in the field like Dr. Anandan and Dr. Vijay Bhaskar have spoken. So anyway, I'll go to my, thank you again, and I'll go to my topic, which is nails in nailing the diagnosis in children. Nail changes in children. I hope you can see my screen.
Yeah.
Yes.
I'll put it in slideshow mode, yes. So Dr. Nisha, as you really rightly pointed out, nails I've often felt are an overlooked part of our systemic examination. In fact, they do not contribute, I don't know whether you agree with me, but they do not maybe perhaps contribute to much of pediatric consultations. And as clinicians, we often do not take a lot of time in clinically examining the nails very specifically, overlooking their importance. Because often we take it as a cosmetic issue, the nail changes, even if the parents tell us. But we know that in certain conditions, like you mentioned, in certain genetic disorders, they have a very specific role. But even more than that, the localization of nails could be an initial sign of a syndrome or a systemic disorder. And they also have very important roles to play in protection, like the nail plate will protect the distal part of your skin, the fingertip, the phalanx, and also they're important in the delicate movement. So nails are an important part of our system. So before we go on to the nail changes and nail diseases, I'll just take a minute to tell you about the development of the nails and the nail anatomy. We know that nail apparatus is being formed from the intrauterine period, starts from the 8th week of gestation, and it finishes at 5th month of intrauterine life. But what, as pediatricians and clinicians, we need to know is that how the nails will help you to even determine the maturity. So in newborns, the nails will be thin and soft, unlike the adults. And at birth, what happens is this nail plate will accurately reach up till the tip of the margin. So that indicates that there is maturity. That is, it's a term newborn. Whereas in post-mature infants, these nail plates will usually extend beyond the hyponychium. Hyponychium means the area of the skin covering the free edge of the nail. So it will extend beyond that, indicating post-maturity. Similarly, in premature infants, the nail plate will be shorter than the distal tree. So that will also help us to identify the maturity. And the growth of the nail occurs maximally till 10 to 12 years of age. And thereafter, it continues to grow for 2 decades, and then it slows down. So here again, I don't know whether you can appreciate, this is a preterm infant. You can see that the nail plate is proximal to the free edge. Whereas in a term infant, the term neonate, the nail plate extends correctly till the free edge. Whereas in post-mature infants, the nail plate is extending beyond the hyponychium or the free edge. So that also gives you an idea. So I'm using these terms like hyponychium and all those things. I don't know how far you're familiar with it. In case you're not, I'll just give you a very concise view about the anatomy of the nail structure. So here you can see this hard outer covering, which is a nail plate. And you have the folds on all 3 sides, which are actually the junction between the skin, the epidermis, and the nail plate. So you have the lateral nail folds here and the proximal nail folds here. Cuticle is the skin covering, the thicker skin covering that junction, the base and the nail plate. And I think this would be a better picture where you can see the free edge of the nail here, of the nail plate here. The skin in the junction of that is called the hyponychium. Here you can see a half moon shaped structure, a whitish structure called the lunula, underneath which you have the, just proximal to it, you have the cuticle or the eponychium, which is actually covering the, it is actually the junction between the skin as well as the nail plate. And you can see the nail folds, the proximal nail folds here and the lateral nail folds on both sides. You have the nail bed here, which is just underneath the nail plate. And the nail matrix is a structure which you have beneath the cuticle, and it extends proximally. It is from the nail matrix that the nail grows, the nail plate grows, right? So I hope a little bit of idea about how we describe the structures of the nail, so that I'll be using them when I move forward. So in children, nail disorders, I thought I'd broadly classify in this manner into 7 types. Physiological alterations, inherited conditions, infections, inflammatory disorders, tumors, things that occur due to trauma, and also those due to systemic and inflammatory disorders. It's very important to know about the physiological alterations, physiological nail changes. It's mainly to counsel or reassure the parents, because often we do not know, we cannot differentiate what is physiological, what is pathological. In children, a lot of changes do occur physiologically, unlike in adults. So it's important to make the distinction. In newborns, koilonychia is quite common. What is koilonychia? We all know it is a flattening of the nail, a spoon-shaped curvature is seen. So we associate it typically with an iron deficiency syndrome or a Plummer-Vinson syndrome or all the endocrine abnormalities, but that's not always the case. In newborns, in 33% of cases, it is physiologically seen, it's normally seen, and it will resolve spontaneously. Similarly, onychoschizia or what you call as a split in the distal aspect of the nail plate. That is also commonly seen in newborns. Punctate leukonychia or white spots on the nail, absence of lunula. In 50% of the newborns, the semicircular thing may not be seen, which is seen towards the proximal aspect of the nail plate. Lunula may not be seen. Sometimes there can be pseudo-hypertrophy of the toenail, like an ingrown toenail. In fact, that is seen in almost 75% of the newborns. And that is because of the thin, the nail plate is thin in newborns, which is why, and that angulation is also somewhat triangular. So there's a force towards the lateral nail folds, which is why you see it physiologically, the ingrown toenail. So if the parents come to you with these complaints, it is enough just to reassure them and that these changes will remit spontaneously. Similarly, you can have pigmentation, boss lines in infants, which will remit. I'll take up one by one. So these changes are physiological. Leukonychia again, leukonychia means leuco means white, onychia means nails. It means white spots on the nails, which can be involving the entire nail, or it can involve only partially. And punctate leukonychia is what is frequently seen in newborns. It is because of the trauma during birth, trauma that occurs to the proximal nail matrix during birth. Transverse leukonychia, that is, it is not very common. If at all it occurs, it's seen in older children because of the restrictive, tight-fitting footwear. So this is punctate leukonychia. We simply need to reassure in most cases. Boss lines again, it is seen in newborns very commonly, and this is because of intrauterine distress, and they tend to grow out of this 14 weeks. We commonly associate boss nails with hand-foot-mouth disease, with infections, and with drugs, but it is not always the case. It can be seen physiologically as well. So these are ball lines. I'm sure you all know it. These are transverse creases that you see, usually towards the proximal aspect of the nail. And as you can actually get an idea, if it is due to a specific insult, you can get an idea of the timing of when the insult occurred by calculating the distance of the this Bose lines from the proximal nail fold. Chevron nails are again, it's called the herringbone nails as well. These are also physiologically seen. These are longitudinal ridges which converge towards the distal part. Again, they occur between 5 and 7 years of age, and they disappear with adulthood. Very, very commonly seen, I think, this particular thing. I think you might be seeing it more often than us. This is onychophagia, or nail biting. Quite common in children, and usually associated with an anxiety or some disordered state or obsessive compulsive disorder, and even otherwise as well. Usually starts by 3 to 4 years of age. What you generally see with this are the ragged cuticles. I don't know if you can appreciate it. The cuticles here look very ragged. That's a clue. And the nail plate would usually be shortened, obviously, and sometimes it can be irreversibly shortened as well. And you might also get hangnails. You can also get paronychia as well. Paronychia means inflammation of the nail folds. These changes can be seen in onychophagia, or nail biting in children. So treatment required there is just counseling to identify the cause and addressing that particular cause. Of course, so these were the physiological things. Now coming to the congenital, the things that you see at birth in the nail, and the inherited nail disorders. So again, we can classify this for better understanding into 4. Genetic disorders restricted to the nail, involving both nail and skin, involving nail, skin, and other organs, and also in which nail alone might be, it is not about the nail, but nail might or might not be involved. So there are certain disorders restricted to the nail. And these are non-syndromic congenital nail disorders, and it can be tracheonychia. Tracheonychia means a roughening of nail plate, like sandpaper appearance. It can involve all nails, all 10 fingernails and 10 toenails. So this is why we call it a 20-nail dystrophy. So this can occur congenitally. Koilonychia, like the spoon-shaped curvature, can occur. Leukonychia means white. Anonychia, absence of nails, can occur. So all the ones which I've mentioned here can all occur as an isolated change in the nails. There's also another disorder called congenital malalignment of the big toe nail, which may not be associated with something. Here what happens, you can see that the big toe nails they're oriented laterally. This is because of the difference in the orientation of the nail matrix, which is not aligned with the alignment of the distal phalanx. So that happens like this. And again, you need only to reassure the parents and the patient. Now there are genetic diseases which involve nail and the skin, and the prototype here would be epidermolysis bullosa. Epidermolysis bullosa, I'm sure you all know, it is a congenital blistering disorder where you have mutations within the specific skin proteins, usually in the basement membrane zone, affecting fragility. Causes fragility of skin. So nail changes are very common, but these are not specific. Nail changes with epidermolysis bullosa are not specific. They occur due to blistering and scarring of the nail matrix and the nail bed. So you get hemorrhagic onycholysis. The nail onycholysis means the nail plate is destroyed and it gets separated from the nail bed. And you can get bulle here in the periungual region, subungual region. So in EB simplex is the most superficial variant. You get mild changes in the form of dystrophic nails onychomedicis, and things like that. Whereas in junctional epidermolysis bullosa, which is deeper, you get anonychia, that is absence of nails, hemorrhagic paronychia, etc. Whereas you get mitten deformity of hands and total anonychia in the dystrophic and the more severe variant of epidermolysis bullosa. So these are, you can see hemorrhagic bullae and formation of granulation tissue erosions in the subungual area. So these are all very commonly seen in epidermolysis bullosa. So in fact, the presence of nail changes will also help you to distinguish sometimes between the level of split, so whether it's a very superficial split as in case of EB simplex, where the nail changes would be rather mild or absent. Now here we have genetic diseases where both skin as well as other organs are involved, nail as well as other organs are involved. So this is the most common thing. So nail patella syndrome. I will not go into the details of it, but severity of, usually it's present at birth, the nail changes, but severity decreases from thumb towards the little finger. That's a characteristic feature. And you see all these changes, but the characteristic, the hallmark of the disease is the triangular or V-shaped lunula, which can occur alone or in combination with the missing phalanx. Right, so this is the picture. You can see that lunula usually, which is a semicircular shaped thing, here it looks triangular. So that is pathognomonic of a nail patella syndrome. Of course, the other syndrome that even Dr. Nisha was talking about is a pachyonychia congenita. So here you have what? You have thickened nails. Pachy means thickened.
Hello, Dr. Soumya.
Can you hear me now? I think I got.
Yeah, your slide had frozen. Can you restart it?
Yeah. Right. Can you see it now? Did you hear about the pachyonychia congenita part? The
No,
hoof-like nail?
We had stopped till here. We were not able to listen to you.
Okay, so I'll carry on. Start from pachyonychia congenita, where you have very specific nail changes. Pachy means thickening of nails. So you're looking at thickening of nails here, and the specific changes are, one is early V-shaped thickening of the toenail, and also you should look at the distal 2/3 of the nail plate, which gets thickened, and there is an increased transverse curvature, and due to which the nail becomes lifted upwards. And there will be a material which is accumulated causing subungual hyperkeratosis, means beneath the nail plate, the subungual region, it is thickened, and this characteristically gives rise to a hoof nail kind of appearance. I'll show you the picture here. So this is the appearance. You can see the subungual hyperkeratosis, the increased transverse curvature, resulting in the nail to be lifted. Of course, there are other conditions where you get nail involvement, which are syndromic, like the ectodermal dysplasias. Here in pachyonychia congenita, you are seeing thickening, pachyonychia. Here you are seeing thinning, hypoplasia. Sometimes thickening can also occur. Of course, other changes like anonychia, that is absence of nail plate, micronychia, which means smaller nail plates, all these can be seen. Incontinentia pigmenti, porphyrias, in all these conditions, you can see nail changes. So here is a involvement of ectodermal dysplasia, nail involvement. Then, of course, these are genetic diseases in which nail may be involved, like the Darrier disease. I would only talk about Darrier disease, where you have the V-shaped nicking of the distal nails, as well as red and white bands. Also, tuberous sclerosis, Keenan's tumors, I guess you're all familiar with. So here you can see the typical V-shaped nicking in the distal creases in Darrier disease. Darrier disease is a disease where you have dirty white papules on the seborrheic areas, on the flexural areas. It's a genodermatosis actually. So you see this V-shaped nicking, and you also see the red and white longitudinal bands, streaks. So this is nothing but periungual fibro, Keenan's tumor seen in tuberous sclerosis. Of course, infections are not that common. Bacterial and viral infections are commoner in children. In fact, fungal infections are less common. But if you have certain predisposing factors like immunocompromised states, which would predispose towards them. So fingernail onychomycosis is usually caused by Candida albicans. Again, you see this with cutaneous candidiasis, in perinatal candidiasis, in immunosuppression. I think you all already know about chronic mucocutaneous candidiasis. It's a condition where you see recurrent infections of Candida albicans in nails. There's a genetic mutation there, and you see also endocrine and systemic disorders associated with it. So what do you see in the nail there? You see that nail involvement may not be present initially, it may follow after a few years. You actually see earlier chronic oral candidiasis and paronychia. Paronychia means inflammation of the folds with a bulbous distal phalanx. I think you can see it in this picture. And the nail plate gets thickened, it is crumbled and discolored. And the periungual areas are also inflamed. There will be paronychia, that is inflammation of the folds as well. This is the picture. So dermatophyte onychomycosis is less common, but you do see it with Trichophyton rubrum. Candida is different. Candida is non-dermatophyte. I think Dr. Anandan had already described it in detail, so I will not go into it, but this is how you confirm it, and you treatment is, again, I think it has already been taken up. So topical and systemic. In nails, we prefer cycloperoxin, amorolfin, and in systemic, yeah, like Sir said, we do prefer itraconazole. Even in children nowadays, we have data emerging that itraconazole can be used. So now paronychia. Paronychia is another fungal infection, or in acute paronychia is usually due to bacterial infections like Staphylococcus aureus and beta hemolytic streptococcus. And in children, it is common because you have predisposing factors like nail picking, nail biting, sucking, and all those things. So the affected digit as a whole would be swollen. And in chronic cases, again, that could be due to a fungal infection, or it could be due to chronic picking and other inflammatory disorders. So the treatment, again, acute paronychia, you treat it with either antibiotics or drainage. And in chronic cases, it's basically about removal of the precipitating factors, and you might need a topical antibiotic or steroid or antifungal as the cause. So this is the acute paronychia. You can see that the whole of nail fold, the proximal nail fold here is inflamed. Again, another common condition is herpetic whitlow following infection by herpes simplex virus type 1 and 2. And this is usually you see it after an oral herpes, herpes labialis. And again, here an acute paronychia picture might be there, and you would see erythematous vesicles, groups of vesicles with severe pain. It's of an acute onset. It is usually self-limiting, but recurrences can occur. So if you diagnose it early and you give oral antiviral drugs, it will really help. This is how it usually occurs. You see grouped vesicles, you see paronychia. Hand, foot, mouth disease. Again, you all see it, I think, day in and day out. The nail changes are very common. They include orangish discoloration of the nail, Bose lines, and onychomedesis. What is the difference between Bose lines and onychomedesis? Bose lines means just transverse creases are seen, which signifies an arrest in the nail plate arrest in the development of the nail plate. Whereas in onychomedesis, what happens is you get a full thickness split, and in fact, the nail sheds off from that particular area. It's seen in the proximal part of the nail plate. And here again, the fingernails are commonly more involved than the toenails, and temporary arrest in nail matrix, which is why it occurs. And usually you can reassure them that spontaneous recovery is the rule in 1 to 2 months. You need not treat the nail changes as such. So you can see here Buse lines, and here actual onychomedesis where full thickness split has occurred and shedding of the nail plate will occur. Now we go to inflammatory nail. How much time do I have? Inflammatory nail diseases. So psoriasis again, very rare in children, the nail involvement when compared to adults. So treatment, again, what you see generally, we know about is the pits that occur in psoriasis. Nail pitting is the most common finding, and it's more commonly seen on the fingernails. And how do you differentiate the pits? These are actually irregular pits, not very regular, and they are deeper. And other features like the oil, thickened nails. In psoriasis, again, there is thickening of nails. There'll be Bose lines or onycholysis. Oil drop sign is quite specific, which actually indicates that the nail plate has separated from the nail bed. Treatment of, I'll show you a picture. So here you can see, I guess, the pits which are very irregular. This is occurring in psoriasis nail. And again, the nail, you can see onycholysis happening here. Again, you can have thickening of nails, you can have subungual hyper. Again, here you can appreciate the onycholysis. Sometimes it is difficult to differentiate psoriasis from onychomycosis. So you always have to take a history regarding other skin lesions and take those points. And if in doubt, you have to go for a culture or a microscopy. So treatment again depends upon the severity and the pattern of involvement. We usually use high potent topical steroids, calcipotriene or tazarotene. If limited nail involvement, we also try intralesional triamcinolone, nail matricial injection, or you can even give intralesional methotrexate. So systemically, if you have all nails involved, TNF-alpha, biologics like TNF-alpha really works well, but it is not often used. You can't really convince when you have isolated nail involvement to give a systemic drug like that. We also give cyclosporin, whose response is better than methotrexate and phototherapy. So nail changes in psoriasis, lichen planus is again another condition where you have a lot of nail involvement happening. So here what happens is there is nail plate thinning. In psoriasis you had again thickening, here you have thinning. Tracheonychia might occur. You see longitudinal ridging as well. Usually in adults you see a lot of pterygium formation, a wing-like structure is formed, which is not as common in children. So this nail lichen planus can have 3 different presentations actually, which is the typical nail lichen planus. Then you get the 20 nailless dystrophy or tracheonychia, where all the nails are involved, and also idiopathic atrophy of the nails, which can be quite rapidly progressing. The nails really atrophy fast. In fact, that's a presentation that is more common in Indian children, in dark-skinned races. So they also respond very well to high potent topical steroids. You can try a 12-week course. Also systemic steroids, methotrexate, phototherapy, acitretin, these are all treatment options. So this is a typical tracheonychia. There is 20 nail dystrophy. You can see that all the nails are involved. Similarly, the nail plate looks roughened. It looks like it's got a sandpaper-like appearance. Thinning of the nail is the rule in nail lichen planus, unlike in psoriasis. Alopecia areata, again, I think sir had already talked about it. You get a geometric regular pitting, like a scotch, we call it the scotch plate appearance. That is the hallmark here. So you can see like it's arranged like bands, you know. So that's in alopecia areata. 20 nail dystrophy, we are again, so this is not it's only a morphological entity. This is not a specific diagnosis. So this morphological entity is characterized by longitudinal ridging, roughness of the nail plate, and a specific appearance, sandpaper-like appearance. So most commonly in children, it is due to alopecia areata, psoriasis, lichen planus, and so forth. So you usually treat it with emollients, steroids and retinoids may also be used, but most importantly, you have to identify if there's an underlying disease and treat that particular disease. Tumors of the nails, this is the 5th one, and warts are not exactly tumors, but very common, they appear like tumors. So you actually, in children, it's quite common. Why? Because of the, again, this nail biting, picking. I'm sure you all might be, you know, getting cases where children are. So usually we tell the children that it's a self-limiting, it can spontaneously resolve, but you need to treat to avoid spreading of the infection. What will, you know, it can spread. So what we need to do is, generally as in OP, if you can't do a cryotherapy or do a cautery, the restrictive modalities, you can prescribe salicylic acid or lactic acid based creams, paints, etc. If you have actual nail involvement, intralesional bleomycin, it's a very, very effective for periungual and subungual warts without actually taking off, without excising the nail plate. It is easier, the intralesional bleomycin in our experience has given excellent results in periungual and subungual warts, which are more difficult to treat than the normal warts. So you can here see the subungual, periungual warts, which is difficult to treat at times. Of course, parents might come to you with worries about longitudinal streaks. They might be worried about melanoma occurring in nails in children, but actually it's quite uncommon. Melanoma is extremely rare in children. You see this longitudinal melanonychia is actually a longitudinal pigment band of even width. It will be even width. It will not be irregular. And it's usually a stable melanocytic proliferation. So nevi and lentigo are also often seen, and it can be present at birth. And sometimes you might also see the pseudo-Hutchison sign. When you actually have to be careful is if you see increasing width or darkening of the lesion, If you see irregularities in the pigmentation or you see nail dystrophy associated with these pigmented bands, then you have to go for a biopsy. Otherwise, it is enough to reassure the parents. So this is again, you can see this is longitudinal melanonychia, but here there is the Hutchison sign. Hutchison sign means there is involvement of the proximal nail fold as well. But this is a pseudo Hutchison sign. Usually Hutchison sign should prompt us to rule out a melanoma, but in certain cases it can also occur without it. Another tumor common is subungual exostosis, which is seen, it's actually an osteochondral tumor of the distal phalanx of fingers, mainly the great toe. It actually presents like a fixed subungual growth and it can get ulcerated. Treatment is excision. It can mimic a wart. This is the subungual exostosis seen in toenails. Infantile digital fibromatosis. This is also another tumor, and it's usually present at first year of life. It's quite common, so I don't think I'll go into details. So, but just for your information, it can have a presentation like this. Then again, the traumatic nail disorders, quite common: onychophagia, finger sucking, nail picking. Habit tick deformity. I want to spend a minute here. Habit tick deformity is not uncommon. In fact, you see it in adults also. In fact, I had a pediatrician coming to me with the typical presentation. Here it is due to habitual external trauma. You constantly push the cuticle at the proximal nail fold. Some people have a tendency to do that. So constant doing that will result in a peculiar deformity, which results in a series of transverse lines from the proximal to distal end. And it's like a median canalicular dystrophy. This is quite characteristic. I don't know if you can appreciate it. Because of this constant pushing from the proximal to the distal end, you can see this series of changes. This is due to habit tick deformity. If you identify that, you are always able to reassure the patient and tell them that this is the root cause for this. So again, something is, yes, juvenile ingrown toenails. We discussed that in neonates, it's quite common, but in teenagers and adolescents, you might see this because of lateral ingrowth of the nail folds and and that could be because of the tight footwear, the overt sweating, and the habit of not trimming your nails properly. You have to trim them in a straight line, the free edge. If you do it inward, that could also predispose towards overt growth of the nail folds laterally. So this leads to inflammation.
Excuse me, Dr. Soumya.
Yes.
Actually, we are past time. Could you please
I'll just stop right there. Yeah. Just a minute more. So that was about the tumors. Now the last thing is nail disorders and systemic inflammation. So I'm just going to show you these charts because I cannot go systemic diseases and drugs. So I cannot go into details of each and every one. So this is for your reference. Certain drugs like isotretinoin, doxycycline, pseudovidin, these can cause changes. As you can see, isotretinoin can cause onycholysis, pseudovidin and doxorubicin can cause melanonychia. And so I've summarized them here. And also nutritional deficiencies in certain cases can present with nail changes. I'm sure you all know, I've just summarized them here. So that's it. I hope you got something out of some.
Thank you, Dr. Soumya. I should say that you had something for postgraduates, academicians, as well as the practicing pediatricians. It was sort of complete. All the best to you.
Thank you, ma'am, again for the lovely words. I'll stop sharing.
I would like to invite Dr. Arun Mahmood to invite the next chairperson.
So that was a good topic on the nail changes. Now we are moving on to the next session, skin and soft tissue infections. I would like to introduce the next moderator for the session, Dr. Madhusudanan sir. Sir is a senior most pediatrician and the president of IAP Wynand branch. And moreover, rather than that, he's our dear Vishnu's father-in-law. And coming to academics, he was the first rank holder in the Trivandrum Medical College MBBS exam. And I would like to welcome Madhusudanan sir to introduce our next speaker for the session. Thank you.
Madhusudanan sir, kindly unmute, sir.
Yes.
Audible.
Am I
Sir.
audible?
Yes, sir. Yes, sir.
Okay. Now, good morning to all. May I extend my sincere thanks to the organizers, Dr. Jijo and Dr. Binikutan, for making me to chair this very important session. The doyen of the hour is none other than our Secretary General, Dr. Ramesh. Secretary General, to narrate his achievements, even it may be lengthier than the speech itself. He is the fellow of IAP and he is the Secretary General for the past 2 years. He is a diplomat in Pediatric Environmental Health, International Pediatric Association. He is the member of Environmental Health Technical Advisory Group of IPA. He is the chief editor of Enrich from 2011 to 2016, from 2011 to 2015. He is the editor of many textbooks, journals, and authored chapters in textbooks. He is the founder of IAP clinical programs. Central IAP member 2011, 2012, and 2015 and 2016. He is the national president of Environment and Child Health Group of Central IAP 2017 to 2018. He is the president of NNF Kerala 2015 and 2016. Secretary IAP Kerala. Secretary IAP Kerala 2000 and HOD of Pediatrics in Apollo Adelaide Hospital, Cochin. Add to his name for the post of National President of IAP. We assure Dr. Ramesh that we all are behind you, and I request all the members and participants from Kerala and outside Kerala to canvass and also to vote for him to give him a smashing victory. With these few words of introduction, I am presenting the doyen of the day, Dr. Ramesh. He will speak on soft tissue infections and soft tissue infections, bacterial flora revisited. Now over to Dr. Ramesh.
Respected Chairperson, Dr. Madhusudanan, my respected teachers on the platform, Dr. Girija, Dr. Lada, Dr. Sukumaran, and all others, and my seniors from the IAP family, my great friends from across the country, and my dears in IAP Kerala. Thanks, dear Madhusudanan sir, for that sweet introduction. And I'm quite privileged to be on this August platform with the doyens of dermatology, like Dr. Vijay Bhaskar, Dr. Anandan, Dr. Soumya, and Dr. Jarina, and all others to follow, and Jagamas are around. And I'm quite happy that IAP Pathanamthitta is hosting this meeting, which has come out in a big way. So friends, let me start moving to my presentation for the day. Is it okay, Jijo? Fine.
Visible,
okay.
Sir. Visible.
Okay, fine. Thank you. So, friends, my session will be on something which is a little different from except not purely dermatology. I may be going a little deeper into the skin and soft tissue also, and maybe giving some wild thoughts to you on the bacterial infections and their rational antibiotics or optimal antibiotics on the particular scenarios. Having been in the thick of the antimicrobial stewardship, it's very important for all of us to know or localize the lesion and treat it optimally. As you know, dermatological lesions are many a time treated with a package, not an average pediatrician's point, because we don't ponder much over it, and we don't take our time to localize or focus the lesion. Maybe even with a combination, it may respond, but still it's always worthy to identify the lesion and go about it in a very systematic manner. So let's have it is a basics only, and we'll be revisiting the skin and soft tissue infections as well as how common or how important are the bacterial flora. Friends, the skin infections are basically fungal infections have been discussed here. The bacterial infections are basically impetigo, folliculitis, pharyngeal, carbuncle, cellulitis, eczema, pyoderma, and blister. These are the important ones, which are the common ones, and we'll be discussing one by one. And just to have a recap, the fungal and parasitic infections have been discussed already here. Tinea, all the categories of tinea, as well as the pediculosis and the scabies, and the viral infections, mostly simplex, zoster, as well as molluscum. So we'll be focusing most only on the bacterial infections. And just have a recap on the skin anatomy. This is very important to identify the layer of involvement. As you all are very sure, the epidermis has got a stratum corneum layer at the top and the stratum basal layer, germinativum. And then we have got the pilosebaceous apparatus, which is very important. The hair shaft. This is one important concern for the focus for the bacterial infections. The hair shaft is here. You can see the sebaceous gland, the eccrine gland, and this contributes what is called as a pilosebaceous apparatus. Down that epidermis, you have got the dermis, and still down, you have got the subcutaneous tissue, and then down the connective tissue or the fascia. So this I will be discussing the epidermis, dermis, subcutaneous tissue, and the fascia, the infections concerning them. And this is one important slide which I would like you to recollect, and which I may be putting it time and again for you to recap. So then, friends, we'll be discussing on the infections of the epidermis, like the impetigo and the erysipelas. Then the infections of the pilosebaceous apparatus, like folliculitis, pharyngals, and carbuncles, what all concerned with the hair follicle. Then the infections of the subcutaneous tissue, like cellulitis and abscess. And still further down, we may be having a word about necrotizing fasciitis. Let's have a look at this picture. See what exactly is around. You've got a child here right now, maybe an infant with some multiple vesicular lesions. I think a little amount of crusting is also there. Multiple vesicular lesions on an erythematous base. This is very important, on an erythematous base. And with some amount of crusting is also there. So quite easy. You always identify this lesion in OPD. You put it as the impetigo. So impetigos are basically multiple vesicular lesions on an erythematous base, which crust over a period of time. One. Second is usually present on the exposed parts of the body, like the face, most common as you see here, then the extremities, as well as in the scalp. These are the three common sites. Third is usually can be due to in a primary infection, de novo, or it can come in areas of where there's a ruptured skin barrier is there, like as it occurs in atopic dermatitis or as it occurs in a scabies infection. And fourth, there are two types called as the impetigo contagiosa and bullous impetigo. Friends, this differentiation is very important in the sense the treatment may vary wide. Impetigo contagiosa basically is caused by the group-A beta hemolytic streptococcus as well as Staph aureus. It occurs mostly in the face and exposed areas, vesicles and pustules, bright gold custard lesions, and source of acquisition is from the skin only. In the topical, directly from the skin, maybe toward the poor hygiene and systemic symptoms are absent. Whereas you can see they have a comparison here. Bullous impetigo, mostly the Staph, it's a more virulent strain, is mostly in the abdomen and pectoral areas. Classic bullae are the usual features, and the source of acquisition is important. It can not only from the normal skin, it can be from the nasopharyngeal carriages or even from the nostrils. So the portal infantry can be the nose or the normal skin. So systemic symptoms are present. So this differentiation is important in the management. In the sense when we go again, you can see here the crusted lesions. So this is actually a impetigo contagiosa, and here what you can see is mostly a flaccid bullae. This is mostly a bullous impetigo. So this differentiation is important. So how will you treat? The treatment is basically topical treatment. This is enough for any, especially in impetigo contagiosa. Mupirocin 2% 2 times a day for 7 to 10 days is sufficient to treat any infection with a impetigo contagiosa. You don't have to go for a systemic antibiotic. Bactericidal is superior to even oral erythromycin. Alternative choices are fusidic acid 2%, but then the disadvantage is you may have to use 2 to 5 times a day. Still, you have got choices like nadifloxacin and rictapamilin. The main when the advantage of mupirocin is mainly is bactericidal, and it can be even given once a day is maybe sufficient. Systemic antibiotics are required if there are widespread involvement where the multiple non-contiguous sites are involved. Maybe systemic antibiotics are involvement. If there is a deeper involvement is there, you may have to have systemic antibiotics. Otherwise, mupirocin will suffice in almost 99% of the scenarios. And it is important to make clear here that the treatment does not prevent a post-streptococcal glomerulonephritis, because the PS gene is mostly due to the molecular mimicry arising out of the streptococcal antigens. So treatment may not prevent it. Having said about the impetigo and the infection of the epidermis, now let's have a look at the infection of the pilosebaceous at the hair follicle is here. So this goes from the hair shaft is here, it goes down into the dermis, deep rooted in the dermis, even up to the subcutaneous tissue. So let's have that look at the infection of the folliculitis, pharyngeal, and the carbuncle. Folliculitis, pharyngeal, carbuncle folliculitis is a single hair follicles involved and perifollicular structures are involved, and it involves only the superficial epidermis, the hair shaft, the base of the hair shaft as well as only is involved. Whereas in a pharyngeal, it goes into the dermis. It is just a perifollicular staphylococcal abscess. It is acute, round, tender, circumscribed lesion, and there will be a central suppuration at the top. Whereas a carbuncle is a conglomerate of multiple coalescing pharyngles. 2 or 3 pharyngles will be around, and that will be coalescing together to form a carbuncle. The infection of a pilosebaceous unit. Let's have some pics on this. So this is what you see, a circumscribed lesion, acute lesion, and it is around a perifollicular area. It's around a follicle. So this is actually a folliculitis, or it can be even, so you can still see here a folliculitis, as well as sometimes it can, since the abscess is here, it can be a pharyngeal. So it's a pharyngeal, and this is actually the ruptured pharyngeal. So pharyngeal, this is a pharyngeal. And what you see here is a multiple pharyngles coalescing into what you say as a carbuncle. So this is the carbuncle. Carbuncles are usually seen in the nape of the neck or even the buttocks or other area, flexural areas. So carbuncle is the coalescing pharyngles are usually termed as carbuncles. Carbuncle or pharyngeal, the common or causative organism is the staph aureus. It spreads by physical contact, and the important feature here is there will be a central necrosis and rupture, discharging purulent material and necrotic debris. And the common sites, as I mentioned earlier, are the nape of the neck, axilla, and the buttocks. So we have seen the folliculitis, the hair shaft is involved, a single lesion, pharyngeal, there is a perifollicular abscess there, and multiple pharyngles coalescing to form a carbuncle. That much is about the infections of the hair follicle and the pilosebaceous unit. Now let's go a little deep and see what exactly are the infections of the subcutaneous tissue or the loose connective tissue. We have got a cellulitis and abscess coming up. So this is a 7-year-old child who had chickenpox for 5 days. Of course, a scenario of chickenpox mostly lead to poor personal hygiene or no bathing for some time, and that may lead to some painful blisters and redness on the back or even the posterior part of the thigh. So you can see some lesions here, which is that the skin is not much involved, but of course you can have a look that the underlying soft tissue may be involved here. So this is a situation of a cellulitis. Cellulitis are infection and inflammation of the loose connective tissue, limited involvement of the dermis, and relative sparing in the epidermis. The skin as such may be looking normal, but when you have a feel, you may see that it is a very tender lesion. There is a involvement of the deeper tissues. And when it comes from a staphylococcus, it is more localized and suppurate. And when it comes from a streptococcus pyogenes, it's usually associated with lymphangitis. It tends to spread more rapidly, and whereas in a staphylococcus lesion, mostly we'll have regional adenopathy. Constitutional signs are more with staph, as you know, and streptococcus, the constitutional signs are rare, and regional adenopathy is uncommon. So relative sparing of the epidermis, involvement of the dermis, and infection and inflammation of the loose connective tissue, you are at cellulitis. Cellulitis bugs in immunocompetent, that the bugs may differ in scenarios of an immunocompetent child and an immunocompromised child. And immunocompetent individuals or possible organisms are the most common one, the group A beta hemolytic streptococcus, as you said, noticed earlier. Lymphangitis can be there. It tends to spread rapidly. Staph aureus, as we noted earlier, is more localized and tends to separate. These are the two common organisms. Of course, we can have Haemophilus influenza type B or pneumococcal, as in the situation scenario of a periorbital cellulitis and sinusitis or an otitis media. You must be wary of a hip coming up or a pneumococcal coming up into the picture. So that's about the immunocompetent individuals. And again, we have got the neonate. If it's a neonate, it can be a group B streptococcus or an E. coli coming up. What about the scenario of an immunocompromised individual? Immunocompromised individual cellulitis bugs may be totally little scary looking organisms could be there, like the gram negatives, Pseudomonas, Proteus, Serratia, and Enterobacter. You can have the Cryptococcus neoforms and seen in dialysis patients, and you can have in nephrotic syndrome settings, you can have the E. coli. So this is the, so as the individual setting, the organisms may vary. Immunocompetent and immunocompromised are widely varying organisms as the causative bugs. Moving ahead, you can see what exactly is a 2-year-old child with swelling, redness, and pain in the breast. You can see a warm, tender, warm swelling here, a fluctuant swelling, all features of inflammation like rubor, calor, dolor, tumor. Redness is there, pain is there, swelling is there, and warmth is there. So this is a classical abscess. All features of inflammation are there. And abscess is pus within the dermis. A more serious form of cellulitis where it is more localized and well defined is the constitution of an abscess. Pus within the dermis and the deeper tissues, we call it as an abscess. And organisms in an abscess sitting to be raising our eyebrows, mostly could be polymicrobial, in the sense it can have organisms from the region of the normal, that regional skin flora can be there, adjacent mucous membranes, organisms can be there. So in the setting of an abscess is mostly polymicrobial. And the treatment of abscess, most important, or the first thing is moist heat and incision and drainage. It's more important because as we have learned in surgery, basically wherever there is pus, the drainage is most important. But still, we may have to, the antibiotics are required. And this particular child was started on cefixime plus clavulanic acid. So is the choice of antibiotic correct? Was it? Cefixime is a third generation cephalosporin, and it just got poor activity against gram-positive organisms. So coming down from first generation to second generation to third generation cephalosporins, the gram-positive coverage is the maximum in first generation and minimum in third generation. So the positive bugs here being mainly the Streptococcus pyogenes as well as Staphylococcus, we need to focus more on agents which can act against the gram-positive organisms, and in that situation, cefixime fails us. So cefixime is not at all a choice for this particular scenario. Then what is the choice ahead? No, as we need to cover Staph aureus. So what is the choice? Ampicillin or amoxicillin, is it okay? Ampicillin, as you know, ampicillin, 60% of the isolates of Staph aureus will be resistant to ampicillin. So ampicillin cannot be an appropriate choice. Amoxicillin can be still, amoxicillin also has a lot of strains, or ESBL producing strains of Streptococcus. So amoxicillin cannot be an optimal choice. Ahead, cloxacillin. Cloxacillin, of course, is very good for Staphylococcus, excellent organ, but cloxacillin is very poor activity against the Streptococcus pyogenes. So cloxacillin, and more than that, the oral formulations of cloxacillin are also not that easily available. So cloxacillin with a poor activity against Streptococcus pyogenes is not an ideal antibiotic here. Okay, ampicillin plus cloxacillin, how does it work? We have seen that ampicillin is not effective against the Staph aureus. Ampicillin, adding ampicillin to cloxacillin will increase the side effects only, because we need to give 100 mg per kg of ampicillin and 100 mg per kg of cloxacillin. That means 200 milligram per kilogram body weight. An absolutely unfriendly situation to the gastrointestinal tract, as well as the coverage may be quite inferior. So ampicillin plus cloxacillin still is not the choice. Ceftriaxone, is it okay? We know that ceftriaxone is a first generation cephalosporin, and being a first generation cephalosporin with a good number of oral formulations, easy to, highly palatable, very cheap drug. Ceftriaxone has got very good activity against Staph aureus and Streptococcus pyogenes. So that brings ceftriaxone as our preferred choice, or our favorite choice in a setting of any setting of a skin and soft tissue infection. So ceftriaxone is the first choice. Ceftriaxone plus clavulanic acid, is it required? This is just a marketing gimmick only, because to increase to escape the clutches of the drug controller, they will add clavulanic acid. Ceftriaxone by itself is sensitive to the gram-positive, the Staph aureus and reagents, and the beta-lactamase producing strains. Ceftriaxone is resistant to them. So when it is ceftriaxone by itself is resistant to the beta-lactamase producing strains of Staph aureus, why do you want to add clavulanic acid? So absolutely, there is no rationale for adding clavulanic acid to ceftriaxone in any setting. It is just an irrational combination. Ceftriaxone is our choice right now. Comoxiclav, yes, comoxiclav is effective, but being a broad-spectrum antibiotic, comoxiclav will have destroys the aerobic and anaerobic as well as the gram-negative flora of the gut, and that will lead on to resistant colonization of the gut by resistant organisms. So why do you want to give such a high broad-spectrum antibiotic when you have got ceftriaxone is there, when you have got other formulations is there? So our choice is cephalosporins are preferred. First generation, especially ceftriaxone. Ceftriaxone is the choice. Others, if there is some issue with ceftriaxone, you can go for cloxacillin, you can go for amoxiclav or even erythromycin. But resistance to macrolides is on the rise. That's why yesterday years erythromycin was the choice and was only used. Now they go for mostly the ceftriaxone. If there's a systemic toxicity, we go for injection cefazolin or coamoxiclav. So then there is a MSSA. Suppose there is a Staph aureus, there can be two strains. I will just have an intake on this here. Where there's a methicillin sensitive Staph aureus, cloxacillin should be used, and you have to add clindamycin to reduce the toxin production by MSSA. So methicillin sensitive Staph aureus, cloxacillin alone. If you feel that the child is toxic, add clindamycin. Clindamycin will reduce the toxin production. What about an MRSA? If there is a methicillin resistant Staph aureus, definitely you go for vancomycin, which is effective in such a setting, and add on linezolid. Linezolid reduces the toxin production by methicillin MRSA. So MSSA, methicillin sensitive Staph aureus, clos plus clinda, methicillin resistant Staph aureus, vancomycin plus linezolid. Clindamycin, whenever you are using inducible resistance D-test duplicate, which is a surrogate marker for clindamycin, and if it is positive, you may have to change from clindamycin to linezolid. But a word about linezolid here. Linezolid being bacteriostatic in nature may not be effective when high bacterial loads are present. So many intensivists, they don't prefer linezolid as first shot. A word about community acquired MRSA here. It is uncommon when you talk. MRSA is mostly what about we used to talk about hospital acquired MRSA, but now that the community acquired MRSA is in vogue right now, it differs from HA MRSA in the sense that the antibiotic sensitivity patterns are very easily treatable with the cotrimoxazole, clindamycin, vancomycin. This is just for an appraisal. It thought to have evolved separately in the community based on genetic differences. So all MRSAs are not HA MRSA hospital acquired right now. There can be a CA MRSA also in picture. So again, going down, we have got something called a necrotizing fasciitis. We go into the fascia. Necrotizing fasciitis is a subcutaneous infection, deep layers of the superficial facial layer involved, and mostly the organisms are polymicrobial. So it's called as a flesh-eating bacteria or the melanine ulcer. Distinguishing feature NSTI from cellulitis is basically the wooden hard feel of the subcutaneous tissue. If it is a cellulitis or if it's an erysipelas, the tissue, the skin may be yielding or palpable. Here it's a wooden hard feel, and this is important that edema extends beyond the margin of erythema. If you see a margin of erythema and edema will extend beyond that, the wooden hard feel will be beyond that. So that will raise, make your hair stand up, because this is a little difficult situation. You are in for something, okay, severe necrotizing fasciitis, and systemic toxicity is affected, always there. Surgical debridement is required, and antibiotics of choice here are ceftriaxone to cover the gram-negative organisms, vancomycin to cover the Staph aureus, especially the methicillin-resistant Staph aureus, clindamycin or linezolid to reduce the toxin production. So we need to have a combination of ceftriaxone plus vancomycin plus clinda bar linezolid in such settings. Friends, this is a 6-month-old child with a fever and multiple bullous lesions the last 24 hours. You can see in the last 24 hours, multiple lesions are evolved. This is an infant. So your take is straight away there. This is a Staphylococcus scalded skin syndrome. So Staphylococcus scalded skin syndrome, rectal disease caused by exfoliated exotoxin produced by staph, tender erythematous lesions in the circumorificial and faccial area. This is important. Around the orifices, around the mouth, around the anus and other orifices, and in the axilla and the inguinal fold. It's important that the toxins here are epidermolytic toxins. They produce the split by binding and cleaving to desmoglein 1. And what if you see as something called as a Niskolsky skin? Nichols-Kissine, I can tell you that the stratum germinativum here, the epidermis will shear away from the dermis. This is a gentle shearing force is applied over the epidermis, and gentle by that gentle shearing force, you can there is a cleavage will happen. And how it can happen is something like you can hold. How you can demonstrate this is by the eraser of a pencil. If you can hold it and place it over the roof of the lesion and roll it between your the fingers, you can see the lesion will open up. So this is the easy way of demonstrating a Nichols-Kissine rather than pushing with your hands, which the parents may not be accepting. So use a eraser of a pencil and use demonstrate the Nichols-Kissine. So scalded skin syndrome, usually febrile, rapidly progress to shock, and it's seen in infants only just because the immature renal function of the infants is inadequate to handle the toxin production by the staff. When an older child, the renal system is mature enough to handle the cumulative toxin production, and SSS is rarely to happen in an older child. Blood cultures are usually negative. This is just because it is toxemia which produces the symptoms and there is no bacteremia. It is the exfoliative toxin by the Staphylococcus which produces the symptoms and which produces the results. So hence, blood cultures are usually negative. Application of an emollient is enough. Plus, topical antibiotics are unnecessary. Most important, first generation cephalosporins or cloxacillin, Sabatroxil or cloxacillin, unless MRSA is suspected. If MRSA is there, you may have to go for vancomycin plus clindamycin may be useful. If there is a severe toxin looking child, you can add clindamycin to reduce the bacterial toxin synthesis. So culture negative, application of emollient with the first generation cephalosporin is sufficient to treat a Staphylococcus aureus skin syndrome. Just last 2-3 slides. Ecthyma, just for the completion sake, I am adding ecthyma. It resembles non-bullous impetigo in the onset, usually group A beta-hemosyl streptococcus, and usually they form adherent crust over the lesions. Pyoderma vegetans, this is just another lesion with just a blastomycosis like pyoderma, Staph aureus and DABHS, blistering distal dactylitis. These are 3 lesions I have added just to complete the cutaneous bacterial infections. So prevention of recurrent pyoderma, just 2 slides on this. Good personal hygiene, improve environmental conditions, avoid sharing of garments or towels, evaluate contacts. This happens in a hostel or in a daycare setting or even in the daycares or nurseries, other kindergarten schools, everywhere this is applicable. So underlying skin diseases like atopic dermatitis is treated. So many a time we get children with recurrent pyodermas. So very important is you can apply mupirocin to the traumatized skin and antibacterial agents, especially mupirocin, you apply inside the nose, nearest the nostrils, axilla or perianal area 3 times a day for 5 days, every month into 3 months. This is very important because as I have learned 5-6 years back, this information as I am having this, I have treated many patients with recurrent pyoderma and none of them have had a recurrence thereafter. Mupirocin, because you have to, the portal of entry is the nostrils. So the portal of entry should be blocked, maybe sufficiently for 5 days for 3 months. Applying mupirocin, that will prevent the recurrent pyodermas. Even systemic antibiotics occasionally can be used if the mupirocin, local mupirocin is not effective. Clindamycin attain adequate levels in nasal secretions. And older children, 150 milligram per day orally into 3 months, clindamycin is okay, but still it is a rather inferior choice and many parents will not accept this choice. So mupirocin 3 times a day for 5 days, every month into 3 months will be sufficient to prevent the current pyodermas. So friends, my carry home takes for the day, bacterial skin and soft tissue organisms are common. Commonest organisms are 2. You have to remember only 2 organisms, Streptococcus pyogenes and Staphylococcus aureus. Topical therapy with mupirocin is sufficient. Once a day for 7 days will clear most of the impetigos as well as the topical superficial lesions. If you are going for an oral therapy, cephalexin or cefadroxil are the choices. It is there do wonders, and a therapy with 50 rupees for 5 days is sufficient enough to treat any skin lesion rather than going for a higher antibiotic. Parenteral, at any time, if you are bound to give, you go for first generation cephalosporin like a cefazolin. Still, comoxiclav and clindamycin are alternate choices. We need to address Streptococcus pyogenes and Staphylococcus aureus in these situations. Hence, we go for cefazolin or comoxiclav, and toxin production always has to be tackled. Hence, clindamycin or linezolidone can be added. Higher agents like vancomycin should not be used unless MRSA is suspected. Recurrent pyodermas can be prevented by appropriate use of mupirocin. So I believe, friends, I have given an overview of the skin and soft tissue infections right from the superficial dermis to the necrotizing fasciitis, how best in this era of antimicrobial survivorship, as I mentioned earlier, rational antibiotic use is very important, and identifying the layer of involvement of in a skin lesion is half the job is done, and the organisms are very well in front of you, and you can treat simple antibiotics to treat these lesions. Thank you very much, my dear friends, for the patient listening, and thanks by all my dears in the IAP platform for being with us in the dermatology session for the day. Thank you very much, and thanks Dermatology Chapter and IAP Pathanamthitta for the opportunity to be with all this august audience. Thank you.
Thank you, Dr. Yes.
Jijo, please start with the discussion part.
Okay. Thank you, sir. Thank you for the excellent talk. Now we are going back to the discussion. We'll start off with the first speaker. For the first speaker, I invite Dr. Girja Mohan to answer the question. There have been a lot of questions on the chat box, and we'll be taking up the important questions. Many of them have already been answered by sir. Over to you, Girja, ma'am. Ma'am, kindly unmute, ma'am.
Am I audible?
Audible.
Yeah.
Most of the questions have been answered by you in the chat box, but still, what is the shampoo of choice for infants? You have mentioned about Spoo shampoo. Can you elaborate on that, sir?
Spoo shampoo mainly we recommend for a person with cradle cap or having any seborrheic dermatitis. It will be a better shampoo. But any baby shampoo, for that matter, any baby shampoo is safe for all the babies. The only thing is it should be colorless and it should be fragranceless. So no fragrance, no color. That is the best shampoo for any infants.
So Spoo shampoo is the trade name.
Yeah, it is the trade name that can be used for cradle cap or you can use it for seborrheic dermatitis.
Then there are so many questions about hair loss. What is the preferable hair oil for hair loss? Do you recommend any specific hair oils?
No, maybe if I start a company, then I may recommend that particular oil. So actually, that's what I said, that most of the oils may not help. There are a few studies are available which shows that even the thickness may get increased, that's all. But I don't think any hair oil, you can, whatever hair oil you want, you can use it, or even if you don't use it, doesn't matter.
Then you have mentioned about why leprosy does not affect scalp. You have answered that leprosy bacilli will not survive in warm areas like scalp, axilla, and groin. Very well answered, sir. Then another question is treatment of androgenic alopecia in adolescents, which is a very common complaint of adolescents.
So normally we say androgenetic alopecia in adolescent age group, but there are studies which have showed that even at 7 years of age, the androgenetic alopecia may start, particularly if they're genetically prone, the mother side, father side, they carry the gene, then it can occur. But minoxidil, we recommend only above 18 years of age group. So you can go for Procapil. Procapil is a drug which you can apply twice daily, 1 ml, twice daily you can apply. Definitely that will retain the hair that is present. And it has to be lifelong. So once they cross around 18 years, you can switch back to minoxidil 5%. Then you can have to use it lifelong. Or once you get married, maybe if you're not interested in your hair, you can stop it also.
Then what about the features of alopecia in SLE? That was one question.
Yeah. SLE, you can have like tangled hair, again, like trichotillomania, you may have short and long hairs that may be present. So here again, basically you have to treat the cause. Try to bring the SLE under control, the hair will definitely. It is uncombed hair. We normally call it as an uncombed hair, like hair you can get in there.
Then, sir, many questions regarding premature graying, role of biotin, trade name of melatonin solution.
So it is melitane actually. I was mentioning melitane that is available. As I told you, like if you have premature graying, biotin is one vitamin that is required for the hair, but that is not going to help in premature graying. One. Second, calcium pantothenate. There are some studies which have shown that calcium pantothenate will help. PABA, para-amino benzoic acid, will help, and the trace elements and minerals that can be used. And melitane, 5% and 1% solutions are available, which you can apply in the night. In the morning, you can apply in the night and leave it off. This will help in the blackening of the gray hair. But you have to use it up to 25 years of age. You can use it. After that, it may not work also.
So is it that effective, sir, according to your
No, madam.
experience?
No, I mean, I have seen good improvement in some people. For some people, that is not much of improvement. So maybe it is again individual based. Definitely, it shows some improvement at least.
Then regarding treatment of hypertrichosis, I think you have mentioned regarding the laser treatment and all.
Hypertrichosis and hirsutism, you have to remember, hypertrichosis occurs in non-androgen dependent areas.
Yeah.
It can be localized, it can be generalized, it can be congenital and all. Whereas hirsutism occurs only in the androgen based areas like mush, chin, in those areas which is there. So for this hair growth can be either congenital or acquired, or it can be, I mean, if it is localized to one area like fontaine hair, if you see, it's an hypertrichosis. Again, you have to see for the underlying abnormalities. But if you want to remove the hair, the best for hirsutism, you have to do the basic investigations to find out whether there are any underlying causes of it. And for removal of hair, the best solution will be lasers. All other epilatory methods, shaving, they may help you only temporarily, but lasers like diode laser and your NDAG lasers, they may help in complete resolution of the hair.
Sir, in the lighter vein, one more question: why most of the dermatologists are having thick hair?
I think this is somebody who is known to me. I think you have asked. I think I have just covered my hair. I have an androgenetic alopecia. It is not that we have thick hair or we are not telling any secrets outside. It is genetically. If you have androgenetic alopecia, you will get it. Or if you have good hair, you will get it. That's all.
Less
Amal Raj asked this question. He has got a good amount as a pediatrician.
Thank you, sir. Thank you for the quick response.
Thank you.
Thank you, ma'am and sir. Now we'll move on to Lata madam for the next session talk questions for Anandan sir.
So there are a few questions, and one is
Yes,
that
madam.
sharing the nail cutter will it transmit the fungal infections?
Madam, can you come again? I'm not able to follow your question.
Sharing the nail cutter. If
Nail
you share
cutter.
nail cutter.
Sharing the nail cutter, sir.
Nail cutter. So if you use nail cutter, so many persons are using the same nail cutter. Can it transmit the fungal infection? That's one question.
Right. See, the nail cutter is going to be used only for the nails, cutting the nails. And more or less, this fomite issue comes for the glabrous skin, dermatophytosis. Since our nail fungus also comes under glabrous skin dermatophytosis infections, there is a chance of transmitting the infection, right? Especially if the subungual area has got a lot of spores deposited, and if that is getting transferred to the nail cutter, and if it gets used to another person, if they are genetically prone or immune system wise prone, they are likely to get it. There is a possible chance.
Next question is intertrigo. How to differentiate between bacterial and fungal intertrigo?
Right. See, bacterial intertrigo is associated with all the four findings of inflammation. It will be erythematous, it will be swollen, it will be red, it will be painful, and it will be tender also. All these things will be absent in our fungal intertrigo. One. And this bacterial intertrigo will appear fiery red, whereas fungal intertrigo will have a rosy appearance. And it will be moist also, this one, fungal intertrigo. But whereas bacterial intertrigo will be dry because of the heat that has been generated from beneath. And more or less, fissuring is quite common in bacterial intertrigo, whereas not so common in fungal intertrigo. So this can differentiate.
Now we are using the sanitary.
Your video and audio is on hold, madam.
Madam seems to have some connection issues. We'll
Yes.
give her a minute so that she can get back. Ma'am, kindly unmute, ma'am.
Okay.
Yeah, audible, ma'am.
Can they? Now we are using sanitizers very frequently.
Yes,
so whether it will harm your skin, whether it will predispose to fungal infections.
Yes, madam. So we are using isopropyl alcohol. Isopropyl alcohol, 70 to 90% of the isopropyl alcohol will be there in the sanitizers. Very frequent use can cause dryness as well as scaling. The superficial peeling of the skin, that is the stratum corneum is peeled off. And taking away the microbial flora of the palms also, which is going to have a defensive role in the local areas. So there is likely possible chances of developing the fungal infection, but 100% will it develop is a big question. There are possible chances.
Okay, how to treat extensive dermatophytosis in an infant?
First of all, extensive dermatophytosis in an infant is very, very unlikely, but still, if it is going to be there, definitely immune status has to be thoroughly checked up, and mismanagement of the previous condition has to be tackled. And if it is proved to be extensive dermatophytosis, definitely I'll go for the fluconazole, 5 milligram per kg body weight, over a period of 4 to 6 weeks, depending on the kg body weight. So this gives a very good result, because this fluconazole is one drug which can be used in the newborn period, right from the day one of the child.
Ma'am, we will go ahead with the next moderator because we are running short of
No,
time.
running short of time.
Sort of
Okay,
time.
okay.
I will kindly request Anandan sir to answer the rest of the queries on the chat box if possible, sir.
Yes, sir. Sure.
Okay. And now I'll invite Dr. Nisha to ask questions for the next session.
Dr. Soumya, Dr. Pramod wants to know whether some maternal drugs are there which affect the fetal nails.
Fetal nail, yes. Yes, Dr. Pramod, some of the many maternal drugs can affect fetal nail. For example, the thing that comes to my mind is phenytoin. As you know, anti-epileptic medication when taken by mothers can cause involvement of the nail plate, hypoplasia, and hypoplasia of the nails is typically seen in fetal Hydantoin syndrome. So anti-epileptics do contribute. A lot of nail changes. HCQ sometimes is used by mothers, so pigmentary changes may be seen. So yes, maternal drugs can affect fetal nails, yes.
Dr. Rutvik asks whether there is any treatment of Pachyonychia congenita.
Of the nail, you mean?
Yeah.
Yes, Pachyonychia congenita, it's very important to take care of the nails because it can be very disabling. So regular trimming of the calluses is very important. And also mechanical debridement, thinning of the nails, using specific knives and grinders to keep your nail thin. Also chemical debridement, like we give 40% urea, salicylic acid and high concentrations to keep the nail plate thin. So that will also help with the increased curvature. So these are things that we do apart from maintaining the hygiene, avoiding infections in the nails that can contribute, that can worsen the condition. Also systemic drugs like retinoids will also help in a certain way in reducing the in altering the keratinization.
Okay. Another person also wanted to know whether topical steroids and topical calcipotriol application is helpful in it.
In Pachyonychia congenita,
yeah, in the same situation.
It's not exactly an inflammatory disorder. It's rather a genetic disorder. Topical steroids will have a thinning action, but may not, you cannot keep applying it for a long time. In topical steroids and calcipotriol, we prefer to use in inflammatory disorders like psoriasis, like lichen planus, where you can use it for a specified amount of time. Pachyonychia congenita being a genetic disorder, which you have to manage on a real long term, it is not advisable to use potent topical steroids.
And Dr. Pramod also wants to know causes of melanonychia. Somewhat you have covered in the talk.
Melanonychia, again, it can be a big classification is there. Yeah. It can be true melanonychia, where you'll see the pigmentation. It can be in the nail plate. It can be, because of the nail bed involvement. We talked about mainly about nevi very commonly causing melanonychia, the longitudinal bands. You can have depositions of dyes in the nail plate, exogenous causes causing melanonychia. Then you can have infections, for example, Pseudomonas, green nail it causes. With candidal infection or an onychomycosis, you can get yellowish discoloration. Of course, the drugs we talked about, zidovudine, the HCQ, all these drugs can cause melanonychia, n number of causes. I think I'll have to sit and recite.
Okay. Dr. Nishant wants to know the difference between Candida and bacterial paronychia.
Candida and that's a good question. Candidal paronychia can be both acute and chronic, whereas bacterial paronychia is usually acute. We talked about paronychia, I think, where you have the nail folds getting inflamed. And candidal paronychia is usually seen only in the proximal nail folds. It's it's got this predisposition towards proximal nail folds, whereas in bacterial you can get the lateral nail folds also affected, and there's generally a tendency for the pus to point as well when you have acute bacterial paronychia. You generally don't get as much, like Dr. Anandan was mentioning in the previous question when he was differentiating acute intertrigo as well as chronic bacterial and fungal intertrigo. Same thing happens in bacterial paronychia. There's more inflammation, it's more fiery red, more pain, tender, whereas in candidal you can get milder reddish discoloration, you can get erythema, but it is not as acute, it is not as inflammation is not as much as in a bacterial condition. You don't get pus pointing, and you do also tend to get a chronic paronychia where it is mainly colonization rather than actual chronic paronychia is usually due to hand dermatitis and other reasons. You get candida as a colonizer than an actual pathogen. So this kind of helps you to differentiate.
And he has a comment whether there's any role of vitamin D in nail disease.
Yes, of course. Nowadays, vitamin D has got a role in everything. So I think if you ask me, a lot of studies are there regarding a role of vitamin D in nail disease, and for example, in psoriasis and atopic dermatitis and everything. So when you have something where we are not really sure in what ways it affects, but yes, it is important when you have hair and nail issues, for example, hair loss or nail issues, we always ask the patients to keep their vitamin D levels in the normal ranges. It might have something to play.
Dr. Rajaram, K. Rajaram has a comment over there stating that the transverse white lines in fingernails, the me lines in children, it's due to arsenic toxicity, maybe heavy metals, others can cause, and it is due to homeo medications. Would you like to comment on that?
Yeah. I'm thankful for this question because I did not spend time on systemic diseases much. So the Mees lines and the Muric lines, they're important. These are actually transverse lines, transverse white lines, Mees lines, which are parallel to the lunula. And Mees lines, as he rightly mentioned, we attribute it to heavy metal toxicity. It could be arsenic, it could be anything. I don't want to specifically talk about homeo medication regarding the controversy, but yes, heavy metal toxicity is what we have to rule out. It can occur in other states in renal failure and endocrine issues as well. But that is true leukonychia. You're getting true white lines. Whereas in Muric lines, it's apparent white transverse lines that you see. It's usually due to hypoalbuminemia. Just like you see in Terry's nails and Lindsay's nails. Terry's nails is, apparent like Muric lines, whereas in Lindsay nails, a half and half nail, you actually get the whitish discoloration.
I think we're done with the queries with regard to this topic. Thank you, Dr. Soumya.
Thank you, Dr. Nisha and Dr. Soumya. Now we are going to the final session, question and answers, to Dr. Madhusudan sir, over to Dr. Ramesh sir for the questions. Dr. Madhusudan sir.
Okay, not much questions. One question is regarding the carbuncle. Carbuncle, is it some sign of immunodeficiency?
Because carbuncle mostly occurs in immunocompromised situations, especially in older patients with diabetes and other issues. But in children, it's very rare. But then it inadequately managed folliculitis or even or pharyngeal may go for a carbuncle if totally left over. But per se, it cannot be taken as an evidence of an immunodeficiency. There is a suggestion, sir, there regards. Yes, sir. Please.
Then regarding what Paluni molluscum.
That is being taken up again, sir. Okay. So there are two aspects I mentioned here in the chat box. One is regarding the availability, the sapazolin, the sapatroxin, does it really work? So from my experience, sapatroxin really works, and I have been treating all skin infections with for the last 10 years with sapatroxin only or cephalexin. And availability, as Dr. Jose Anthony has rightly pointed out, availability is limited. Even when I'm joined Apollo now, and after so many 3 or 4 months of persuasion only, they have kept sapatroxin in the pharmacy because it is cost only 3 rupees or a tablet. Its preparations are rather difficult, but Safadior is there, Droxil is there. It is easily available. Unless you push for it, the pharma or the retailer or the even outlets will stock Safetroxil because the margin is very, very minimal. You don't get even 50 paise or 10 paise for selling 1 rupee for selling a bottle. So they don't keep it. That's what they have learned from them. The bottle is only 30 rupees, one bottle cost. So that's a problem. That's a crux of the issue where the marketing and the economics comes into picture. But it is available. If you push for it, it is there. So many preparations are available and it works very well. Cephalexin's products, I am not able to mention supposed to mention the trade names here, but it's easily available. And another question is here regarding, can you suggest an emollient? So I believe there are a lot of much more learned dermatologists around, so they may be better able to take it better. But I still, from my side, there are two types of emollients. One are the natural emollients where you use oil and butter mainly as a natural emollient, where the other emollients are basically containing urea, propyl glycol, lactic acid, something like. And the purpose, the main assignment of the emollient is to retain water, moisture in the upper skin layer, retain moisture. So they hold water for us. All these contents will hold water. And plus, some of the emollients may contain some contents which works against itching, like calamine lotion is added. Calamine is added to many formulations. So emollient, basically, I am not able to advise to dispel the name of the preparations right in this platform. But emollients, lot are available. Humanized these natural emollients plus the other ones with containing the artificial components with some amount of anti-itching formulations.
Then what is the difference between shampoo and hair conditioner?
It doesn't come under my purview, sir. I believe.
Again, sir, this question
will
will be
the competent person to address it.
Sir, can I take that question?
Yes, sir.
Yes.
Yeah, a shampoo is like any soap or something. No, it is a cleanser. It cleanses the hair, right? Whereas conditioner is one which coats the individual hair so that it doesn't stick and doesn't tangle, and that gives a soft feeling. That is the only difference between the conditioner and the shampoo. So shampoo is used as a cleansing agent, whereas your conditioner coats the hair and doesn't allow each one to attach itself or tangle, and it keeps it soft.
So, sir, we have come to the end of the session for discussion. It has been an excellent session from all the speakers. There might be few questions missed out in the chat box. I request all the faculty to just go through the chat box to make sure it has not been missed. Now we have comments coming in from very senior pediatricians who've been using cefuroxime for more than 20 years, committing to the drug itself. So that is again a positive sign.
I agree with Dr. Palaniraman. He has written 20 years. Even I have been using 15-20 years cefuroxime and cephalexin. Only thing, you have to make it available in your pharmacy or the retailer. Wonderful molecule.
Okay, sir. Thank you, sir. Now we are going towards the most awaited session for the day. I would like to invite Dr. Binukuttan to introduce our moderator.
Hello, sir. After 4 excellent sessions, we is having the much awaited panel discussion on pediatric dermatology potpourri. And we have 3 eminent speakers. And to moderate the session, we have the most apt person, Dr. C. Jayakumar, sir, my teacher. Sir is currently the professor and HOD at Amrita Institute of Medical Science, Kochi. Sir was the past NNF president of Kerala chapter in 2013-14, national EB member of IAP in 2012 and 2017. Sir was the national secretary of IAP Allergy and Immunology chapter in 2014-17. Sir is having so many publications in national and international journals. Sir is a postgraduate examiner, and Sir has contributed various chapters in various books. So I welcome C. Jayakumar, sir, to moderate this session. Thank you, sir.
Thank you, Dr. Binukuttan, for your kind words. At the outset, I would like to thank the president of IAP Dermatology chapter, Dr. Hari, Dr. Naushid, and state office bearers, Dr. Narayanan, Dr. Bala, Dr. Krishnamohan, and the IAP Pathanamthitta president, Dr. Binukuttan, and Dr. Jijo, and the organizers of this meeting, Dr. Roy and Dr. Arun, and our president, Honorable HSC in the past, and also the presidential candidate, Dr. Ramesh Kumar. So you know that this potpourri, don't think that's a repetition. Almost you consider it as a recapitulations. So many questions in this has already been discussed. Now let me share my screen. That is this one. Can you see? Can you see my?
Yes,
Hello?
come, sir. Just come.
Just come. That is slideshow. Okay, slideshow. Is it okay? Start from first slide. Okay. So, Dr. Anandan and Dr. Vijay Bhaskar has already been introduced. It's my duty to introduce the professor, Dr. Renu George. She was the professor, formerly professor of CMC Bellu, Dermatology, and she was a postgraduate teacher. She has so many publications, 23 publications, and she's a member of the Indian Association of Dermatology and Venereology chapter. So my first question, okay, this is the credentials of Professor Dr. Renu George. So, the first question, this is a strong prescription practice among practitioners, the triple combination of steroid, antifungal, antibiotic work in most of the pediatric skin problems. So do you agree or justify this practice of prescribing antibiotic, steroid, antifungal combination? Dr. Renu, madam.
I hate to start this panel discussion on a negative note, but I would say a firm no to the use of triple combination in the pediatric age group. But occasionally, if you go on to the next slide, sir, I have.
Yeah.
Yeah, so occasionally you can use a topical steroid antibiotic combination for an infected atopic dermatitis if it's localized. And similarly, for a bad diaper dermatitis, you can use a mild topical steroid with antifungal. When you're using topical steroids, please remember to use it only for a short term.
So in general, it's a big no. So better not to use this combination. Isn't it like that, madam?
Absolutely.
Okay. That's fine. Okay. Now the second question is to Dr. Vijay Bhaskar. So you know that one of the best important fundamental principle in dermatology practice, dry wet lesions and wet dry lesions, fundamental principles. I have learned this from one of your class webinars actually. So could you please elaborate this statement with examples, Dr. Vijaya?
Yeah, yes, sir. This is one of the simple, or I can tell this is the mantra of dermatology. Anything that is dry, you wet it. Anything that is wet, you have to dry it. So wet lesions, for example, if you take miliary rubra is a wet lesion, right? So you have to dry it. That is the reason we use calamine lotion. Calamine lotion is a drying agent. So try to use a pure calamine lotion and you can have a soothing thing and it will also dry the lesion. Similarly in eczemas, which is a wet lesion where you can use a cream rather than ointment, you can make it dry. And next you take ichthyosis. This is a dry lesions, right? Here you need a moisturizer. So this is how normally basically the dermatology works. So always wet the dry one and dry the wet lesions.
So dry the wet and wet the dry. Okay, that's agreed. Okay, now the question is to Professor Dr. Anandan. So when children comes to scaly scalp lesions, most of us diagnose as dandruff. So whether all these are dandruff or what are the other DD that you have to consider, suppose there is a scaly lesions, and what's the best management for dandruff? Professor Dr. Anandan.
Yes, sir. Good afternoon, everybody. First of all, this dandruff itself is a misnomer, which has been clearly stated that it is a milder form of seborrheic dermatitis. And this depends upon the age group what we are going to deal. If it is going to be more than 2 months of age group, then I'll think more in terms of atopic dermatitis. And still later we can think of psoriasis. And in my lecture, I mentioned about the fungal infections and irritant contact dermatitis, where any oils that has been applied. And sometimes I come across with baby scalp rubbed with camphor and oil put together. So that can produce a severe irritant contact dermatitis. And if a seborrheic dermatitis-like picture is produced in a little bit older child with organomegaly or lymphadenopathy, one should think of histiocytosis X. And certain immunodeficiencies, nutritional and metabolic disorders also should be thought of as a differential diagnosis for the scaly scalp. Mild can be left untreated. Moderate to severe, if we are very sure if it is going to be fungal, then we can go for antifungal shampoos, which has already been mentioned, where 2% ketoconazole can be applied for a period of about 5 minutes, which can be thoroughly massaged into the scalp after wetting the scalp. Then it can be rinsed thoroughly twice weekly for about first 8 weeks, and then once weekly for about next 4 weeks. So that should give a good result.
So Langerhans cell histiocytosis is an important DD that you have to consider. You palpate the liver and palpate the spleen, also see whether it is enlarged or not, and that's the most dangerous of in this group. Is it like that, sir?
Yes, sir.
Yes.
One has to keep in mind high index of suspicion should be kept there.
So, Professor Dr. Renu, we also come across with alopecia that is already discussed. It's a recapitulation. twice or thrice in a month. So could you please explain the pediatrician's role? What's our role in seeing a child with a loss of hair? So this is not about alopecia totalis, because alopecia totalis is your field, not our field.
If
Madam.
you would just go to the next, yes.
Yeah.
Okay, so if you look at hair loss, the first thing I would ask the parent is this congenital or this is acquired? So if it's congenital, it's a totally different ball game and another trajectory and another talk. But then you look at whether it's a diffuse kind of hair loss or whether it's a focal hair loss. If it's focal, it could be alopecia areata or it could be tinea capitis. If it's not your cup of tea, send him to the nearest dermatologist. But if you see diffuse non-scarring alopecia like this child with SLE has, I think that's where the pediatricians come in. And what I would look for is an ongoing underlying systemic disease, which could be a connective tissue disease or a thyroid dysfunction. It could be malnutrition, or it could have been a preceding illness like a severe dengue or a typhoid. There are some medications that can cause hair fall, like most in the pediatric age group, it would be the anticonvulsants. And depending on this, your history, your clinical findings, you do a focused lab investigation. Some of the common tests that are done, I've mentioned, and then treat it.
Madam, stress is also an important factor, because personally I had a note because I had alopecia areata when I was commuting from Kottayam to Trivandrum, and after 2 years I had 2 large alopecia areata. My dermatologist,
Yes.
Dr. Benjamin, was telling me that the stress. Is it like that? Is
yes.
it?
Yes, can.
Yeah.
Yes, at
Yes,
least we
yes.
believe.
Yes, madam. Thank you, madam. Then Dr. Vijay Bhaskar, sir, whether we have to go beyond skin when Dr. Ramesh was telling about this, because recurrent furunculosis, whether we have to go beyond this skin. Yeah.
So treating furunculosis is going to be easy. Like as Sarah has already mentioned in his lecture, sulflexin is more than sufficient to treat any furunculosis bacterial infection. But when it becomes recurrent, then we have to have a few differential diagnoses, or we have to go into the history and find out. One of the commonest condition is carrier state. The person may be carrying the infection elsewhere in the body, but he may have recurrent infection in the skin. Second is you have to think of iron and zinc deficiency also may be one of the cause, or it may be an immunodeficiency. A simple diabetic in a child also can bring out these lesions. So how to take care of the carrier state? There are so many methods of using mupirocin. One among them is applying mupirocin over the anterior nares, umbilicus and perianal region twice daily for 10 days. And there are studies, as Sarah has mentioned, you can use it thrice daily for 5 days, once in a month also that can be used. And along with that, what we do is we normally put them on rifampicin. Rifampicin 10 milligram per kg body weight for 10 days. Definitely you will see a lot of improvement if it is going to be a carrier state. Otherwise, definitely you have to investigate for any iron deficiency and look for any immunodeficiency in these children.
So right now we have a patient with a CGD in our hospital. This child is scarring furunculosis. So that's why I asked this question. So you have to go beyond this nails. You have to cover this perianal and umbilical region also. You have to apply this ointment here also. Thank you, Dr. Vijay Bhaskar, and point is well taken. And Professor Dr. Anandan. So we are scared of our cut wounds, because we always fear that any wound will end up in post-streptococcal glomerulonephritis. Sputum is a nightmare for us. Surgeons say sterile cut, there is no need of any antibiotic, but no need of any systemic antibiotics, nothing. So what about wounds in general to a child? And all wounds are whether get infected. So whether topical antibiotics work, or if it is works, which antibiotics you prefer? Can you hear me? Sorry.
Yes, sir. Bombarded with questions. So here, cut wound going for post-streptococcal glomerulonephritis. It is not that all the wounds which is going to go for post-streptococcal glomerulonephritis, and we have seen very, very few patients going for it. When I search the literature, it says only 5% of the patients can go for PSGN. And usually it is the 3 to 6 weeks post-infection. So that is the dangerous period, or one should suspect about the PSGN. If they cross that period, most of the time they are safe. And the management depends. If it is going to be a clean cut wound, as the surgeon says, nothing necessary. But as a dermatologist, I always feel that children cannot be kept sterile. So it's always better to give a supportive management. If it is small, not bleeding, if the bleeding is arrested, then observation will be the best choice. If it is large and bleeding, just a pressure bandage or just a pressure over the bleeding point can arrest the bleeding. If necessary, even the surgeons say glues, surgical glues can be applied to close the wound. And the last resort, if the bleeding is not arrested, then one will be forced to go for sutures. As a dermatologist, if at all I want to use a topical drug, I will go for topical mupirocin twice daily for a period of about 7 days. And the ceiling is always given as 10 days. Don't go beyond 10 days. And why? Because the resistance is very low and it covers the MRSA also. So I feel that mupirocin will be the best choice.
If there is a cellulitis or abscess formation before that, do you start which antibiotics? As Dr. Ramesh rightly said, I have only one belief in only one antibiotic, that is ceftriaxone, because very cheap, compliance is there. So do you prefer ceftriaxone or cephalexin or clarithromycin or erythromycin? So what's your preference of choice, Dr. Anandan?
Sir, cephalexin has been studied extensively, and the literature also says that it is akin to using penicillins. So it can equal the effects of penicillin. So in my practice, I use cephalosporins. And in my area, I've used a lot of cefadroxils also.
Yeah,
But
good
maybe
complaints.
the area sensitivity doesn't work well with cefadroxil. I don't find a satisfactory result with cefadroxil when compared to cephalosporins. Cephalexin.
Cephalexin.
So
Okay,
this
sir.
is my finding.
Okay, sir. Agreed. So then the question is to Dr. Renu, madam. Madam, last question was about alopecia. May I ask one connected questions? We fumble when patients come with gray hair. That was discussed, but it's a recapitulation. So we usually prescribe zinc and B complexes. So what's the reason for this gray hair? Whether these children need any investigations, and what can we do in these cases?
You could just, okay, so few things that we can do to help the patient. It's very distressing problem all around, patient, parent, and the physician. One thing you check on is the family history. Stop the smokers in the family. Look for diseases that you can treat. At least this will arrest the progress of the canities. So some of those are pernicious anemia, hypothyroidism. Look for underlying vitiligo when you have a patch of white hair on the head. And of course, then protein energy malnutrition. And it could be a herald sign of some of the progeroid syndromes. Barring that, there's nothing much we can do. You treat the underlying disease or deficiency. It was mentioned calcium pantothenate, para-aminobenzoic acid, PUVA. These are anecdotal reports of its improvement, but no consistent reports in studies. So at the end of the day, we're left with cosmetic camouflage with all its limitations.
Madam, you said chloroquine can also cause problem because I have already gray hairs, but I don't know whether youngsters are taking prophylactic hydroxychloroquine, whether they will end up in gray hair soon.
They will have, I mean, if that's you're giving it for your SLEs and you find the hair looking a slightly lighter shade of gray of black, yes, it can happen.
Now people are taking HCQ for prophylaxis of COVID, whether they will end up in gray hair soon.
No, I don't think so. That's short term, hopefully.
Okay, madam. Then the question is to Dr. Vidya Bhaskar. So what's the best management for diaper dermatitis? A big issue there. There's a lot of environmental issues are there because it's diapers. So what's the best diaper that you'll advise, and whether these children need diapers during night also?
The best thing is to prevent diaper dermatitis, do not use the diaper.
Oh,
okay.
That's exactly.
That is in case, of course, this is a fast world where both parents are working nowadays, and it is very, very difficult for them to manage without a diaper. That is one. So in case of diaper dermatitis, the child develops diaper dermatitis. So you better avoid the diaper at that particular point of time. And if there are any irritant dermatitis skin lesions, you can go for topical steroids. I would like to recommend only the weakest steroid, like hydrocortisone can be applied in that area, because it has to be occluded. Anyway, it's going to be occluded, so the potency may go up. Only for 2 weeks should be more than sufficient. And suppose that there are raw areas along with it, you can go for a combination of a steroid with fusidic acid, like hydrocortisone with fusidic acid can be used. If there is itching, you can go for antihistamine. And if there are going to be any secondary infections, you can go for topical, or if necessary, oral antibiotics also can be given. Sometimes, very rarely, we get antifungal. Fungal infection also could be secondarily there. So you can go for antifungals if secondary candidiasis is present. And because they cannot avoid diapers in this period, in this era. So in case they want to use a diaper, I tell my patients strictly to use super absorbent diapers, which is like a cloth, or we call it as a breathable diapers. They contain super absorbent polymers, and it looks like a cloth only, but it has to be changed frequently. Once in 3 to 4, whether they wet it, whether they soil it or not, it has to be changed. And before applying the diaper, it is better to go for a barrier cream, particularly in children who are prone for it. You apply a barrier cream which contains zinc oxide and petrolatum combination based formulations can be applied, and then you can apply. And we are going to change the next time the diaper, you need not wash this barrier cream or that particular area. you can apply the cream again and then you can use the diapers. This is the advice I used to give to the children. And wearing diapers in night, definitely not. I don't recommend that. Maybe one of the parents can get up and clean the child and they can use it. Particularly, I see children going to school with the diapers, right? That is, and it may cause even problem for the control of their bowel habits also.
So 2 questions. So what is the percentage of hydrocortisone that you are doing? 0.5% or 1%?
1% hydrocortisone is more than sufficient, sir.
Then one more question, sir. So you said you prefer mipirocin, and now you say fusidic acid is the antibiotic that you will advise.
Because there is a combination. When it is a combination available in India, we have got combination with hydrocortisone is only fusidic acid.
Oh, yeah,
you don't get mother combination. That is the reason I prefer that with
the comment. That's fine. The point is well taken. Okay,
because
then
if you want to use fluticasone. Fluticasone will be in class 4 steroid. It will come to class 4. It will be higher potent steroid, which I would not like to use it in a flexural area or an occluded area.
So the message is very clear. Don't use in diapers during night. Okay, then Professor Dr. Anandan. So what's your advice regarding baby soaps? People are now the Johnson, some other trade names and all that are there. Whether do you advise baby soaps? What's your advice regarding baby soaps in clinical practice for newborn babies?
Sir, as far as soaps are concerned, it is only the soap or a syndet. There is nothing called baby soaps. Baby soaps, they are called so because just, traditionally they have been called so just because they add some vitamin E in it or a moisturizing factor in it. So nothing, it doesn't, prove the criteria to be a baby soap. Whether it is a soap or a syndet. Syndet is supposed to be best because it matches the skin pH, and this syndets are always superior to soaps, and syndets is not a must. It is not a must, but special conditions like atopic dermatitis, syndets might be beneficial for their moisturizing effects.
So what's the essential difference between the soaps and syndets? We are not aware of this difference between syndet and soap.
Sir, the soap preparation is a very complex procedure, but I'll tell you in a very simple method. Fatty acid plus alkali, that is soap.
Yeah.
Fatty acid plus acid is syndet. Simple.
Okay. Any syndet preparation? Could you could you please tell the name of the syndet preparations?
Am I permitted to say the trade names in this forum?
Oh, that. Okay. The word syndet is there in that particular. That means, for example, okay.
Syndet is nothing but synthetic detergents.
Okay,
that's it.
Fine. The next question is to Madam. I think so. Okay. I think this topic has already been discussed, but they can recapitulate. What is the management of onycholysosis?
That's an entire chapter, but anyway. So first of all, find out what the onycholysis is due to. It could be the child playing in water for a long time, an adolescent trying to remove her nail polish over and over again with acetone-based nail polish remover. It could be a medications like tetracycline, but that's not usually given in the pediatric age group. But a few things that we can treat are psoriasis and tinea. And if you could go to the next slide, sir.
Yeah.
Yeah, okay, so here we have distal onycholysis, very typical of psoriasis, and some of the agents that you can use are tazarotene, which is a vitamin A, or a topical steroid. And when it comes to tinea unguum, you treat with either itraconazole or terbinafine.
So these are drugs that is indicated, but that we are afraid to use tetracycline in children less than 6 years for prolonged period.
That's right.
If possible, we try to restrict the use of tetracycline in children less than 6 years. You can try terbinafine and itraconazole can be used, but not we are not in favor of this tetracycline pediatrics.
No, tetracycline was not for treatment, sir. It is a cause of onycholysis.
Cause only. Okay, that's
yes, it's a cause of onycholysis.
Oh, thank you. That point is well taken. Okay, Dr. Vijaya. So you have already told me about the hirsutism is unrelated to drugs. So could you please tell something about suggestions to remove this excess hair? Any methods?
First of all, as I already mentioned in my previous talk, the hirsutism or the excessive hair growth in a female, we can make it like this. It can be male pattern. It can be generalized. Right? If it is male pattern, we call it as hirsutism. It is generalized or localized, we call it as hypertrichosis. As you mentioned, you don't want to talk about drugs, so that is there, not there. And there should be a family history of hyperandrogenism in case of hirsutism. Then if it is present, then you see the rate of onset. If it is not present,
PCOD you are meaning?
Yes, So it is coming. It is coming there. In case if it is hyperandrogenism is present, family history of hyperandrogenism is present, you see the rate of onset. If it is gradual rate of onset, then you have to think about PCOS or an congenital adrenal hyperplasia. When it is rapid, always think about malignancies. As I told you, the best management for hypertrichosis, if you are able to rule out other causes and then you control the causes if it is present, then the best management will be to go for lasers. As I already told you, the best lasers could be diode laser, alexandrite, or you can go for Nd:YAG lasers. These are better. They do it and you get good results with these lasers.
So thank you. And then a question is to Dr. Anandan. So pediculosis capitis, what's the management policy? The family treatment needed or not?
Sir, as far as pediculosis capitis is concerned, this is Lowe's-borne disease, and 1% permethrin topical rinse, which is kept there for 20 minutes over the wet hair, and then it should be rinsed, and it should be repeated after a week. So this is what is being followed. Oral ivermectin could be added if the child passes the criteria, like if it is more than 15 kgs of weight or more than 5 years of age. So this should be the FDA criteria. And if it is very extensive, then we can go for oral ivermectin. Otherwise, it's not necessary. And if it is associated with secondary infection, one can always go for cotrimoxazole, that is trimethoprim and sulfamethoxazole combinations, because this interferes with the gut production of B12 in the louse. That is responsible to sustain the life of the lice. So if you can cut that cycle, automatically the lice dies. So that is the drug of choice or the drug of antibiotic that is required for serious secondary infected cases of pediculosis capitis. If you ask whether the family members has to be treated, as a dermatologist, I'll say yes, they have to be treated.
So any other drug other than cotrimoxazole, personally, I'm scared of using cotrimoxazole fearing Steven Johnson syndrome. So there is no other option. Only cotrimoxazole is the best in this condition. Is it like that? Okay.
Yes, sir. Yes.
Okay, sir. So Professor Renu Madam, so one drug I'm not saying an orphan, now is introduced for this cerebral blindness, now it is the drug of choice in COVID. Do you have any experience with this ivermectin in COVID? No, you
no,
are.
I have not managed COVID.
Okay.
I don't know. I can talk about ivermectin and scabies.
Okay. Ivermectin, people say it's going to be a good drug in the early stages of COVID. I don't know whether it is there is evidence is there, but still people are using. So many studies are there in Bangladesh and other places. And now latest, the Indian Academy of Pediatrics Association of some doctors have said that you have to introduce ivermectin in clinical practice because there is a good improvement. You can become RT-PCR become negative very early if you start using ivermectin. So that inhibits the important protein that is necessary for the introduction of this COVID virus into the cytoplasm, from the cytoplasm to the nucleus. So this viral disruption occurs, suppose if you use ivermectin. Okay, so you're using ivermectin left and right for scabies and also for other conditions.
No, I don't use it left and right, sir. Very selective.
Very selective.
If you go on to the next slide, I'll tell you.
Okay.
So ivermectin, I don't use it for classic scabies unless my drug of choice, the medicament of choice is 5% permethrin cream. But you could use oral ivermectin if you find that the child cannot apply the topicals because of the limb is in a cast or severely infected or eczematized, then you can use ivermectin. But for crusted scabies, CDC does say that you need to use oral ivermectin with topical treatment, and the regime is slightly different for oral ivermectin than for classic scabies, where you give 2 doses of oral ivermectin 1 week apart.
Is it a safe drug?
In elderly patients, no. In children, not. I haven't found any side effects to talk about.
Okay, madam. Okay, so that you use ivermectin as a second line drug only. You prefer 5% permethrin. Okay,
yes.
Then to Dr. Anandan. So we have some difficulty in differentiating Ashleaf macule that we see in children with tuberous sclerosis from nevus anemicus. So could you, in which way you have to differentiate this Ashleaf macule from nevus anemicus?
Yes, sir. First of all, this Ashleaf macule is something pigment related, whereas nevus anemicus is vasculature related. And once you see this ash leaf, it is just like an similar to a neem leaf. And if you can see the borders, it will be serrated. But whereas nevus anemicus, it's diffuse hypopigmentation, which is seen. And once you use this glass line, that is, which is shown in the second picture, just if you can compress involving both the involved and the non-involved area, that is the normal skin, one can see the merging of the borders. So this says that there is going to be a vascular component underneath. And if you're going to use an wood slab, this can be easily picked up, the ash leaf macule. But whereas wood slab may not be helpful in the nevus anemicus.
So the left one is nevus anemicus or ash leaf macule? Left one, this one.
That is ash leaf macule.
This is ash leaf. This is nevus anemicus.
Nevus anemicus. The procedure done is diascopy.
Okay, thank you, sir. So then the question is to. So we are Dr. Renu, madam. Sorry, madam.
No problem. We'll continue.
We are basically brownies. Any change in color, especially white compared to the rest of the skin, is worrisome to the parents. You know. So could you please tell me about the important DD that you'll consider in these white patches in the skin?
Okay. So if you could go to my, yeah. Okay, first of all, when we talk about white patches, there's always a confusion. For the dermatologist, it's very, we are very, we know what we're talking about when we say white, but generally there is a confusion. So first you make sure whether you're talking about a depigmented patch or a hypopigmented patch. Next slide, sir.
Yeah.
Okay. So then you go on to the differential diagnosis. The first thing I would ask when a child comes with these patches is whether they're congenital. So let's just take depigmented patches. You have piebaldism, you have tuberous sclerosis, and you have nevus depigmentosis. And acquired, so we'll talk about acquired now, where you have vitiligo and lichen sclerosis and atrophic. When we talk about hypopigmented patches, we have, again, congenital. You have ash leaf macules, which can look depigmented or hypopigmented, and you have the nevi. And acquired causes are really wide. So you have anything from tinea versicolor, indeterminate Hansen's, post-inflammatory hypopigmentation, pityriasis alba, to hypopigmented mycosis fungoides. So if to go to the next slide, sir.
Okay.
Yeah, okay. So the next question to me was how you treat it. Again, that's very wide, but I'll tell you just very briefly. When you're treating vitiligo, you first look to see whether it's focal or diffuse or generalized. If it's generalized, you go for phototherapy. You have to go for narrowband UVB. When it's focal disease, you can try on the face. I would try a calcineurin inhibitor, either tacrolimus or pimecrolimus. The other options are topical steroids, calcipotriol, and if you have the luxury of targeted phototherapy, that's a good option. You can also use topical sorolins. Hypopigmented patches really depends on the cause. Treat infections. Pityriasis alba is something that you'll come across in your practice. You can try a sunscreen, just emollients. Parents very worried, try a calcineurin inhibitor. Remember, you need to use it only for a short term. And if a pityriasis alba or the white patch continues and stays for a long time, you would need to rule out indeterminate Hansen's disease.
So what about using soap in these conditions if there is pityriasis alba, madam?
Please go ahead.
Well, can we use soaps? Can we use soap?
Yes, of course.
Yeah.
Of course.
Because whether that will dry the skin or
doesn't matter. Just use an emollient after that.
Okay, fine, madam. Yeah. Then Dr. Vijay Bhaskar, now we are seeing a lot of adolescents now. Pediatricians, number of pediatric patients are coming down every day because the population is aging. So we have to manage so many adolescents. Now acne vulgaris also we have to manage. Children less than 18 years are coming to the hospital. So how should we counsel them about this acne vulgaris?
Not only 18 years, sir. In US, if I am right, they have made the pediatric age group as 21 years.
Oh my God. So that's the only hope for us. Now the population is aging. So the pediatric population is going to be the same even to 2020, not only 2020, 2200. Same population.
Slowly it will become only pediatrics and geriatrics, I think, in the long run.
No pediatrics, only geriatrics.
So coming to the acne vulgaris, we all know that it is age related and it is there changes in the hormones in the body, and it is all our androgen dependent reasons. So we have to explain to the parents about the condition, why they get acne. First, we have to tell them why they get acne and why we should control acne. That is more important, because the acne can start from adolescent age group. It can, on an average, it can go up to 25 years of age, or it can even last up to 30, 35 years of age. So it all depends on their hormones that we have to tell. And we have to control the acne, because if you don't control the acne, then they will ask the next question is, if it occurs up to 25 or 35, why should I treat? And you have to tell them, if you don't treat, then the appearance will not be good, one, and they may have complication like scars. So that you have to tell them. And you have to tell them that as the child grows, the hormone settles down and everything comes to normal. Second is food. There is advice we can give regarding food. We can tell them this high glycemic diets like chocolates, ice cream, cool drinks, that can be avoided. The moment you tell that, the children will tell, we'll go to the next
junk foods you have to
junk
avoid.
foods to be avoided, but always they would like to go to the next doctor if you advise this, but still you have to advise, and parents are very happy when we tell this particular advice. And next thing you have to tell the child is not to pick the lesions. Once they pick the lesions, there is going to be a secondary infection, and already there is some amount of bacteria there, which can lead to more scars also. And how to tell them in case they come with the scars or after the acne or with the scars, you have to reassure them that even the scars can be taken down very, and they can become, we can make them more, presentable. That we can tell them, and you have to reassure them. This is what normally we advise, and we have to tell the parents that what medicines we are giving is only to control acne, not to cure acne. We never cure acne, we only control the acne. So sometimes after the stoppage of the treatment, the acne can recur back, and again they have to go for the medications.
So thank you so much, sir. And to Professor Anandan, so what's the minimum requirement of a sun protection cream? Now, fortunately, we are all indoors. That problem of sun protection is not there. So as long as COVID is there, there is no need of any sun protection. So, but once the COVID is out, then you have to use this sun protection scheme. So should we use it always when you go out, sir?
Sir, before getting into the topic proper, I would like to say that it is not going to prevent anything against the sun. It is mainly the UV light we are going to talk about, UVA and UVB. So even if we stay indoor, the screens, what we see here, or even the fluorescent tube lights can emit this UV light. So that can be harmful to the skin for those who are genetically predisposed. So this sunscreens may not be required for everybody. Maybe those who are prone to develop photosensitive disorders, the sunscreens will be very useful. Now that the sun protection factor, the minimum requirement should be at least 15 for its effect to take care. And best thing will be, it should be an UVA as well as an UVB blocker if preferable. And daily use is recommended, preferably 30 minutes before you step out of the house, it should be applied. And please remember, whatever they say, it is sweat resistant, it will be 24 hours on your body. It is not so. Every 3 to 4 hours, one has to apply sunscreens to take care of their skin. Of their skin, if they are genetically prone to develop any photosensitive disorders.
So SLE patients, where they have to use it always? SLE patients?
Yes, sir. SLE patients, apart from topical sunscreens, they also take hydroxychloroquine, which is supposed to be a systemic sunscreener also.
Thank you, sir. Thank you. And Professor Dr. Renu, so you got antibiotics and hand hygiene. So what do you have to do to prevent recurrent pyoderma in a child? That has already been addressed, but I can also contribute, madam.
If you could just go to the, yeah, okay. So I think everyone's gone through the causes, which includes chronic nasal carried atopic dermatitis, underlying diabetes, primary immunodeficiency. One thing we need to know is that when they come with just the skin, it's unlikely to be a primary immunodeficiency, because in primary immunodeficiency, you usually don't get single organ infection, you get multiple organ infections, and that's what raises the red flag. Now, I always suggest you do a pus culture and sensitivity, because sometimes you're treating for MSSA, but it's a MRSA. So then you switch the antibiotic and you get your results. Decolonization has been talked about, and you not only need to treat the carrier, the child, but also the caregiver, because sometimes they are the carriers. Cut nails, these usual household things that you can do, and prevent sharing of towels, etc.
So better not to share the nail cutters. Is it like that?
What's the nail cutter? What's the nail cutter?
What's the nail cutters? Okay, then. So now the question, yeah, madam.
Yes.
Okay. So one of the most important difficult problem in pediatrics, we are really scared, is Stevens-Johnson syndrome. We don't want that condition. We don't want that condition. So how will you manage, how will you make an early diagnosis of the Stevens-Johnson syndrome, and what is the best skin protection strategy?
I wish I had the answers. If you could just go to the next slide. We're as scared of this as you all are. So early diagnosis is nothing to replace history and clinical findings, because that's what clinches the diagnosis of a Stevens-Johnson. If in doubt, you can do a skin biopsy. You can't wait for the regular 8 days to get the report. The child, you have to. So then where you have the facility, like we would go ahead and do a frozen section, which will give you the answer within about an hour if the good pathologist. As far as treatment goes, stopping the drug is the most important. You need to give good supportive care, therapy. Skin care is important. We do a burns dressing. Now you have very many agents that are supposed to be to work in Stevens-Johnson, but you must remember a couple of things here. You're dealing with a disease with an inherent mortality. We grade it with Scorton. So if you have a Scorton of 5 or more, you're looking at a mortality of 90%. So nothing less than a miracle is going to take the child out of that situation. But these are the agents that we can give, which can halt the progress, provided it's given early. So you have systemic steroids, IVIG, cyclosporin, and now more recently, etanercept, where you only have case series in the pediatric age group. The youngest child being treated was 4 years. Of these, if there is severe infection, I would prefer to give IVIG, provided if the child has come with an underlying infection for which the drug was started. I would say IVIG is the safest bet because the others can immunosuppress further and then push the child into sepsis. In the other, we have severe mucosal inflammation. Systemic steroids is like I give hydrocortisone because it's short acting and less immunosuppressing than the others for severe mucosal inflammation. Cyclosporin is good. You give it at a dose of 3 milligrams per kilogram. Etanercept, as far as RCT, there's one RCT in the adult. It hasn't shown a decrease in mortality. What it statistically significant decrease in mortality. What it has shown is that it hastens the re-epithelialization. As I've said, if it's a high Scorton 5 or more, most of these are not going to be very helpful. Try, you must, you can, but do it judiciously.
The dose of IVIG may be 2 grams per kilogram body weight. It's a team approach between pediatrician, dermatologist, and ophthalmologist.
Yes,
so one more question. Suppose if I'll use an antibiotic that's occurred because of infections, which antibiotic you prefer? That means the antibiotics that not cause this problem. Is azithromycin okay?
No, I don't give azithromycin because usually I go for usually what is not used too much and effective for the skin is linezolid, where most of the common bugs are staph and strep, unless the child has got diabetes or something where you expect Pseudomonas, where you can go and give meropenem. So usually I give something that I'm sure the child would not have it previously, which is linezolid, which I give.
So you
usually
prefer linezolid or meropenem?
Meropenem if you for a gram neck cover, and for the skin per se, for a staph cover, I would give linezolid.
Okay, thank you, madam. So the next question is sorry. Oh, it's coming. So, because I think it's question is to Dr. Anand then, or Dr. Vijay Shekhar, I don't know. What's the strategy to prevent aging? Because we are all managing with children because nobody want aging, change in the skin. Dr. Vijay Bhaskar.
Yes.
Yeah.
See, I have read a famous statement which says that people nowadays want to die young in older age, right? That's what they want. Okay. So you can postpone aging. You can never prevent aging. You can never prevent aging. You can only postpone aging. And best thing is you have to keep your skin clean. That is very important. So cleansing is very, very important. And something with the moisturizer will be a better choice. One. Second, moisturization. Application of moisturizer also helps to have that glow, and it will retain the moisture, and that it will make you look young. That is one. And sunscreens, definitely sunscreens play a major role because our UV radiation can damage the elastic tissue that is present inside, and that can lead to more wrinkles. So sunscreens as a regular usage can take care of your aging, but of course your vitamin D, you have to take care about the vitamin D also. And healthy food. And I think what I mean by healthy food is good amount of vegetables, greens, fruits will help. And particularly, again, the high glycemic foods or carbohydrate rich foods definitely has a role in bringing down the aging. So if you want to have a younger look, it's better to not to go for carbohydrates, rich in carbohydrates. Of course, whatever is essential for the day, that has to be taken, and you can avoid those type of foods. So this will help. And there are a lot of anti-aging creams that are available in the market, like retinol, and so many things are available. Yes, they may help you only transiently, or whenever you apply them, it may help you. The moment you stop them, you can go back to your own skin. So the other things, as I mentioned, cleansing agent, moisturization, sunscreen, and healthy foods. And mostly we don't want to get aged, particularly in adults. If they are having drinking, then it is better to bring down the amount of alcohol they take, because again, that can also age the skin. And smoking, you have to quit smoking in case you have any habit of smoking. Even that has to be brought down. These are the few tips by which you can keep yourself young.
So cleansing agent means you have to wash your body with soap and water, or only with the
Yes,
water?
Soap and water, at least that twice a day you can take bath. That will definitely help. And even the face, it will help in getting you the glow.
Okay, thank you so much, sir. So we can prevent the aging. So pediatricians want to ask, sir said, die as young. Okay. And then next question to Dr. Anandan. So urticaria children, acute urticaria be managed with hydroxyl hydrochloride and H2RA and also adrenaline. But chronic urticaria, most of these patients go to dermatologists. So how will you manage children with a chronic urticaria?
Sir, once the urticaria crosses 6 weeks, then you call it as chronic urticaria in a broad sense. And this chronic urticaria will also include all the eyes that has been found to be the etiological factors in acute urticaria. Apart from all those things, three important things. One is the atopic dermatitis, underlying silent atopic dermatitis, malignancies, severe infections somewhere which has been missed, and connective tissue disorders has to be ruled out for the chronic urticaria management wise. Once you know the etiology, you target the etiology, and this may need a long-term treatment. Apart from the antihistamines alone, nowadays urticaria, they have given a 4-step regimen. First you start with the usual dose of antihistamines. Second stage, you go for about 4 times increase of the antihistamines what you are using. And third, you can introduce steroids and immunosuppressants, finally biologicals. And recently, the stage 4 or the step 4 has been made into step 3, and step 3 has come to step 4. So these are all the various step ladders which can be climbed before you reach a satisfactory treatment option for chronic urticaria.
So which type of antihistamine you prefer, sir? First generation or second generation? Pediatricians always prefer second generation antihistamines. We don't want sedating antihistamines, because if you sedate this child, the mother will come back and say, oh, my child is sleeping. So after your medication, the child is not at all waking up. So we prefer second generation antihistamines. What's your comment about this antihistamine, sir? First generation or second generation?
As a dermatologist, even Renu Madam as well as Vijay Bhaskar will agree with me in this panel that we use both first generation and second generation. Second generation in the daytime and first generation in the night time. So if you make the child sleep in the night time, the mother is very, very happy.
Yeah, that
so
part
you
I
make
agree.
them sleep.
Yes, sir. That part I agree. So, but don't use better not to use first generation antihistamine during daytime.
Yes.
Yeah. Thank you, sir. Okay, then Dr. Vijay Bhaskar. So, last time when you doing Bangalore Pedicon, you were in a vehicle because you were telling that you're coming directly from this COVID duty. So, what's your skin dermatological experience with this COVID-19?
Sir, to be very frank, I have been posted in a place of COVID care center with adults, most of the adults, and they didn't have an opportunity to visit my hospital. Now I'm posted back to the hospital. One. Second is, out from my colleagues from Institute of Childhood, from my colleagues from Dr. Povadigi and all, I got the information that Kawasaki-like manifestations are more commonly seen in COVID children. That's what Madam was telling. And second is, the age group, normally we see Kawasaki disease is up to 5 or 6 years of age group. But now Madam was telling that it was up to 10 years children. They present the same symptoms, and also they had some coronary artery aneurysm. Even the director was telling me that even coronary aneurysms were commonly seen in these children. And of course, there are some patients who have been admitted with vasculitis. This is what I got as a information. I think we can ask Dr. Anandan and Dr. Renujaj Madam to throw more light on this, sir.
So the interesting aspect is that these children presents with a KD-like picture, but they didn't have any symptoms suggestive of COVID. They come late with no symptoms. Antigen may be negative, so you have to test the antibody. But then, okay, government Kerala, they are not allowing the antibody to be tested. So that is the saddest part, because so KD skin manifestations are there in following post-COVID-19. Isn't it like that, sir, in children?
Yes, sir, that's what we are telling. I think Madam and Dr. Anandan can throw more light on that for their own experience.
Madam, what's your experience?
Okay. No, I have no experience with this. I'm in Brunei, so I have no experience. But from what I read, I think what Dr. Vijay Bhaskar said is true, and most of it is thought to be, it's a post-infectious problem, Kawasaki, most of the time, though it can occur with it. And they can also present with exanthematous lesions, even urticaria. You can see a whole scope. And recently there was a child with TN who was COVID antibody positive. So probably, and this is what I saw in a group. So I think post-infectious response can manifest either like Kawasaki or many other skin diseases.
Professor Anandan, your experience?
Sir, 2 weeks, maybe 2 to 3 weeks back, we saw a patient who was an adolescent in our OPD who presented with unilateral purpuric lesions over the, around the ankles, which was referred to as henoxalal purpura. But when a proper history was taken, he had fever 3 days back, and he had severe headache also. And at the time of our examination, he didn't have fever. So we straight away sent him to the COVID OP. He was tested for RT-PCR, and he was found to be positive. So we thought that this purpuric lesion could be a manifestation of that COVID-19 disease. So once he became all right from COVID, and these purpuric lesions disappeared without any much of treatment. So we concluded that that could be a manifestation.
So in the coming days, we have to be more careful that you have to consider this option of COVID also in children with skin manifestations. So, Madam, whether will skin biopsy results in a scar? Because you used to do skin biopsy for everything. So, if so, is there any methods to avoid scar?
Okay, I hope it doesn't result. Every biopsy mine has not resulted in a scar. If you could just go to the next slide. Yeah. So usually we do a 4 millimeter punch, and that we don't expect to see a scar. But I think some of the things that you could check on is whether there is a family history of developing keloids, in which case you would give intralesional steroids and give silicone gel as post-surgery to prevent the development of a scar. And correct surgical technique, of course, is very important. You go along the all the dermatologists are aware of what they need to do, and you have to prevent wound infection along with topical. I think there was a discussion on that. If you're doing an infected lesion, or it's on a site that might get infected, you can also give prophylactic oral antibiotics about 30 to 60 minutes before the procedure. It's usually a cephalosporin.
Thank you, madam. So that means we can avoid scar by this method. Professor Anandan, so how will you prevent scar formation? Madam has said, because do you want anything to be added?
Yes, sir. Can I go to the next slide? Yeah. As madam said, it's all the madam which has already said. You need to avoid injuries first of all. Once an injury has occurred, treat it immediately. Keep the wounds clean, cover the wound properly, and petrolatum jelly can be applied over it. And finally, silicone-based medications can be applied. Why? Because this silicone-based gels, being copolymers, they stimulate the transformation growth factor beta, so that the underlying collagen is stimulated and it is remodeled also to form a good-looking scar rather than an ugly scar. But still, all these things doesn't work if there is going to be a propensity towards an hypertrophic scar or a keloid genetically. So it is very difficult, but still this silicone-based gel will not make any magics overnight. That has to be applied 3 times daily over a period of 3 months. So it needs a lot of, it's quite expensive also.
Is it available? Is it available in the market?
Yes, it's available.
It's costly. It's very costly.
Yes, it's a bit costly for 3 months therapy.
Oh, but but still we have to avoid a scar. That's important. For young children develop scar, then that's a problem. Dr. Vijaya, so what are the most important problems that we usually is molluscum contagiosum? What's the line of management for molluscum contagiosum?
First of all, if just reassure them, if a few are there, we can reassure and observe. But the problem is in pediatric age group,
usually come
whatever
in
you
chronic,
reassure,
crop.
yeah, it
So-
comes in crops, and when you reassure also, they go and visit Dr. Anandan. He is nearby practicing, so that is the problem. So we do that. The actual for the postgraduate we sell reassure and observation, but in practice it's not possible. If a few lesions are there and child is cooperative, needling can be done. And I try a lot of 5 to 10, particularly when child may be cooperative, but parents may not be cooperative. They say, no, doctor, you don't take the needle near the child. So in those type of children, I try to dispense 5 to 10% KOH. In small children, I give 5%, or in 10% for bigger children above 6 years. I prepare the own KOH and give it to them. I ask them to apply it twice daily, once in the morning and once in the night, only over the lesion for a week or two. It causes irritant dermatitis, and then it opens up and throws the molluscum body out. I get good results with that one. And topical salicylic acid, which is used for wart, also has been tried, but I don't try it. And it should not be used on the face also. That is very, very sure. And of course, cauterization also can be used. And we have a video of how to needle the molluscum.
So sir, I couldn't include that video in the
Okay, because I have to thank Dr. Anandan. He was the one who has taken that
sorry,
video.
very sorry.
No issues at all, sir.
Of course, I don't know whether that will work. That's not work. That's not working.
Okay, fine. So that is one thing which we can do. Anyway, I thought, and one more thing, very important thing about molluscum is, if you needle, you can charge also. For each lesion, you can charge 100 to 200 rupees depending on your area of consultation. So I think people will be more, eager to learn about the needling of this particular, right?
Sorry that I couldn't include. And
No,
then,
no,
Dr. Madam, how will you manage your warts in children? Because
okay, if you could just go to the next slide.
Yeah.
Okay. So first of all, you figure out if it's you need to see if it's single or multiple, the age of the child, the site, and whether there's an underlying immunodeficiency. So if it's single or a few warts on the trunk or on the extremities, I would use cryotherapy. I prefer that to electrosurgery or radiosurgery in children, because they see a needle and just get frightened out of their wits. If it's a plantar wart, I would use a concap. That's a salicylic acid impregnated plaster, combine it with pairing and cryo, or maybe even a trichloroacetic acid on the sole, that's fine. Now, if there are multiple warts, I have used candid antigen in the past, and now you have intralesional immunotherapy with tuberculin MMR vaccine. I think that's the only practical option. It's variable efficacy, but it appears to be relatively safe. When you're looking at facial warts, you have two options. If they're very thin, rather flat warts, you can try topical tretinoin. You need to use it for a long period of time. If they're slightly more hypertrophic, I use touch cryo. So this is in essence my management of warts.
Could you please elaborate this one? Intralesional immunotherapy with the tuberculin. What is that, madam? Yeah, what is that, madam?
PPD, with PPD, what you do is what you need to do is first you induce an immunogenicity. So you give an intradermal, like you do the usual PPD that we do, and look at the reaction at the site. If the patient is not anergic, that is, there is a reaction at the site, depending upon the induration, you can titrate the intralesional tuberculin that you give. So you usually give it onto the largest lesion. And what happens is that even the distant, you give it to the largest lesion, you need to continue it a variable interval of time, minimum of 1 week. Some people give it once in 3 weeks. And distant warts also regress in time. But as I said, it's a variable efficacy. If the patient is anergic, then there's no point in doing with any of these, tuberculin, candid, and whatever you're using. If it's anergic, you have to switch to something else.
Thank you, madam. For facial warts, you will give tretinoin. Facial warts, you will give topical tretinoin. You will give. Thank you, madam. Now, question is that, and Dr. Anandan. So because, rheumatology, we usually depend upon the skin. There are so many skin manifestations for rheumatic disorders, rheumatology disorders, maybe what do you call, starting from KD. So you have so many manifestations. So what are your skin manifestations that are things you usually look in this condition?
Sir, first of all, rheumatism is a systemic disorder where we have some cutaneous findings. And in dermatology, this cutaneous findings can give only a clue, but it cannot say that you just look at it and you make a diagnosis of rheumatism, because even the molluscum contagiosum, which says, yes, I'm here, has got a very close differential diagnosis, so that it has to be thought of. But rheumatism, these are the common things which usually occur. either a painful digital ulcer in the tip of the fingers, or livido reticularis like, that is net-like pattern rash, which is not painful, not tender, and the nail fold infarcts, apart from the usual findings of the rheumatism. So once these findings are there, this is giving only a clue to the diagnosis, and you need to have a workup for the confirmation of the rheumatism. So this can be the common cutaneous findings which can give a clue.
Gottard sign, heliotropic rash. So I think I completed all the, at the time 1 hour I am allotted, and I completed all the questions. I would like to thank all the panelists, Professor Dr. Renu George, Professor Dr. Anandan, Professor Dr. Vijay Bhaskar, and all the more. Two important people, Dr. Hari Kumar and Dr. Jijo, in addition to the organizers. And thank you all. And also our president, Dr. Narayan and Dr. Balachandar. Thank you so much. Any questions?
Yeah. Sir, actually, you're a wonderful moderator, sir. I'm a very poor moderator. I saw that in Dakshin Pedicon. And actually, I really thank the entire team, because I know everyone there, whoever is there. And the entire team, I would like to thank for the opportunity given. Thank you. Thank you, one and all, sir.
Thank you, sir. It was an excellent presentation. By the time Jaikumar sir just glances through the questions which has been answered on the asked on the chat, I would like to share the video of the needling which Anandan sir has sent it.
Thank you so much, sir, because I unfortunately I want to ask questions before the video or after the video.
So after by the time the video is playing, sir, you'll be able to.
I'll go to it.
Is it visible?
Yeah.
So this video actually was sent by Dr. Anandan. It was made by Anandan and it was sent.
Chat എടുക്കുന്ന എങ്ങനെ പഴയത് പഴയ ചാറ്റ് സലിക്ക്
The needling was done. I think the video went rapidly, and they are squeezing the molluscum body out. So 200 rupees, sir. 200 rupees for that. Okay, for each lesion.
Vijay Bhaskar, I charge 500 per lesion.
Okay.
It's a money-making issue.
We'll just show it once more.
Yeah, I think the needling was not. It passed away. The video passed away very fast.
Yes, the video was very fast, rapid.
So you have to take the needle. An ordinary disposable needle is more than sufficient. And then go through and through and through and through, and then you just remove it. And then you can open it up, and you can squeeze with your own hands, or you can go with a squeeze like this. The white body that comes out is the molluscum. That is the molluscum body that comes. Once it comes out, there may be mild bleed sometimes. Just you give small pressure, it will become all right, and they are cured now. This is courtesy Dr. Anandan, this video.
Thanks for the acknowledgement, Vijay Bhaskar, but it's all common property.
Thank you, sir.
So one question is that what's the percentage of salicylic acid that you have to use, in what and how long we have to use? Nobody can answer.
Can I take that?
Yeah.
Yeah, you can use 16.7% salicylic acid with lactic acid in a collodion base. We apply in the night over the lesion. You can wash it off.
Okay, 16%.
16.7% salicylic acid. It's
this
available.
Combination is commercially available.
Yeah. Next question is 1 second. Sorry. Yeah. What is the preferable sunscreen which you use in your practice? That's one question, Dr. Anandan sir.
Sir, I personally use a sunscreen which contains or which can block both UVA and UVB, and which has got a maximum sunscreen, sun protection factor, that is SPF 50+. Why? Because if it is to be very precise, if you are likely to get sunburn within 10 minutes, if you are going to use a sun protection factor cream with 15 or 15+, you need 150 minutes for the the skin to get burned. So I use 50+ sun protection factor, with both UVA and UVB, which contains titanium dioxide for UVA and our benzone for UVB protections. So,
sir, excuse me, sir. Sir, Jaykumar, sir.
Yeah.
Sir, yeah, we can't. No, we have two more speakers.
Yeah.
So
Well, last question from my friend,
yeah,
Jose want to know which antibiotic you use for secondary bacterial infection, sir. So, which antibiotic you prefer for secondary bacterial infection? Can anyone can say? Ceftriaxone or cephalexin, and then cephalexin, and
I prefer cephalexin, sir.
Yeah, you prefer cephalexin. But the complaints is the issue, sir. You have to give 4 times per day. Your children won't take 4 times per day.
Sir, we very well know that they don't take, at least we calculate the dose for 3 times and give it, sir. To be very frank, it works,
okay.
really works.
Thank you, Dr. Hari, Dr. Jijo, and all the organizers for giving me the opportunity. Thanks once again. Thanks the panelists. Wonderful answers. Wonderful answers.
Thank you all.
Rest of the questions we can manage after 2 talks and 2 more speakers. After that, there will be 1 more question answer session. We will be deliberating there. Okay.
Okay. Thank you, Hari. Thank you, Hari.
Thank you, sir.
Thank you.
As much as possible, Vijay sir has answered many of the questions on the chat box. The ones which are left out from the chat box, we'll try to take up in the last discussion session. Thank you, Jaykumar sir, for an excellent session. Many of the questions which they had asked even before the session had been started have been answered throughout the panel. It has been a very enlightening session. After the panel discussion, now we are moving ahead to the next talk. I would like to invite Dr. Naushid to introduce the next chairperson.
Can you audible?
You're audible.
And next our topic is common skin changes in neonates when to treat by Dr. Nafina. Now I invite Dr. Rajendra Prasad, our Vice President of IAP Kerala, to chair the session. Over to you, sir.
Rajendra Prasad, sir, kindly unmute yourself, sir.
Okay. Yeah.
You're audible, sir.
After the wonderful panel discussion by Dr. Jaykumar, let's move to the common skin infection in neonates. Before we go to the topic, first me thank Dr. Roy Alexander, Jijo, Binukutan for this chance for chairing this session. The next speaker is Dr. Nafina Jasmine. She is a consultant dermatologist and cosmetologist, PRS Hospital, Trivandrum. She got her MD from Kasturba Medical College, Manipal, and she is a faculty in different conferences and workshops in national and state level. She has also received Best Speaker Award from the institution in 2018-2019, and she is contributed a chapter in our newsletter. Also, her areas of interest is aesthetic dermatology, dermatological surgery, pediatric dermatology. And today's topic is common skin infections in neonate when to treat. Over to Dr. Nafina. Thank you.
Thank you, sir, for the introduction. Very good afternoon, everyone. I thank IAP Kerala Dermatology Chapter and IAP Pathanamthitta for giving me this opportunity. So today my topic is on common skin changes in a neonate, when it is to be treated and when the treatment is actually not necessary. So before going to the topic per se, let me just say a few words about newborn skin and how it is different from the adult skin. So most of my pediatrician friends, they end up coming to me, breaking their head, telling, dermatology part is quite difficult to remember. It's quite confusing. So to make it simple, I've just highlighted the key differentiating features of the newborn skin with that of the adult skin. So the first differentiating point would be that the epidermis is loosely adherent to the dermis beneath in your newborn skin. So there's more chance of blistering in a newborn skin. The second point would be the increased permeability of stratum corneum, which is the topmost layer or the uppermost layer of the epidermis. So because of this reason on increased permeability, there's more chance of transepidermal water loss, or that can result in dryness. And also there is more chance of temperature instability because of this permeability, and also increased percutaneous absorption happens because of this increased permeability. So we should be very careful when we give any topical application. It has to be done judiciously so that there's not much of increased absorption and does not result in any toxicity. The third point is that the epidermal barrier is not fully developed as in an adult skin. So the skin would be more susceptible to microbial attack and more reaction or increased reaction to any sort of irritant applied to the skin. So you should be very careful on that. And the fourth point, another very important point, is the acid mantle of the skin. The newborn skin has got an acidic pH of 5. So anything which increases the pH or increases the alkalinity can cause further damage to the skin. So I broadly classify the conditions into transient conditions, which include the physiological ones, such as the vascular phenomenon, also other physiological conditions like vernix caseosa, milia, sebaceous hyperplasia, etc. And also transient vesicular pustular eruptions, which are non-infective. And the second category would be the infectious conditions and the infestations. And few other miscellaneous, where I've included the eczematous conditions like seborrheic dermatitis. So among these, the transient ones, including the physiological ones, since they are self-limiting or they spontaneously disappear, they do not require any treatment. And the infectious conditions and the infestations and the inflammatory or eczematous conditions do require treatment. To begin with the first set of conditions, the transient vascular phenomena, as you're already familiar with, the cutis marmorata and the harlequin fetus. Yes, the baby presenting with reticulated mottling due to a vascular response to cold, and it resolves with warming where no treatment is required. That's the case of cutis marmorata. Sometimes it can persist for a longer duration, then it is called as the cutis marmorata telangiectasia congenita. The next condition, when the baby lies on the side, there's erythema of the dependent side and blanching of the contralateral side persisting for around 30 to 60 seconds. And this can resolve with muscular activity or crying. Yes, that is a case of harlequin color change. Usually seen in low birth weight babies around 2nd to 5th day due to imbalance of the autonomic mechanism of the cutaneous blood vessels. It happens. Another vascular phenomenon or a vasomotor change, which is benign, which results in peripheral vasoconstriction and increased tissue oxygen extraction, resulting in peripheral cyanosis, as you can see in this picture. Yes, that is a case of acrocyanosis. Acral stands for the extremity, so it's seen around the extremities and around the mouth, and it can be seen in healthy newborns and persists only for around 24 to 48 hours. Okay, next set I was talking about were the vesicular pustular eruptions, which are transient and which are non-infective. So first condition, presenting with papules, macules, pustules, and usually not seen on palms and soles and seen on other areas like face, tongue, and extremities, giving the characteristic flea-bitten appearance, quite common. Yes, that is erythema toxicum neonatorum, seen in 50% of term, and it is a misnomer because it is not toxic in origin. Starts around 24 to 48 hours, and waxing and waning can happen in a week's time. Test, as you all know, the key cell or the characteristic cell found as eosinophil on right or Jameson stain, and peripheral eosinophilia can be seen. The baby is healthy, so no further workup or no specific treatment required for this condition. Another condition presenting with a pustule which can rupture, leaving behind this characteristic hypopigmented macule in 3 to 4 weeks time, associated with characteristic colorate of scale can also be seen. Yes, so it is a pustule leaving behind the macule, so it is pustular melanosis. So since it's transient neonatal pustular melanosis. Etiology is unknown, seen in 5% of term black patients and less than 1% in whites. Test neutrophil is the characteristic cell in right stain, and even though it's a pustule, it is a sterile condition, and so bacterial culture would be negative, the baby would be healthy, and again no further workup required for the condition. So just to differentiate between these two, an erythema toxicum neonatorum 24 to 48 hours it appears, and pustular melanosis seen at birth. erythema in this condition, and as I mentioned, pustules in pustular melanosis. Palms and soles not involved, usually not involved. Here it may be involved. And erythema toxicum neonatorum usually resolves without sequelae. Here it resolves with hyperpigmentation of the macule. Eosinophil the key cell and the neutrophil the key cell in pustular melanosis. Miliaria, another common condition due to obstruction of the sweat or the eccrine duct seen in warm weather or and associated with fever. Again, various types of miliaria, which are miliaria crystallina, rubra, and pustulosa. Crystallina, as the name mentioned, you can see clear vesicles, and usually not much of redness is seen. Miliaria rubra, again, as the name mentioned, rubra stands for red, so red papules, vesicle, and this is what we commonly call as a heat rash or the prickly heat commonly seen on the covered areas. Another variant I was mentioning was the pustulosa. As the name mentioned, it presents as pustules on these covered areas. So because this is because of humid environment and overheating, management would be basically to avoid overheating, removal of excess clothing to keep the body cool. We can keep cooling baths and air conditioning. Another neonatal condition presenting with the characteristic closed comedones. It's called as a closed comedones, and with few erythematous papule. This is a case of neonatal acne or acne neonatorum with the typical lesion I mentioned, that's the closed comedones. So basically it's because of the stimulation of the sebaceous glands of the skin by the maternal androgens. Usually resolves spontaneously, but sometimes it can persist for a very long period and it can be very extensive. We can give a trial with 2.5% benzoyl peroxide with a minimal application, but make sure you try it on an antecubital fossa area or something to see for any sort of local irritation before applying directly on the face. Another variant of neonatal acne presenting with more of pustules instead of the comedones, which are seen in acne. Here comedones are not seen. Here more of pustules and papules are seen, as you can see in this picture. This is a case of neonatal cephalic pustulosis. As I mentioned, it's a variant, no comedones. Here it is more of fungal in origin. The pityrosporum fungus acts here. So it's a form of pityrosporum folliculitis. I've already mentioned these points. Again, this resolves spontaneously. I mean, if it's persisting, maybe you can give a trial with topical antifungal. Another quite common condition presenting with pearly white yellow papules because of the retention of keratin seen in almost 50% of newborns. Yes, that's a case of milia, and commonly seen on the face areas like forehead, cheeks, nose, chin. And sometimes a similar picture is seen, but on specific area, that is a seborrheic area around the nose or the perinasal area and around the mouth, the perioral area. You can see the seborrheic area. And yes, that's a name given for that is seborrheic hyperplasia because of the hyperplastic sebaceous glands. Again, both these conditions are benign and self-limiting. They disappear spontaneously, so simple reassurance would do. Vernix caseosa. Do you know what vernix means? It means to varnish. And caseosa comes from caseous. Caseous means cheesy. So it's called as a creamy, cheesy coating seen on the neonatal or newborn skin, which acts as a biofilm. And this is a lipid-rich material. And basically, this is for the postnatal adaptation of the baby's skin. So it has various advantages, like it prevents water loss, it prevents temperature loss, and other properties like anti-infective property, antioxidant, and it can give a moisturizing effect also to the skin. So what happens is this HPA axis is the one which regulates the sebaceous gland activity in utero, producing the sebum. So around third trimester of pregnancy, the gland activity peaks. So this increased sebum production along with the desquamated corneocytes. Corneocytes are the cells of the topmost layer, which I mentioned, the stratum cornea. So the desquamated corneocytes along with the sebum actually forms the true vernix, which gives this coating. Applications in hemolytic disease of the newborn and post-maturity, the color would be different, which is a golden yellow color. In fetal distress, again, the vernix is stained by the bile pigments in the meconium. And in very low birth weight babies, the stratum corneum is incompetent. So it lacks a proper stratum corneum. So there's not much of shedding of the corneocytes, so it lacks the proper vernix. The next condition, this is an eczematous condition presenting with erythema and greasy scale on the seborrheic areas like the face, the perinasal, eyebrows, the retroauricular area, the intertriginous areas or the folds. Yes, that is a case of seborrheic dermatitis. I mean, it predominates on the scalp. It is given the name, as you all know, the cradle cap. Fungus plays a role, the Malassezia fur organism, and hormonal fluctuations do play a role, and that is why it is seen on sites which is dense in sebaceous glands. And if it is associated, or if the baby is sick and associated with diarrhea and FTT, you have to evaluate for immunodeficiency condition called as the Lainer's disease. Now, how do you manage a case of seborrheic dermatitis? It can be self-limiting if it is minimal. And if it's persisting, start with the basic remedies like overnight application of oil. Then next day, go for shampooing with mild baby shampoo. Then if possible, whichever removable, remove the scales with a soft brush, but not vigorously. And you can add on a topical antifungal. Still, if the inflammatory component, erythema component is persisting, you can add on another mild steroid cream like hydrocortisone or dasanide. Make sure it is a mild steroid cream and not a potent one. Maybe a period of 3 to 5 days would do, not more than that. Okay, now moving to the next set of conditions, the infections ones. Bacterial. As you all know, Staph aureus is the most common organism causing cutaneous infections. So that can be localized as well as systemic. Localized, quite common condition presenting with bulla, pustules, and crusted erosion, may be associated with fever, which can heal without scarring. That is a case of bullous impetigo. But in neonates, it may not be localized. It can even get widespread, because of which it was previously even erroneously called as pemphigus neonatorum. Systemic condition, ill-appearing child, blistering desquamation with fluid electrolyte imbalance and resulting in temperature instability, giving this scalded appearance with erosions. Yes, that's a case of staphylococcal scalded skin syndrome. Infectious source being conjunctiva, nasopharynx, omphalitis, and the staph producing the toxins called as exotoxin A and B. And these exotoxins are epidermolytic, which further causes exfoliation and blistering. So by epidermolytic, what do I mean? So this is the structure of skin, or epidermis of the skin. You can see the layers, stratum basal or the basal layer, stratum spinosum, the stratum granulosum, and this is the stratum corneum. So you can see the attachment between the cells. So these cells are attached to each other with the help of these blue structures and the yellow structures. These are nothing but desmogleins. Desmogleins are desmosomal attachment between the cells of the epidermis. So when these exotoxins are produced by the staph, it destroys these desmoglein attachment between these cells, thus resulting in blistering and bullae formation, ultimately desquamation and erosion. Management, anti-staphylococcal antibiotics in the penicillin groups or cephalosporin groups, fluid electrolyte balance, and temperature maintenance. The next set would be the viral. Presenting with characteristic grouped vesicles on the presenting part of the baby, like the face and the scalp. It can be associated with oral erosion as well. The grouped vesicle is a characteristic terminology given to this viral condition, that is the herpes simplex viral infection. So transmission usually from the genital tract during time of delivery, or ascending infection from premature rupture of membrane, and higher incidence is usually seen in mothers with first episode of HSV infection. Diagnosis, you go for a Zang smear in microscopy, you can see the multinucleated giant cell, but the gold standard or the test of choice would be PCR, which detects the viral DNA. Prevention, if you're suspecting, go for cesarean section and avoid normal vaginal delivery. Treatment, IV acyclovir 20 milligram per kilogram per day, thrice, or 60 in 3 divided doses, can give up to 14-21 days depending on the extent of lesions. The next set presenting with papules, all the different type of lesions, papules which can progress to pustules, scaling. Usually the premature and very low birth weight babies are at risk. This is a case of congenital candidiasis. Again, predisposing factors such as ascending infection of chorioamnionitis can play a role. Now, cutaneous candidiasis can be either congenital or neonatal. So congenital when it's acquired intrauterine, and neonatal when it's acquired at the time of delivery or just immediate postnatal. Neonatal candidiasis, you have to see for white flaky patch in the oral mucosa. So diagnosis confirmatory test would be potassium hydroxide mount under microscope. You can see the yeast and the pseudomycelia. Treatment, just the topical antifungals with clotrimazole and miconazole. It has an excellent outcome. Not common, but I've included it here in the infectious condition because of the characteristic clinical feature of tense blister or the vesicular bullous rash, typically seen on the palms and soles in the child, and oral mucosa can show the characteristic patch or the ulcers. That is a case of, any guess? Okay, that's a case of, yes, congenital syphilis. So diagnosis, serology, go for the VDRL, and dark field microscopy shows characteristic corkscrew mobility of the Treponema pallidum. Treatment, benzathine penicillin, a single IM dose of 50,000 units per kg would be enough. Okay, again, another condition. Again, I've included torch here, again, not very common, but because of the characteristic feature of the blue reddish nodules seen on the trunk, face, extremities, giving the blueberry muffin appearance. Yes, that's a case of CMV infection. And also the blueberry muffin appearance can also be seen in another torch infection, which is congenital rubella, with the triad of sensory neural hearing loss, eye defects, and cardiac defects. Infestation. Neonatal scabies, as you all know, caused by the Sarcoptes scabies mite. But unlike in adults, there are few changes in the neonatal scabies. Start with the eruptions, the site of involvement. The site of involvement, it includes additionally scalp, face, neck, and palms and soles. Unlike in adults, usually scalp, face, and neck not much involved. And the lesions, again, it takes various forms. First, papules, vesicles, and this can have the tendency to go into pustule formation, which ruptures, leaving behind crusting and even scaling. So it gives an appearance, an eczematous appearance or secondary eczematization. Diagnosis usually missed or delayed as the neonates do not itch. The rash can get extensive and it spreads rapidly. So the child would be irritable with poor feeding and failure to thrive. So to confirm the diagnosis, again, KH mount, go for microscopy, you can see either the mite, eggs, or the fecal pellets. Treatment, 10% crutametone lotion or cream on 3 to 5 consecutive nights, or the latest study even says permethrin 5% cream can be given, but it has to be given for a very shorter duration of 2 to 4 hours. A single application would do, maybe it can be repeated after 10 days. A relatively rare condition, but I've included here as a DD for scabies because of clinically similar picture on the palms and soles or on the acral area, intensely pruritic, tiny vesicles or pustules in the acral area, last more than 15 days. This has a tendency to recur every 2 to 4 weeks, but this remits spontaneously by the age of 2 to 3 years of age. So those were the conditions I mentioned. Just to brief it or summarize, the transient ones including the transient vascular phenomenon and other transient, other physiological conditions like the Wernicke's caesusa, amelia, sebaceous hyperplasia, and the transient vesicular pustular eruptions which are non-infective like erythema toxicum neonatorum, pustular melanosis, miliaria, acne, and the cephalic pustulosis. And the infections ones like bacterial, viral, fungal, and the spirochetal, and infestation scabies, and the eczematous conditions like the seborrheic dermatitis. So among these, the transient ones and the physiological ones, which are self-limiting and spontaneous, need not be treated, and the infectious ones and the infestations and the eczematous conditions have to be treated. So these are the the neonatal dermatosis has a very big list of innumerable conditions, but these are all quite rare. So I've not mentioned it, like the genodermatosis, like ichthyosis, epidermolysis bullosa, incontinence pigmenti, the nutritional conditions like acrodermatitis, enteropathica, then erythroderma is another serious condition or fatal condition, like the congenital ichthyosiform erythroderma presenting as colloidal baby, the harlequin ichthyosis. Various immunodeficiencies like the Omen syndrome, Viscodaldric, and developmental anomalies and the nevi, etc. So thank you.
Thank you, ma'am.
Thank you, Dr. Nafina. Okay. Thank you, Dr. Rajendra Prasad, sir, and thank you, Dr. Nafina, for the excellent talk. And we are coming to the fag end of the session, and the last talk, last but not the least, as we say that it's an important topic, that is hypo and hyperpigmented lesions in children. And to moderate the talk, moderate the session, we have Dr. Priya Srinivasan, who is the associate professor of pediatrics in Government Medical College Trivandrum. Not only that, other than that, she is our secretary of IAP, our prestigious branch of Trivandrum, and who is doing an excellent job as secretary in Trivandrum and our Trivandrum branch. So I invite with pleasure our Dr. Priya Srinivasan to moderate the talk on Dr. Jareen Matthews' hypopigmentation, hyperpigmentation.
Thank you, sir. Thank you, sir, for that nice introduction. And first of all, let me congratulate the organizers for the excellent conduct of this state conference. And I thank the organizers for giving me this opportunity. And the next talk is by Dr. Jareen Matthews. She has completed postgraduate training in dermatology from JIPMER and is the first pediatric dermatology fellow trained from JIPMER. She is currently working as the consultant pediatric dermatologist at Believers Church Medical College in Tiruvalla, Kerala. Her areas of special interest and research include atopic dermatitis and genodermatosis, and she has been a speaker at pediatric dermatology conferences on the same topics. She has completed ICMR training in molecular diagnostics and counseling in genetic disorders. She has publications in international journals in the area of pediatric dermatology, and she's a reviewer for the International Journal of Dermatology. So over to you, Dr. Jareen Matthews, for the next talk.
Thank you, ma'am, for that introduction. Am I audible?
Yes. Yes, you can start.
Shall I share the screen?
Yes.
At the outset, I'd like to thank IAP Pathanamthitta, the organizers, for this opportunity. It's really wonderful to share a forum with my teacher, Jayakumar sir, with senior dermatologists that I look up to, like Dr. Renu, Dr. Anandan, and Dr. Vijay Bhaskar, and also to Dr. Saumya, who I've always looked up to since the time I was aspiring to be a dermatologist. To proceed with my topic, today I'll be presenting a brief approach to hypo and hyperpigmented skin lesions in children. It's a very wide topic, so I'll be giving a few questions that we can look at in history as well as examination to come to a diagnosis. So I'll be mostly focusing on the diagnostics. So the first question is, what affects skin color? The obvious answer is, of course, melanin and melanocytes in the epidermis, but also the presence of hemoglobin in the dermal vessels influences color. So as we have already seen, a local vasoconstriction can produce hypopigmentation. Then epidermal thickness also affects skin color. Thickening of skin can produce hyperpigmentation, such as we'll see in acanthosis nigricans. And last of all, we can have pigments in dermis as well. So the melanin can be abnormally present in dermis. That's called melanin incontinence. Melanocytes may be sometimes present in dermis, and sometimes we may get drug deposits and tattoos. So first we'll be looking at localized hypopigmentation. For the purpose of this talk, I'll be covering only localized lesions and not diffuse lesions. So when there is localized hypopigmentation, which is a common problem in our OPD, what are the points that we can look at in history? The first question is, of course, when did it start? Is it congenital or acquired? Is it post-inflammatory, or is the pigmentary change the primary process? The primary process, as we shall see, is always important. And has a lesion been modified by therapy? So, of course, topical steroid application is a frequent cause of hypopigmentation. So, these three questions in history are often helpful. In examination, we look for the distribution, the morphology of lesions, that is, what are the margins like? Are they well defined, or are they diffuse or blurry? And are there any other changes in the hypopigmented lesions? That is there any scaling? Is there any atrophy or other textural changes? So as we see individual cases, we'll be going through these 6 questions again and again. So first we'll be looking at the acquired hypopigmented lesions. This is an adolescent boy who presented with asymptomatic hypopigmented macules over the upper chest and also the neck and upper back. And if we look closely in this inset, we can see that the margins of these lesions are well defined and they are scalloped. So this is the appearance of scalloping, and this border is very typical for tinea versicolor. This is another adolescent girl who presented with hypopigmented macules over the arm. So this is the arm. Here we can see instead of being scalloped, there are tiny lesions which are perifollicular. So these are early lesions of tinea versicolor. They start around the hair follicles, and when they coalesce, we get the typical scallop lesions. Another sign that we can look for in tinea versicolor is, in all of these lesions that we have seen so far, is evoked scaling. So just stretching with the thumb and the forefinger or scratching those lesions with a glass slide will produce a fine white scaling. And this phenomenon is referred to as evoked scales. So this is also a picture of tinea versicolor. It's an infant, and when we look at this one lesion closely, we can see again the margins are well defined and they are scalloped. And it's very typical to get hypopigmented tinea versicolor on the face of infants. This is because infants have seborrhea under the influence of maternal androgens as well as the adrenal androgens. So infants usually get tinea versicolor, and this is a very typical site, the medial canthus of the eye. So how to answer the question of is it tinea versicolor? Seborrheic distribution is important. So all the lesions we have seen so far were on the face, upper trunk, the upper chest, or the upper back. Infants and adolescents are particularly prone because of seborrhea. Children in the in-between age group can also get tinea versicolor. It's not as common. Well-defined scallop margins with early lesions being tiny perifollicular lesions, and finally evoked scaling. Now this is another common hypopigmented lesion of the face in children that we see in OPD. We can see here there are hypopigmented macules which don't have very sharp borders. They are diffuse borders. Again, here we can see the same thing. This is pityriasis alba. So pityriasis alba is typically has diffuse borders and it is scaly. And the usual history is of that of spontaneous remissions and relapses. Usually affects infants and older children. And in addition to the face, the trunk and limbs are also often involved. So how to identify P. alba? The blurred or diffuse nature of the borders and the fine scaling. The pityriasis alba has been linked to atopy, so it's more common in children with atopic disorders, but non-atopic children can also develop pityriasis alba. Now, two other things to also consider when there are hypopigmented lesions on a child's face. First is polymorphic light eruption, and the next is Hansen's disease. So this is a picture of a child, and this is that of an adult with hypopigmented lesions at the typical site, that is over the zygomatic and the temporal area. So this is a site with a lot of UV exposure when you go out in the sun, and this is polymorphic light eruption. So PMLE is usually pruritic, and it has a relapsing and limiting history. Sometimes we may get a history that there was an unaccustomed sun exposure, but we often don't get that because children play outside all the time. And the site is usually typical, that is over the cheek and the temporal area, and also at other photoexposed sites like the upper back and the extensor aspect of forearm. Now, infants don't get PMLE. It's usually seen in older children and adults. And polymorphic light eruption is characterized by papules and plaques. So it is not flat. There are papules which coalesce to form plaques, and it's usually scaly. And the plaques develop a central hyperpigmentation, which we can see in this picture here. Well, the periphery remains hypopigmented. So this is polymorphic light eruption. Here it's predominantly papillary over the extensor aspect of the eye. Now, any persistent hypopigmented macula in children, of course, our worry is indeterminate Hansen, because indeterminate Hansen is, they are flat lesions, they are not plaques, and you may not get the typical features of Hansen's. And it can occur on the face, buttocks, or limbs. So how to approach it if you are suspecting indeterminate Hansen? We can ask for history of contact with Hansen disease in the family. Sometimes it may be necessary to examine the family members as well. So in the child, we can look for two things, that is loss of sensations. Temperature sensation is lost earliest. So even if pain or touch is intact, always look for temperature sensation. And thickening of peripheral nerves. Around the pars, there may be thickened feeder nerves, or particularly on the face, you may look for the thickening of the greater auricular nerve. And if these are not conclusive, both are not there, we can do a biopsy. And a biopsy usually does not have well-formed granulomas in the case of indeterminate Hansen, but a few acid-fast bacilli can be seen, or a nerve involvement can be seen. But many times it happens in indeterminate Hansen that you do not get a conclusion either from examination or from biopsy. That is, sensations are not lost, nerves are not thickened, and biopsy is inconclusive. So in such a situation, what do? We can wait and watch. Usually an observation for 3 months will clear things up. Either indeterminate Hansen.
Dr. Jareen, can you speak a little louder?
Yeah.
Oh, sorry. Yes. In indeterminate Hansen, an observation for 3 months, if you're still suspecting indeterminate Hansen, is useful. There can be either spontaneous healing, or it may evolve to either a lepromatous or tuberculoid spectrum. At which point of time we may get specific features like infiltration of lesions or sensory loss, or in the lepromatous spectrum, there will be increase in number of lesions. Am I audible now, ma'am?
Yes, yes.
Yeah.
Thank you. So another doubt that the patients always have, and of course we also have, is this vitiligo? So as we have already discussed, Renu ma'am has already discussed, the vitiligo is depigmented lesion. So that we have to differentiate between hypo and depigmented lesion. And an acquired depigmented lesion is often vitiligo. Of course, congenital depigmented lesions, which look similar to this, is P-pallism. And lichen sclerosis atrophic is another cause of depigmented lesions, but this is usually associated with atrophy or fibrosis, and LSA is most common in the genitalia. But also we have to remember that when topical steroids have been applied, some amount of atrophy may be present even in vitiligo. So our confusion is not when vitiligo presents with depigmented lesion. Early lesions may be hypopigmented and may have diffuse borders. So here in this picture, we can see on the right side, there are hypopigmented lesions, while here we have the typical depigmented lesions. So when it is hypopigmented, it can be difficult to differentiate. So what do? We can look for some clues. So there can be leukotrichia, that's whitening of hairs, Kubnerization, that is development of lesions along lines of trauma. Halo nevi, so this is an adolescent who had hypopigmented macules on face, but on the trunk there was hypopigmentation and depigmentation developing around melanocytic nevi. So if any of these clues are present, we can still make a diagnosis of vitiligo. But what if you're not sure? It is always better to wait and watch, because the diagnosis of vitiligo carries a lot of stress and social stigma. So we can watch and wait. Biopsy does not help in such cases. So the next most diverse group is, of course, post-inflammatory hypopigmentation, and it is particularly a problem in Indian skin. It's a frequent problem in dark skin. So the question is, was there a primary process before the pigmentary changes appeared? For that, the history is most important. Was it preceded by redness, scaling, raised lesions, or oozing? And an older child may give history of itching or burning sensation. And the distribution of the hypopigmentation often gives a clue to what the primary process was. So this is an infant who had some hypopigmented macules on the upper chest. Here we can see that the adjacent hypopigmented areas also have some red raised lesions, and it is also scaly, though not apparent here. And the child also had a follicular eczema, that is mild hypopigmentation and scaling, that is around the hair follicles over the abdomen, and also red scaly lesions over the chin, and it was present also over the cheeks. So here the diagnosis was infantile atopic dermatitis, and infantile atopic dermatitis is a common cause of hypopigmentation in this age group, and particularly over the cheeks, the anterior or posterior aspect of trunk. Now this infant presented with complaints of hypopigmentation over the neck creases, but on examination actually there was erythema within the creases. So in this site, the common dermatitis we expect is seborrheic dermatitis, and Candidal intertrigo may also produce a similar hypopigmentation following resolution. These are two children with linear hypopigmented lesion. In the first child, they are papillar lesions. So the history is that these lesions have progressed to form a line over the past few weeks. Second child, the lesions are a few months old, and here instead of papules, we are getting flat hypopigmented lesions. So both of these are Blaschko-linear. We'll come to Blaschko's lines later. And so these are acquired Blaschko-linear pigmentation in a child. The diagnosis is lichen striatus. So just to emphasize the importance of patterns in hypopigmentation, these are two different infants. The first infant had hypopigmented macules with some degree of atrophy over the forehead, temporal area, and the root of the nose. And the second child also had a hard block, and again slightly atrophic hypopigmented macules in a similar distribution. And there was a history that these lesions were red previously. So from the periorbital distribution and the history of hard block, the diagnosis is of course a neonatal LE. So coming to the last cause of hypopigmentation, of course, topical steroid application. We see a lot of over-the-counter use of triple or even quadruple combinations with two antibiotics. And as ma'am has already said, if we are using a combination like this, it means there is no diagnosis. So generally for triple or such combinations, there is usually there is no justifiable situation to use these topical preparations. So to make the diagnosis of a post-steroidal hypopigmentation, history is key. There is usually a history of over-the-counter treatment, and withdrawal of topical steroids is necessary so that the primary disease can become apparent. But it's important to warn the patient that, particularly the parent, that the skin lesions will worsen as the primary disease becomes more apparent. Some clues to steroid use include atrophy of skin. As you can see in the picture here, the vessels have become more prominent. There can be an acneiform eruption, there can be striae or stretch marks, telangiectasias, and localized hypertrichosis. All suggest a topical steroid use. So next we look at congenital hypopigmented lesions. Pigmentary mosaicism is characterized by either macular or hypo or hyperpigmentation present in typical patterns that stop in the midline. And these are present since birth or become apparent early in infancy. So these pictures are useful to look at non-usual patterns, that is Blaschkoid, segmental, and phylloid. So in the first line, we have the common patterns. This is an adolescent girl who has had these hypopigmented lesions since infancy and they are not progressing. There is a midline demarcation and the pattern is a broad Blaschko-linear. Again, an infant with hypopigmented lesions with the pattern that stops in the midline. Again, this is the phylloid type of pigmentary mosaicism. So these pictures show how Blaschko's lines look in the body. These are the lines of embryonic migration of epidermal cells during the fetal life. And this pattern is shown by both congenital as well as acquired lesions. So the question is, why do we need to identify mosaicism? It is important because in a minority of patients, this is associated with abnormalities of other organ systems as well. Most common are musculoskeletal, particularly limb asymmetry and CNS abnormalities, usually presenting as seizures or developmental delay. Less commonly, eye, tooth, or cardiac defects can also be seen. But these are in a minority. Mostly pigmentary mosaicism is confined to skin. So these are some other Blaschko-linear hypopigmented lesions. Here the lesions are slightly depressed and this is associated with the dermal hypoplasia along with other skeletal and CNS defects. So this is Gold syndrome. This is Blaschko-linear blistering in an infant, and this is a case of incontinentia pigmenti. And it is important to identify this in the infancy because it produces retinal vascular abnormalities similar to retinopathy of prematurity. So it needs to be picked up early and treated to prevent blindness. This becomes hypopigmented usually by adolescents and not in infancy. So these are few other causes of Blaschko-linear hypopigmentation just for completion. Now this is the last of our hypopigmented lesions. So this is a well-defined hypopigmented macule, not scaly or atrophic. It has well-defined borders and it is pointed at one end and rounded at the other. Looks like a leaf. So this is an ash leaf macule of tuberous sclerosis. Just when ash leaf macules alone are present, up to 3 may be normal in a child or adult. So obviously we need to look for other features of tuberous sclerosis. So now we'll be moving on to hyperpigmented lesions. So similar to the hypopigmented lesions, what to look for? Are they congenital or acquired? How are they progressing? Was there any preceding lesions? Now, what is the color of the hyperpigmentation? Is it brown, which means it is epidermal, or is it blue, bluish gray, or green, which means it is dermal? And is the skin texture altered? Is there any thickening? Is there any scaling? And what are the distribution of lesions? So this is actually a picture of an adult. So there are well demarcated hyperpigmented macules in the axilla, and the surface is slightly wrinkly. And based on the location and the well demarcated nature and the wrinkly surface, you can make a diagnosis of erythrasma. Of course, here we have the coral red fluorescence seen in Woodsland. Again, we have the hyperpigmented variant of tinea versicolor. Again, in the hyperpigmented variants, we see the same signs that we saw in hypopigmented. Here we can see the evoked scaling, the seborrheic distribution, the well-defined margins which have a scalloped appearance. So this is the next lesion, that is a hyperpigmented macules. Again, no scaling, no atrophy, no surface changes. The borders are well defined and it is uniformly brown in color. So this is a cafe au lait macule. So first thing when we talk about cafe au lait is of course neurofibromatosis. The cafe au lait in NF1 usually have smooth borders, and we know the NIH criteria for NF1 includes 6 or more cafe au lait with size difference before and after puberty. But one thing we have to remember is whenever there is a large cafe au lait with hypertrichosis, it often indicates the presence of a plexiform neurofibroma. So we need to palpate this cafe au lait and look for the bag of worms field. And why is a plexiform neurofibroma important? Of course, it's an additional diagnostic criteria. Even if one is present, it fulfills another NIH criteria. And plexiform neurofibroma are generally present from birth, at which time usually they are very inconspicuous. But as the age advances, they become quite deforming. So it may be important to identify and remove them early. So large cafe au lait with hypertrichosis, think of plexiform neurofibromas. So this is also a cafe au lait, but it has irregular borders and it is stopping at the midline. So such cafe au lait are suggestive of McCune-Albright syndrome. So this is the classical description of the smooth borders in neurofibromatosis coast of California, and the irregular borders resembling the coast of Maine in McCune-Albright. But just to remember, these are not the only syndromes associated with cafe au lait. There are numerous syndromes which can present with cafe au lait macules. So freckling and lentigenes, can these occur in a child? It's unusual to get freckling in a dark skinned child, and it's in any skin type, it's always abnormal below the age of 2 years. So when you see this kind of lesions in photodistributed areas, you can think of two things: either a pigmentary dilution. Now, all pigmentary dilution does not produce white skin, does not produce a total albinism. Sometimes it can be subtle. There may be just a slightly lighter skin in the child compared to the family members. The irises may be lighter in color, the hair may be brown or what we call silvery hair. So these children can present with freckling early, or there may be a genetic disorder associated with photosensitivity like xeroderma pigmentosa. So there are also numerous other syndromes with lentigenes, and these lentigenes need not appear in sun-exposed areas. And again, coming to Blaschko-linear hypopigmented lesions, this is the third stage of incontinentia pigmenti. Initially it blisters, it's followed by a verrucous stage, and the third stage is hyperpigmented stage. And this hyperpigmented stage has a particular pattern called Chinese letter pattern. This is again a picture showing the Chinese letter appearance of Blaschko-linear hyperpigmentation in incontinentia pigmenti. And here often the diagnostic history is the presence of blistering in infancy, which later becomes raised lesions and then hyperpigmented lesions. And this will fade into hypopigmented lesions by adolescence. So it's a Chinese letter pattern. So the other hypopigmented lesions can also be linear, acquired lesions like lichen planus or morphia. And sometimes verrucous epidermal nevi may also be mistaken for a pigmentary disorder because the thickening may be subtle in some cases. So this is now a 10-year-old girl with hyperpigmentation along the neck. The borders are ill-defined. There's a velvety texture, which is obvious even in the photographs, and the skin is thickened. And this child was obese. So our diagnosis, acanthosis nigricans. Acanthosis nigricans can also be present in the axilla, in the groin, and sometimes over the dorsum of fingers, over the knuckles, which is referred to as achial acanthosis nigricans. Juvenile pattern of atopic dermatitis also can present with a complaint of hyperpigmentation. So infantile atopic dermatitis usually presents with hypopigmented lesions, while in juvenile AD, the parents usually complain that the neck of the child looks dark, that cannot be cleaned even after scrubbing, and the cubital fossa, the popliteal fossa, the anterior aspect of ankle are all dark in color, and this is because of lichenification. So here we can see that the skin is thickened, slightly darker, and the skin markings are quite prominent. So this is another cause of hyperpigmentation in a child. Now, this is actually an adult female. She has had these lesions since adolescence. So there is hyperpigmentation, but it's not uniform. It has a speckled appearance. So this is a Becker's nevus. So how to diagnose a Becker's nevus? The first clue is the onset, that is around adolescence. The location, that is usually it is over the breast, the scapular area, or the shoulder. And these lesions tend to darken or become hairy during adolescence because they are androgen responsive. And here one important diagnostic clue that we can see is that this breast is smaller than the other one. So why do we need to identify a Becker's nevus? Because they don't respond very well to treatment. It is important to look for associations. So in this picture, we had a unilateral breast hypoplasia, can get supernumerary nipples, aplasia of pectoralis major, limb reduction abnormality, and scrotal abnormalities. So now if we come to dermal lesions, so now I'll be talking about dermal melanocytosis, that is conditions where the dermis has melanocytes and not just a pigment incontinence. This is of course obvious from the picture. It's a Mongolian spot. The color gives a clue in addition to the location and the onset since infancy. The color is bluish or bluish gray and the borders are ill-defined, suggesting that the pigment is in the dermis. The Mongolian spots are, of course, as most parents themselves will know, they are self-limited and they're innocuous. No management is required. Very rarely, extensive dermal melanocytosis has been associated with mucopolysaccharidosis. This is again similar kind of pigmentation, but started in the adolescence, so in the second decade, and in the trigeminal distribution, the ophthalmic and maxillary division of trigeminal. This is again another form of dermal melanocytosis, that is a nevus of Otta, and the clue comes from the typical location and the color. So the color may be sometimes blue, bluish, gray, or green. The melanocytosis can involve the sclera also, and sometimes the oral mucosa as well. And why is it important to recognize a nevus of Otta? Because it is associated with the risk of open angle glaucoma. The take-home messages from my talk would be hypo and hyperpigmented lesions are very varied. Even when the lesions look very similar, onset and progression are often very useful to differentiate these lesions. Post-inflammatory hypo and hyperpigmentation are common in children. It's always important to take the history for that. And always consider use of topical steroids as a cause of hyperpigmentation. Thank you.
Thank you very much, Dr. Jareen Matthews. That was a very crystal clear presentation, pre-lunch session, and the pictures were also very, very crystal clear. We loved it very much. Thank you.
Thank you.
Over to Hari, sir.
Now we'll be moving
There
on
are
to
no queries. No queries.
No queries. So now we'll be moving on to the discussion part. There are no queries for Dr. Jareen as of now. For the previous talk in newborns, I would like to ask sir to ask the questions for the previous talk.
Rajendra Prasad, sir, please.
Yeah, one or two questions are there. What is the most suitable topical steroid in neonates?
The topical steroids are, am I audible, sir?
Yes,
Yeah, topical steroids are best avoided in a newborn or a neonate, as I've already mentioned, because of the increased permeability of the stratum corneum and increased percutaneous absorption. So more chances of toxicity and side effects. And if at all you require to apply in a very inflammatory condition like erythroderma or conditions like that, when more than 90% involve erythema and scaling and inflammation of skin, maybe you can apply for a very limited period or very shorter duration and a very thin layer or thin application. And we would prefer only the mild potent or the least potent steroid, topical steroid, which are the hydrocortisone or the desanide. But make sure it is used only for a very limited period.
Which topical steroid is most used for tinea versicolor?
Pardon, sir?
Tinea versicolor, which is the
Tinea versicolor
steroid
is a fungal condition. You cannot use a topical steroid for a fungal condition, sir.
That's the question.
Okay.
Okay.
One more question was there, that is regarding emollients usage in newborns.
Okay, sir. So emollients, okay, so moisturizers basically, we can broadly classify them in emollients and humectants. So emollients are more of oil-based products like the mineral oil, vegetable oil, like the most commonly used coconut oil, and even the hydrocarbon products like the petrolatum or petroleum jelly or the liquid paraffin. And humectants are like hygroscopic agents. So they usually absorb water from a humid environment into the skin. But if it is a dry environment, the action will be reversed. Like from the skin, the moisture would be absorbed into the dry environment. So make sure about the environment, and preferably for a very dry condition, we choose an emollient. Like oil-based coconut oil is very good. And again, application, make sure about the environment. If a very humid environment, avoid over application because it can cause occlusion, can occlude the sweat duct pores, and ultimately can result in conditions like miliaria. And also coming to the vegetable oils, other than coconut oil, people have asked me about olive oil, almond oil, and mustard oils. Usually they're not advised for neonates because there is a chance of certain amount of contact dermatitis with these types of vegetable oils. So coconut oils can be used, even petrolatum products like liquid paraffin can be used, and even white petroleum jelly can be used.
Another question.
One more question.
Yes.
Yeah.
Another
What's
question
the topical antifungal in unit?
Pardon, sir?
Topical antifungal in unit.
Topical antifungals, we can choose clotrimazole or miconazole. That's fine.
Thank you, ma'am. Thank you.
Any use of daily emollients in case of newborn patients, newborn babies up to 6 months or 1 year?
Daily use, obviously, sir. If it is like, depending on, again, I said the environmental conditions, we can. If it is a very dry environment and in such cases, we can use a daily.
Routine daily use is recommended or not for newborn skin, for an infant skin?
Yes, sir, that's what I'm saying. If it is like a very dry environment,
उसमें मसाला डालने का रजू
keep the
अरे
skin
मेरे लिए
moist.
चाय बना रहे हैं ना मेरे चाय में मसाला डालने बोल रही हूँ
So, okay, for routine moisturizers can always be tried, but make sure about the climatic variation or the environmental condition. Make sure it does not occlude too much the skin, so that doesn't result in malaria-like condition. Otherwise, you can use it on a daily basis.
Now, one question from my side to Dr. Jareen. What about nutritional dermatosis? As pediatricians, we are worried about the nutritional dermatosis, that is hypo, and they may also present as hypo and hypopigmentation.
Yes, ma'am. I think as far as nutrition is concerned with protein energy malnutrition, we often see hyperpigmented lesion. That is, sometimes the skin becomes wrinkly, it starts peeling off. So it's usually not a pure pigmentary disorder in PEM. There is actually a local keratinocyte loss. And when that peels off, it often leaves behind a hyperpigmentation. So that is in PEM where we can get hyperpigmented lesions with desquamation, particularly over the pressure sites. So where the skin is subjected to pressure frequently, and hyperpigmentation post-inflammatory. Also, we can get a lightening of hair for the typical flag sign that comes with protein energy malnutrition in hair, and generalized hypopigmentation, more generalized rather than localized hypopigmentation can also happen with nutrition deficiencies. And specific nutritional deficiencies, particularly zinc and selenium, can produce a generalized hypopigmentation of skin. And I think sometimes it happens that pityriasis alba is considered to be a nutritional deficiency, but we generally consider it as an eczema rather than and related to dryness of skin and it's linked to atopy rather than nutrition deficiency. So sometimes we see that pituitary salva receives a lot of nutrition supplementation, but then there's no clear link there.
Thank you, Dr. Jarin.
I have one more question. May I ask, Dr. Priya? I have one more question to Dr. Jarin. That is regarding management of linear nerves. Usually we reassure parents that nothing to do in this case. And is there any treatment available for this linear nerves?
So you mean specifically pigmentary mosaicism, or?
Yeah. That
Mosaicism.
hypopigmented lesions, hypopigmented linear lesions.
Yes, sir. If it's a pigmentary mosaicism, then the color we cannot change. So we usually counsel like that. We look for any systemic associations and leave it at that. But then I would generally take a history to rule out that it is not other hypopigmented lesions. But the pigmentary changes are not it's not possible to improve.
Thank you.
With this, we have reached the end of the session of all the discussions. I would like to invite Dr. Harikumar sir, who's the president of the dermatology chapter, for the concluding remarks.
Thank you, Dr. Jijo. That thus we have come to a day-long brainstorming session on pediatric dermatology. Hope you all enjoyed, and we have a very useful and fruitful session for this past few hours. And in fact, during the beginning of our lockdown period, during the beginning of our pandemic, we were so apprehensive about the academic get-togethers, gatherings and all. But in fact, what happened is that we have remodeled to the situation, and we have changed ourselves in to some extent we survived that academical point of view. I am saying that we have attended more sessions. We have attended, there are more academic sessions and CMEs and webinars and all. And if this COVID was not there, if this pandemic was not there, this would have not happened. It is, I mean, paradoxical situation. And to say about the conference as such, so we have a lot of participants from all over the country. At one stage, it was more than 400 participants, and out of that 400, to my surprise, more than 250 people sat down till the end to attend the session. That is quite overwhelming for all of us who organized this conference. So I sincerely appreciate the efforts of Pathanamthitta IAP branch, congratulate and thank them profusely for organizing such a wonderful conference, such a wonderful academic feast for all of us. In the leadership of Dr. Roy Alexander sir, Dr. Arun, Dr. Binukutan, Dr. Jijo, Dr. Roni, and all from Pathanamthitta. So from bottom of my heart, I also thank all our speakers, Dr. Vijay Bhaskar, and I know Dr. Vijay Bhaskar was in a, when we invited him, he was in a very due to this COVID condition, due to this pandemic, he was very busy, and he was in charge of a very big COVID center. And still, he responded to our request. He took up our calls, and he was very cooperative with us. And also Dr. Anandan also, and he had a very lot of other responsibilities, also being the president of their dermatology chapter. Still he cooperated. He was very cooperative with us. And Dr. Renu madam, she is in Brunei now, and she and Dr. Ramesh Kumar is otherwise very busy. You all know. And our other speakers, Dr. Nafina, Dr. Jarin, and Dr. Saumya, who is always with them. I mean, he's a regular speaker in our all dermatology, pediatric dermatology conferences. So I thank all of you, and especially thank all the participants who sat for so long hours in despite their busy schedule, and despite being a Sunday and being a holiday, they all participated. They all these factors, all these things. I mean, these are overwhelming experience for all of us. So I congratulate, I thank you all, especially Dr. Ramesh Kumar. I wish him all the best. And he is from Pathanamthitta. He is contesting for the most coveted post of IAP National President. I expect and I wish him all the best. And I request all the support for his victory as the president of our organization, our prestigious organization, and I thank all the participants and organizers. Thank you so much. Over to Jijo.
Thank you, sir. Hereby we are ending the session. The live video, if you have missed any of the session, the videos are available on YouTube in the IAP YouTube channel. You can go through it, and I am sure it will be helpful in your daily practice also when you encounter similar cases, to go and revise at all times, because you've learned a lot and these are always volatile. We can always revise them. I hope the very best to all of you, and we are hereby ending the meeting. Thank you all.
So we would like to thank Dr. Hari and Dr. Jijo in return.
Thank you, sir.
Dr. Binikudan and Dr. Naushid.
Naushid, our secretary, our dynamic secretary. Naushid.
Dr. Roy and Dr. Arun.
Okay, sir.
Dr. Jaren, very glad to see you. Your presentation was really good.
So nice
Naveen
to
also.
be
Naveen
here.
also. Okay.
Nice presentation, Nafina and
Thank you,
Dr.
sir.
Jarin.
Yeah, Navina
It was
also very
nice.
good. Very good.
Enjoyed it actually. This is
Thank you
one
so
of
much.
the webinar I was stayed till the last, to be very frank.
Thank you so much, sir.
Thank you,
Been with
sir,
us from
Hari
the
sir,
beginning,
thank you, sir, Balchandran sir, Gio.
Thank you, sir.
And there are so many people, no? I mean, I can't take each and individual. So thank you one and all, and take care and stay safe. Thank you.
Thank you, sir.
Best
Thank
of
you so
luck.
much.
Thank you.
All the best. Take care, sir. Thank you.
Thank you all.
Thank you all.
Thank you all.